to the moderator, Mr. Feng Zijian. Distinguished Vice Minister, National Health Commission of People's Republic of China, President of China Preventive Medicine Li Bing and Sun Yang, Deputy Director, National Disease Control and Prevention Administration, and Zhou Chengxiang from Hainan. Ladies and gentlemen, good morning. So, the World Influenza Conference co-hosted by DPMA, APACI, and China CDC is now being held successfully in Boao, Hainan. On behalf of the organizer, I'd like to extend my sincere welcome and gratitude to all the experts and scholars, also entrepreneurs and friends from the media. Thank you very much and welcome all of you. Due to the pandemic, the 2020 and 2022 World Influenza Conference were held online, so today we finally meet offline to seek the new era's global influenza prevention strategy. This is very important. First, I'd like to introduce the important guests. They are the Vice Minister of National Health Commission of People's Republic of China, President of Chinese Preventive Medicine Association, Mr. Li Bing, Deputy Director of National Disease Control and Prevention Administration, Mr. Sun Yang, Mr. Yang Feng from the National Disease Control and Prevention Administration, Mr. Zheng Zhongwei from the National Health Commission of People's Republic of China, and Hainan, Mr. Zhou Changqiang, Mr. Zheng Zhaochang, Hainan CDC, Vice Director Li Qun from China CDC, Academician Chen Huanan from CAS, President of APACI and Beijing Union Hospital, Mr. Shu Hualong, Global Prevention GPMB Secretariat, Madam Sylvia Brand, Mr. Zhang Zhan from APACI, the Vice Director of CPMA and Beijing Union Hospital, Mr. Yang Weizhong, Vice Director of CPMA, Hainan University Disease Control Research Center, Mr. Liang Xiaofeng. Also, we have the Associations of Preventive Medicine of different conferences leaders and hospitals. So welcome all of you, and thank you very much. So World Influenza Conference started in 2018 to retrospect the hundreds of years of influenza to better prevent the disease and seek global solution. It provided a very good platform for the exchanges among the scholars and experts in this sector. So it has been 6 years. With multiple support, it has become a very important brand academic conference in influenza prevention and control. Here, I'd like to thank Mr. Tan Zhaolin from APACI and all the experts for your support and contribution to all the rounds of World Influenza Conference. Also, I'd like to thank APACI, International Influenza and other respiratory association, and United States ADA's Influenza Immunology Summit and European Influenza Science Work Tasks, and all the other international partners support. This conference centered around influenza and COVID vaccines and influenza and COVID infections, clinical features and treatment, and global pandemics prevention and preparedness. Influenza and COVID knowledge and risk communication, influenza and other respiratory diseases, pathogen surveillance and testing. I hope there will be new ideas and thinking and in the conference, improving our understanding of both influenza and other respiratory infectious diseases, and effectively prevent these health risks, and promote the global influenza experts, academic communications and cooperation to contribute to the community of common destiny for all mankind. First, let's give the floor to the Vice Minister of National Health Commission of People's Republic of China, President of China Preventive Medicine Association, Lisa Li Bing, to deliver the opening speech. Welcome. Distinguished experts, guests, ladies and gentlemen, good morning. Today, influenza prevention control experts, virologists, clinicians, public health policymakers, and uh, influenza prevention control backbone experts from China and abroad gathered here to attend 2024 World Influenza Conference. We join hands to seek the global influenza prevention control strategies. We have received the support and care of international colleagues and also the support from different sectors of the society. Here on behalf of the National Health Commission and China Preventive Medicine Association, to extend my sincere welcome and gratitude to all the experts coming from afar and all our old and new friends. And also, I'd like to thank all the institutions preparing for this conference. Thank you very much. Since the outbreak of Spain flu in 1918, there have been 4 rounds of pandemics of influenza, causing the infections of hundreds of millions of people and deaths of hundreds of thousands of people. It shows the damage and unpredictability of influenza. Each time of influenza pandemic is a new challenge for all human beings. So if the influenza pandemic reemerges, the speed of transmission and the public health damage and the impact on social economic will be hard to imagine. So we can only actively prevent and control the risks brought by influenza and continue to improve our preparedness capacity. Can we effectively respond to the possible influenza epidemic? Currently, we can see that global public health challenges are becoming more and more serious, especially after COVID-19 pandemic. We should be more aware that without public safety, there would be no national security and global security, and there would be no sustainable development of social economy and the society. Faced with these huge risks and crises, there will be no country can be left alone. So we should cooperate with each other. This conference focus on from influenza to the comprehensive prevention and control of respiratory infectious disease, with the aim to step up the global influenza and respiratory infectious disease academic exchanges and cooperation to further improve the global influenza prevention control preparedness capacity. Chinese government attach great importance to the prevention and control of influenza and respiratory infectious diseases and the preparedness towards pandemics. Take the influenza as a key risk for people's health. China's influenza prevention control has shifted from the singular to a comprehensive prevention control measures. We adopted strengthening monitoring and surveillance, immunize key populations, promote multi-disease prevention control, standardize epidemics response, and achieve publicity. So in this way, we improve the prevention control of pandemics and reduce the whole chain control costs. Our influenza surveillance system has become the widest covering and most effective infectious disease active surveillance system. It covers 1,292 hospitals and more than 410 network labs. So we can know the activity of influenza in real time and understand the changes of the virus. And we can spot the outbreak of influenza and the novel influenza virus in time and provide scientific evidence and basis for the global influenza vaccine development and antivirus drugs. So this system plays a very important role. We timely spotted the global influenza outbreak in March 2023 and ascertained the influenza H1N1 subtypes and prepared the medical resources. This system also allows us to timely spot the first H10N3 influenza A, H3N8, and other cases, provided epidemic risk evaluation and early treatment with technology guarantee. So within a very short time, we set COVID-19 surveillance and variant surveillance. So it also plays a very important role in the stable transformation of COVID-19 prevention and control. Besides, China also actively participated in the global influenza prevention control activity. We report the epidemics timely and share the variants and support developing countries' influenza prevention control capacity building. So influenza prevention and control is the global public health issue. We contribute to China's wisdom and capacity. Currently, we are faced with global climate change and urbanization. Boundaries are more condensed, and cross-border trade is more convenient. These are all driving forces for the activity of influenza. Further increase outbreaks of influenza. Although we may not know when will the next outbreak of influenza be, but we will need to step up our efforts to reduce the risks and damages it would cause. Thus, different governments and social sectors need to join hands and work together, and we need more advanced, more accessible, and more affordable prevention control technologies, vaccines, and medicines. And we should shorten the preparedness time of influenza prevention control. There's an old Chinese saying that we should go, if we want to go further, we should go together. We host this World Influenza Conference and aiming to build a high-end academic platform on which we can share and exchange the most advanced technologies and be more prepared towards the epidemic of influenza, step up national and regional influenza preparedness capacity, and improve the general public and professional institutions' understanding towards the threat of influenza, and contribute to the building of community of common destiny for mankind. Finally, I'd like to wish the 2024 World Influenza Conference a complete success and wish you all a happy stay and good health here in Hainan. Thank you very much. Thank you, Mr. Li Bing. The National Disease Control and Prevention Administration also pays great attention to this conference. Now let's give the floor to the Deputy Director Sun Yang of National Disease Control and Prevention Administration to deliver his speech. Welcome. Vice Director Li Bing, President, ladies and gentlemen, dear guests, good morning. First, I'd like to thank the organizer for inviting me so that I can have the opportunity to exchange with all the infectious disease experts here on behalf of the National Disease Control Administration. I'd like to congratulate on the opening of the conference, and I'd like to thank all the experts. We know that there is no bystander in front of the pandemic. So the National Disease Prevention Control Administration attaches great importance to the influenza and other respiratory infectious disease. Our principle is people first, life first, and our work approaches is the leadership of the party and carry out joint prevention control and scientific prevention and control. Now, the infectious disease internet direct reporting system has covered 83,000 medical institutions and 28,000 fever clinics, and more than 410 labs covering all the cities in China. And now we have 216 comprehensive hospitals carried out more than 15 kinds of pathogens, multi-pathogen surveillance, comprehensive respiratory infectious disease surveillance. In 2023, our hospital spotted more than 17 million influenza pathogen samples, and the labs tested more than 1 million samples, and we sequenced 110,000 virus. Since 2024, we reported to WHO 12 cases of avian influenza human infected cases. And this year, we shared with the global influenza labs 2,800 variants. 11 of them have been selected for the candidate for global vaccine research and development, making huge contributions to the global vaccine development. Next, we will innovate our hospital prevention coordination system, because hospital is the front line of disease prevention control. We will deepen our hospital prevention control integration and improve our infectious disease internet direct reporting system. In the current e-system, we will install software to guide medical workers to more timely and accurately report epidemic information. Secondly, we will build multi-channel surveillance system and promote the same health awareness. Step up the whole process risk monitoring from human to environment to animals. In 122 municipality cities, we have urban sewage water surveillance spot 455. In the dynamic switch waters, we can supervise COVID-19 virus. In last year, we got 90,000 samples, and we will improve the pathogen recognizing capacity, expanding our switch water monitoring, and adding more disease switch water surveillance. Thirdly, we will step up the cooperation with WHO, implement the newly revised international health approaches, and carry out international exchanges and so with the rapid development of the reform and development of our disease control system, we will improve the legal system and talent building and science, improve our surveillance and early warning capacity, and contribute our
I have to thank you all for your presence. Thank you so much for your attention. All right. Thank you so much, Director General Sun Yang. For APEC has been committed to collaborating with CPMA, and also they are amongst one of the co-organizers for the previous sessions. We shall give the floor to the President APEC, Shui Lun, to address us. Welcome.
And friends, welcome to the World Influenza Conference 2024. It's an honor and privilege to stand before you today as we gather here in the beautiful city Boao to discuss and advance our understanding of influenza and other respiratory infection disease. First and foremost, I would like to extend my heartfelt thanks to the organizers of this prestigious event, the Asian Pacific Alliance for the Control of Influenza, the Chinese Preventive Medicine Association, China CDC, and the Chinese Academy of Medical Sciences. Your dedication and hard work have made this conference possible, and for that, we are deeply grateful. We would also like to express our sincere appreciation to our sponsors, the International Society for Influenza and the other respiratory virus disease, the European Scientific Working Group on Influenza, the National Adult and Influenza Immunization Summit, and the Middle East and North African Influenza Stakeholders Network. Your generous support has been instrumental in bringing us all together. As we gather here today, we are reminded of the critical importance of our work. Influenza, along with other respiratory infection disease, continues to pose a significant threat to global public health. In the past 2 decades, we have experienced the 2009 pandemic and the 2019 COVID-19. We have also witnessed the continuous cross-species transmission of different avian influenza viruses, leading to human infections and deaths. Since, for example, H5N1 since 1997, and also the H5N1 recently infected horses and people in the United States, all indicating that the next pandemic of infection disease is inevitable. Of course, in the past 2 decades, great progresses have also been made for infection disease control and prevention. New technologies represented by, for example, artificial intelligence have continuously accelerated the research and developed speed of vaccines, drugs, and therapeutic agents. However, we are also facing many challenges. We need a more resilient infection disease surveillance system, need timely data and information sharing, need equitable access to antiviral drugs, vaccines, and diagnostic reagents. All these challenges need to be solved for humanity to unite and fight against infection disease, the common enemy of human. Thus, the difficulties and challenges have highlighted the urgency of our mission and the need for continued collaboration and innovation. This conference serves as a unique platform for sharing groundbreaking research, discussing innovative strategies, and fostering collaboration among experts from all around the world. Our comprehensive program covers the epidemiology, detection, prevention, and treatment of influenza, SARS-CoV-2, and other respiratory diseases. It is through these discussions and exchanges that we can continue to advance our knowledge and to improve our response for future pandemics. We are fortunate to have opportunity for both in-person and virtual participations this year. Ensure that our conference is inclusive and far-reaching, and encourage all of you to take all advantages of the session, panels, and the network opportunities available. As we embark on these few days of learning and collaboration communication, I'm confident that we will make significant progress in our shared mission. Together, we can achieve breakthroughs that will protect and save lives around the world. Thank you once again for your presence, your contributions, and the health. I'm looking forward to a successful and inspiring conference. Thank you.
China CDC has also been collaborating with the CPMA on many different occasions. We shall give the floor to the Deputy Director General Li Qing from China CDC to address us. Welcome. Distinguished Li Bing, Li Ji, Sun Yang, Vice Chair Wen Zijian, Zhou Changyang, DDG, dear distinguished guests, ladies and gentlemen, good morning. I'm very happy to be present over the 2024 World Influenza Conference. Note that for the conference, it is now being convened in Guangzhou, China. We have the galleries of the experts committed to the influenza respiratory diseases. It has been very conducive for us to enhance the prevention control for the influenza and many other respiratory viruses and infectious diseases. This will be very conducive to offer the opinions to us to learn from the persons of Li Bing and DDG Sun Yang to guide our work. I believe that the conference will become a very important platform, and it's going to be the fruitful event. Due to that, as one of the organizers hereby representing our China CDC, I congratulate upon the grand opening of this conference, and I'd like to thank all the delegates and thank you so much for your presence, and also by grasping this chance, I'd like to thank all the friends and stakeholders who have given us great support endorsed our work, like the partnership and essential organizations and experts from different countries and regions. I would like to thank the organizers of this conference. Thank you so much for your hard work, so that we have guaranteed its smooth ongoing of the conference. We know that influenza has become the important respiratory tract disease that will boil down to the seasonal epidemic and even the global pandemic. This has posed a great threat to the human beings, and dated back to 1957 under the leadership of the task work of the viruses. Chinese Academy of Medical Sciences, we have established the China Influenza Center, and after that, we have established the China CDC after years of efforts. In 2010, we have become the global research and reference collaborative center for influenza globally. It's been the fifth globally and also the first amongst the developing nations to have the collaboration with WHO for the influenza collaborative work. And we are actually committed to the capacity building to be better prepared and responsive to the influenza epidemic globally. We know that due to the greater variability and hard to predict the development of influenza viruses, how can we actually enhance our capacity building for the preparedness and response better to the pharmacovigilance and the monitoring of influenza? It's very important. By doing so, we can actually have the scientific rationale for us to monitor the variants of influenza by the resistance of drug. It can be very conducive for the medical medication, and also we can also conduct different studies to provide more data to inform the decision making related to the disease pattern studies. It's fair to say that after SARS in 2023, influenza monitoring network is amongst our most successful work we have harvested in the public health monitoring, with the ever improved capacity building for the influenza monitoring and vigilance. They has become more prepared and responsiveness for the whole country to cope with the emerging epidemics. And of course, by resorting to the well-established technological platform and telemeeting, this has also become more responsive and prepared to those emerging infectious diseases. We also have established a lot of new central and checkpoint monitoring to better respond to the infectious diseases. Looking back, we have harvested a lot in the prevention control of influenza. However, we should be aware that for the prevention control of influenza have been embedded with different challenges. For example, we have the greater variability and the recombination of different viruses, and also zoonotic epidemics between men and the animals. For the influenza, it is also subject to change. In the future, we should actually first the collaboration with the international counterparts in the prevention and control of influenza and many other respiratory viruses, dealing with scholars. This task is a very important task. Let's work hand in hand. By resorting to this conference, we can deepen our discussions and communications. We can have more pragmatic collaborations so that we can actually enhance capacity building in the global prevention control of influenza. Let's act together to establish this commonality for human beings and make real contributions. I wish this conference a success. Thank you. Thank you so much, the VDDG Li Qing. It's not possible without the great support from the Hainan Health Commission, as well as the Hainan Administration of Disease Control and Prevention. So we should now give the floor to DDG Zhou Shangqiang from Hainan to address us. Welcome. Distinguished Li Bing, DG Shenyang, experts, delegates, good morning. In July in Hainan, we have very busy, breezy autumn. While we are actually seated on the seashore, I'm very happy that we can actually go gather together in the beautiful world to be present over 2024 World Influenza Conference in the first place, entrusted by the Hainan Provincial People's Government, Vice Governor Xue Jing. I'd like to congratulate upon the grand opening of this conference, and I'd like to extend our warmest welcome to all the delegates, and also gratitude should be extended to the National Health Commission, China CDC, CPMA, Chinese Medical Sciences Academy, and many other organizers, as well as the experts from both home and abroad. Thank you so much for great support endorsed to our work. Thank you so much for that. In Hainan, to establish the free trade zone with Chinese characteristics, it's the important task entrusted by the central government. I mean, at the going global strategy, and we would like to extend our window to be further opened up during the past 6 years. Hainan has been committed to the high-level development to serve the Chinese strategy development, so that we can actually guide the high-quality development in Hainan. We will actually focus our work in the free trade zone, as well as the cash flow and foreign direct investment and the safety of transport and migration of data. And we have established a framework for that, and it has become one of the pillars to actually catalyst the development for the high quality development in Hainan. In the healthcare industry, away from here, by about 15 minutes drive, we have the Lecheng International Tourism Zone, where we also have the special licensure policy for those unapproved innovative drugs and medical devices in China. So let's become such a pilot project in China, for example, in Lecheng, for those unapproved medical devices and drugs in China, but they have been approved in overseas countries. 407 varieties have been covered in that special licensure policy. Will be committed to translating the new policies related to the healthcare development into practice, so that we will actually have our work oriented towards the 14th five-year plan, so that we can actually be more down to earth, and we can actually have a better connection to the data, while the data transportation will be safeguarded. And from the supply side, as well as from demand side, we will enlarge our vision so that hopefully the environment can be well treated in the countryside level, and the key cases or difficult cases were also going to be well addressed within the island. And this has become a reality. And also we have been done to us. We have empowered more resources and allocated more resources to the grassroots level. And we have explored the life cycle management model to the chronic diseases so that we can actually better serve the population. And also have established the 1+5+N prevention and control system for the diseases, especially the infectious diseases. We also have established the responsiveness and preparedness platform to better cope with the emergence of infectious diseases and the outbreak. After years of efforts in 2023, for the life expectancy has reached about 80. For the mortality for the pregnant is about 8.8 per 100,000. For the mortality for the neonates is only about 3.55 per meal. So somehow the prevention control of influenza and many other respiratory diseases, it's hard work, and it's also a sacred mission. We have the gathering of aspects from both home and abroad to be present at the World Influenza Conference. We'd like to facilitate international communication exchanges so that it should be more conducive for our integrated prevention and control work for influenza and respiratory infectious diseases. And this will also become a pillar to upgrade our work in Hainan. It will also going to be a catalyst to driving forward the high quality development in the healthcare industry in Hainan. By grasping this chance, we would like to serve better the national strategy. Hopefully, we can actually first our capacity building for the public health delivery in a holistic way. And also during your stay, please visit our city more so that you can give us more guidances. I would like to quote a very famous song. Luckily, we haven't seen each other a long time no see, but after that, we want to meet more in the future. Hopefully, by resorting to this chance, we can reach new consensus, we can make friends, and we can make contributions to the development of the prevention and control of influenza globally. I wish this conference emphasizes, I wish you good health and blessings to you all. Have a nice day here. Thank you. Thank you so much, DG Chang. Well, 2024 World Influenza Conference will have been greatly endorsed by the different specialties under the umbrella of the Chinese Preventive Medicine Association, as well as many other stakeholders. Thank you for your great endorsement, like PMCH, as well as many other enterprises. Hereby, I'd like to thank all the different associations, organizers, co-organizers, and the entrepreneurs, and as well as many different enterprises and corporations. The convening of the opening ceremony for this conference, it has been adjourned. We're going to take 5-minute break, and then we're going to have the keynote presentation session. The first session, we're going to give the floor to the chair of APSI, as well as Professor Yang Weizhong, who is actually the vice chair of CPMA, to co-moderate the preliminary session. Let's gonna have a 5-minute break, and then after that, we're gonna resume the session for the plenary addresses.
请各位领导、专家落座，大会即将开始。
Distinguished guests, we will be starting shortly.
OK。各位代表。
So the academic report is now beginning. I'm very honored to moderate the academic report session together with Mr. Tan. Mr. Tan is also the director from APACI. We are very honored to moderate this session. The first report will be given by the China CDC Mr. Li, Researcher Li Qun, is Deputy Director General of China Center for Disease Control and Prevention. He will talk about the important factors to be considered for influenza and other respiratory infectious disease surveillance and control in China. Welcome. Thank you, moderator. I'm very honored to have this opportunity to share with you about the influenza and respiratory infectious disease surveillance and control, and very honored to be the first speaker today. So, and just like a warm-up. So according to the arrangement of the conference, I would like to talk about important factors to be considered for influenza and other respiratory infectious diseases surveillance and control, and just some of my personal feelings. And all of your comments are welcome. I'd like to talk about 3 sectors. First, the current characteristics of the disease. So, secondly, the influenza and other respiratory infectious disease, certainly some of our considerations. So let's return to infectious diseases. There are a lot, but what we pay attention to are very narrow parts, like some virus, bacteria, and other pathogens. But some unfamiliar pathogens may give us very heavy health burdens. Second feature is that it may go very fast and can influence a very wide area, for example, COVID-19. Although previously we have some theoretical knowledge about COVID-19, but COVID-19 is the first time we can feel it in such a short term. So, and also, if it can enter a periodical transmission plus other transmission factors, especially the overlapping with other diseases, may cause a huge burden on our medical institutions. Thirdly, the clinical manifestations are diverse and disease burden is severe. So according to the WHO statistics, the respiratory infectious disease is the 4th largest killers, especially for the children. So in China, we still mainly rely on the legal report infectious diseases. We can look at the right, it's the different infectious diseases. The blue is intestine infectious disease, red is respiratory disease, and the orange one is the blood transmitted infectious diseases. So we can see that it may be a little different from the type A and type B infectious diseases. So all type infectious diseases fluctuated a lot. There are like influenza, the diarrhea, and some respiratory infectious diseases. And we can see in general the intestinal infectious diseases is now being replaced by respiratory infectious diseases, especially within the short term. The respiratory infectious diseases can increase sharply within the short term compared with that of intestinal infectious diseases. And also for some vaccine targeted immunized infectious diseases, they declined somewhat, but recently they rebounded. And currently, for some key infectious diseases, for example, COVID-19, now we are still paying to that. Currently, it's rather stable. So maybe in the first half of this year, we don't have a lot of experience of COVID-19. Now the main variants is KP2 and KP3. We still need to keep monitoring the rebound or fluctuation of COVID-19. So we need to focus on COVID-19, although we have already experienced the peaks, but now there are still some variants. And secondly, from different countries or from China's domestic perspective, the changes of the epidemic has features in different areas. It is connected with variants and with vaccine types. And also in China, we have a large population. Once there are serious diseases or mortalities, we still need to pay special attention to that. And secondly, let's look at influenza. Last year in autumn and winter, after around a peak, this time last year was a peak of influenza, and now it remains at a low level, but it differs in southern China and northern China. Currently, the positive rate in southern China's hospitals have a rather high positive rate. In northern China, the positive rate has been reduced to 1.3%. So we need to pay special attention to the rebound of the influenza in southern China. And this slide shows other respiratory infectious diseases. In last autumn and winter, this round of multi disease overlapping. After that, we have entered a rather low level, but it's different in different regions. We can see it has 4 kinds of diseases. The first one shows a mycoplasma pneumonia. We can see currently, compared with last winter, it's a very low level. But for 5 to 10 years old, blue line in the second picture, they are still at a rather high level. And let's look at the right part, adenovirus. In recent times, they are still fluctuating and increasing, especially from 0 to 10 years old children. And in the left lower part is RSV. In recent times, it declined. And the fourth one is the enterovirus. We can see it's increasing very obviously. So we can go to this trend because we carried out the multi-disease, respiratory multi-disease surveillance since last year, and now we are implementing this multi-disease surveillance system around the country, so we can get some baseline data and see the changes. And from surveillance, we have different approaches, like the low stability infectious disease report. And also we have some other infectious disease report like chickenpox, and we have some emergent public health report, and we have some sentinel report system. Influenza, we are very familiar with it, and the previous latest shows that influenza is the very representative case. Now we have a very successful surveillance system. So we carry out the surveillance according to demands, and we have different contents. For example, we have low-bound infectious disease report, and we have sentinel report and surveillance, and we are also the global influenza SARI surveillance, and also through the pneumonia without clear reasons and mortality surveillance, we can also carry out surveillance for influenza, and now we are also carrying out the environment-related surveillance for avian flu. Also, we have the vaccine efficacy surveillance, so we have a rather complete surveillance system for influenza. And then after COVID-19, we can see the surveillance system has changed a lot, especially we built 10 surveillance system, including case report, also reports from the fever clinics, also the community surveillance, and also the sweet water surveillance, as well as the media surveillance. So it's a rather complete surveillance system to help us provide support for the epidemic prediction. So currently we are faced with a very serious situation, or quite challenging situation. First, the whole society are paying attention to that. Secondly, in respiratory infectious diseases, our pediatric and the elderly population, they are exposed to high risks. Each epidemics give them very large disease burden. And then we can see we have very diverse pathogens, and the clinical manifestations very complicated. And thirdly, we need to see, although we are improving our surveillance capacity and system, currently the surveillance data are not perfect. There are some blank areas. And fourthly, our vaccine. Certain kind of disease, after vaccination, they cannot have a lifelong immunity or very long-lasting immunity. So this will pose a very great challenge in public communication. And then it's about the drugs and medicines. For some virus, we don't have very specific drugs. And also the bacteria-caused diseases have some drug-resistant issues. And then from the perspective of infectious diseases, at the national level, we need to first be based on risks and disease burden to develop our different kinds of respiratory infectious disease prevention control strategies. After we have the basic strategy, we need to know what is our priority and what is our action plan. In this way, we can continuously carry out our work. From different perspective, we can divide it into different types. First, we need to eliminate like measles, and secondly, effective control like the pertussis, and also the epidemics cerebral meningitis, and also the third type is to reduce the disease burden like influenza and COVID-19, and the fourth type is to reduce the transmission from animal to humans like the human-infected animal-sourced influenza. So only when we have such clear objectives, we can match it with our resources. And though this is the global influenza strategy published by the WHO, we can read this. It lists different kind of scenarios and objectives. For example, how to reduce the disease burden and reduce the risk of the animal-sourced influenza, and how to reduce the impact of the influenza epidemic. And another topic is how to improve our surveillance system. Currently, I introduce different surveillance systems. Apart from the influenza surveillance system, we need to improve other surveillance systems like the respiratory multi-disease, multi-infectious diseases surveillance. In this way, we can spot the changes of some disease at early times. And secondly, we need to step up the surveillance of pneumonia without clear reasons and mortalities caused by that. Through the improving of our informationalization level, we can more timely find the pneumonia and mortality caused by unknown reasons. In this way, we can improve the sensitivity and timeliness of our surveillance. And in this next, we will ask different medical institutions to carry out diagnosis of this pneumonia. And also, we are expanding our surveillance system. Now we are expanding our sewage water surveillance to medical institutions and the agricultural products markets. And also, we need to improve our medical treatment capacity. Currently, we are faced with a lot of challenges. For example, the drug resistance bacteria. In this sector, we need the cooperation between public health institutions and medical institutions to carry out the surveillance. And also, we need to improve the grassroots level medical treatment level. And also, we need to build a hierarchical mechanism to improve the key infectious disease treatment capacity and reduce its serious disease rate and mortality rate, and coordinate the medical staffs on emergencies. And also the public health intervention level, currently for the drug and non-drug interventions. Here, under the drugs, vaccine is the most effective approach. We need to continuously improve and maintain the target population coverage rate, and also improve the vaccination immunity strategy, readjust and optimize the immunization strategy, and also promote vaccination, improve its accessibility and coverage, and also for some basic and application research like the disease burden, infections results, and the diagnostic agents. And this way, we can have a better and more scientific understanding towards different diseases. And for respiratory diseases, the same health notion is very important, especially for the animal source diseases. We need the multi-departments cooperation to carry out good prevention control of the animal source influenza, and also step up the preparedness for the epidemics, especially for the general public. We should improve their understanding towards respiratory infectious disease. And recently, there are a lot of hot topics. Most importantly, we should have sound technology preparedness, especially some drugs and medicines like vaccines, diagnostic tools, and treatment methods. We need to add more investment in the research and development. These are all in progress. And today we have Director Dan here. Later he will make a speech about that. So that's all for my report. Thank you very much. Thank you, Dr. Li Jun, for your wonderful speech. He comprehensively introduced China's respiratory infectious diseases and the general infectious disease prevention and control. Especially, he mentioned we need to comprehensively implement the multi-disease source surveillance. So in this way, the same network can carry out surveillance for multiple diseases, and one sample can detect different sources of disease. I think in the future, the whole country should replicate this model, and also talking about a lot of other sectors like the preparedness for the epidemic of influenza. So now let's give the floor to John Tan to moderate the next session.
Dr. Sylvie Briand is currently the executive head of the Global Preparedness Monitoring Board, which is co-convened by the World Health Organization and the World Bank. And Dr. Briand's presentation is on global pandemic policy development, the WHO R&D blueprint on pandemic readiness and IHR amendments, and pandemic accord. It's a very long title. I'm sure Sylvie will be able to present, let us know what's going on.
Yeah. So thank you very much to the organizer for inviting me. Good morning, everybody. I'm very pleased to be here today with you to talk about global pandemic policy development. So here on this slide, you see a timeline of the major epidemics and pandemics of this century. Started in 2003 with SARS and the emergence or re-emergence of H5N1, and then we had the H1N1 pandemic in 2009, MERS emergence in 2012, then we had also Ebola in West Africa 2014-15, and of course more recently COVID-19 and Mpox also spreading around the world. And we had also major epidemics such as Zika, yellow fever, cholera, and plague elsewhere. So just to say that the world is at risk of major pandemics, but every time we had a big crisis, member states of WHO did develop global agreements. So we had the International Health Regulation and soon, hopefully, the Pandemic Treaty. So you see at the bottom of these slides every time that all these agreements that were developed. And I will go through them one by one. So, of course, in 2003, major event was SARS and also the re-emergence of influenza A, H5N1. And at that time, we didn't have an updated international health regulation. We were still working with the previous international health regulation, which was updated in 1969. And these regulations were only calling member states to notify mandatory diseases. And at that time, it was cholera, plague, and yellow fever. So SARS and H5N1 were not notified to WHO. Of course, we knew they were existing, but there was no legal agreement to make this notifiable. So in 2005, the international health regulations were updated, and there were major changes in these regulations. The first is that it was emphasizing early control of the disease, and which not limited to a list of mandatory diseases, but any kind of threats should be notified to WHO within 24 hours. The second major change is that the scope of the international health regulation were also including not only any biological threats, but also chemical and radionuclear events. Then also the response was based on the risk assessment and not necessarily on the type of disease. And finally, countries were also asked to build national capacities, national core capacities, and this is what has been done since then. And we have seen a lot of progress in the world in the capacity to early detect disease, but also to set up an early response to emerging threats. So far, since the adoption of the revised international health regulation, the instrument has been used 7 times, including COVID, of course, but also the first time we used it was for the H1N1 pandemic in 2009. So the instrument was not really perfect at the beginning, but it has improved over time, and it's being revised after each crisis. So in 2009, we had the influenza H1N1 pandemic, and here the main issue was really the equitable sharing of influenza vaccines. Most of the developing countries received the vaccine 1 year after the start of the pandemic. So after this event, many countries met and tried to improve the preparedness of the world towards influenza pandemics, and this is when the PIP framework was adopted. PIP means Pandemic Influenza Preparedness Framework. And the PIP framework aims at increasing, of course, the surveillance of influenza viruses by sharing biological material within the GISRES network, but puts also on equal footing the sharing of biological materials and the access to medical countermeasure, vaccine, therapeutics, and diagnostics. And so this was a major advance in the fight against pandemic, acknowledging that the world is one and we need to work together to improve our protection against pandemics and epidemics. In 2014, we had the major outbreak of Ebola in West Africa with more than 20,000 cases and 10,000 deaths. And it spread to 3 countries in West Africa, but also 6 other countries had imported cases. So at that time, most of the countries said, we cannot continue like that, because for Ebola in 2014, we didn't have vaccine, we didn't have treatment, and diagnostic tests were very complicated. So this is when member states decided to develop the WHO Research and Development Blueprint, R&D Blueprint, to accelerate research for those emerging pathogens and develop, of course, treatment, vaccine, and diagnostics. And also bridge the gap in research and infrastructure, making sure that developing countries can also carry out research projects and studies on those emerging pathogens. So within the R&D blueprint, there was also the development of a list of priority diseases, and that includes also disease X. Disease X is a disease we don't know what this disease will be, but the aim is to develop upfront platforms so that we can respond to any kind of threat, any kind of emerging virus. The R&D blueprint is great, but doesn't include influenza. And why? Because influenza was considered at that time as a disease for which there was already a lot of research and didn't need to be put in the R&D blueprint, which was really focusing on disease for which there was no research or no market for the development of medical countermeasures. So for influenza, we have a special tool, and the previous speaker talked about it. We have a global influenza strategy, and there are also a number of manuals that are developed to focus on influenza. And the first research agenda for influenza was developed shortly after the 2009 pandemic, and I have to thank John Tam, who is the father of this first global influenza research agenda. And really the aim is to develop better tools to counter influenza pandemic. And of course, we hope to have a better vaccine with an increased breadth and duration of protection, and enhance effectiveness against severe disease, especially in high-risk groups, and a decreased time for production as well, because currently it takes, at least with egg-based vaccine, around 6 months to develop the vaccine, and we really hope to shorten this duration to 4 and maybe 2 months in the next pandemic. So we have been working since 2009 pandemic a lot in trying to improve the sharing of viruses, but also improve all the techniques that allow us to develop faster the vaccine. So what is important with research during pandemic is that we have seen also a great evolution in the paradigm and the thinking around research. In 2010, really, we wanted to develop research during pandemics, and it was extremely difficult. And since then, many progress have been made, and you have seen this during COVID-19. A lot of funding can be made available quickly during crisis. In 2016, really, the question was how to develop research on pathogens that are very rare. Although when it happens, especially with emerging pathogen, when it happens, the consequences are really high. But still, it was very hard to mobilize the industry, for instance, to produce products for a disease where there is no market. So this is when we developed the R&D blueprint. And in 2020, really, we had changed the paradigm as well, and considering now research as an end-to-end process and a really research ecosystem, and R&D is just the first step of a full process going from R&D production to delivery in supporting equitable response to health crises. Now also we are looking more at families of viruses rather than a specific disease virus. And we are also developing partnerships to work together, because research can advance faster if we are all together. And this is why now we are developing more laboratory networks, but also there are resolutions of WHO resolutions on clinical trials to conduct clinical trials all together, and a lot of global partnerships like the CEPI, the 100-day missions, and so on. So this is just to show now research integrated into a whole process from research and development, manufacturing platforms, and end-to-end health emergency supply chains. And we are working at global level to develop this mega ecosystem for research and development. So in 2020, we had the COVID-19 pandemic. And here again, it was a challenge of equity during pandemics and the equitable sharing of countermeasures. As of October 2023, 70.5% of the world population had received at least one dose of COVID-19 vaccine. But in a number of low-income countries, this proportion dropped down to 35.6%. So you see that it's very hard for low and middle-income countries to access vaccine, therapeutics, and diagnostics. So we need to tackle this inequity because, of course, it puts the world at risk. If some countries cannot vaccinate their population, it means that the virus will continue to circulate in those countries, and maybe more variants will emerge. So it's very important to tackle this. But it's difficult because medical countermeasures are manufactured in a limited amount, a limited number of countries, and a very limited amount, especially at the start of a pandemic. There are very costly medical countermeasures, so not all countries can afford it. And also, it's very difficult for certain countries to import new medical products because they don't have necessarily the regulatory capacities. So based on that, member states decided to amend the international health regulation. And so there was a working group established in 2021 to tackle this update. And so in May 2024, very recently, the new amendments of the International Health Regulation have been approved at the World Health Assembly, and the new amendment includes the following changes. First, there was the introduction of a pandemic emergency, which was not there before. And so this will enable us to trigger more effective international collaboration in response to events that are long-lasting, because pandemic lasts long. This one has had many waves and has lasted at least 3 years. So we need an instrument that allows us to collaborate for a longer time. There is also a commitment to solidarity and equity. There is also an establishment of a state party committee, meaning that member states will be also in a committee revising how the international health regulations are implemented. And there is also a creation of national IHR authorities. Before we had only a national IHR focal point. It was only one person, but now there will be national IHR authorities that will have more power also to make sure that the IHR is better implemented. And last but not least, let's talk about the pandemic agreement. So the aim of this agreement was to strengthen the political dimension of the IHR and tackle the shortcomings highlighting during the COVID-19 pandemic and also previous epidemics. So this process started in November 2021 by the creation of an intergovernmental negotiating body that includes 194 member states of the WHO. It's a member state-led process, and it's a consensus-based process. So there is no voting, and member states have to agree among themselves. So in December 2022, there was a conceptual zero draft of the text, but then a number of working groups have worked on it, and in May 2024, a draft text was presented, but the draft text was not fully finished. Many parts were not adopted by consensus, so member states decided to postpone the decision to May 2025. And so there are some sticky issues in this text, for example, the pathogen access and benefit sharing, which was the issue tackled in the PEP framework, but only for influenza. So now member states are discussing it for other pathogens. And so our Director General was very pleased that the IHR amendments were adopted, and it's a good sign that hopefully the pandemic agreement will also be adopted, because the next pandemic is not a matter of when, but a matter of if. And we all know that if we are not able to work together and collaboratively, the virus will win. So we need to stay together. And so what's next, nobody knows, but really important to maintain the trust, the relationship, and the collective approach to a pandemic to make the world safer. Thank you very much.
Understanding the WHO's negotiation on pandemic handling and also agreement on the international health regulations. The next speaker, Yang Lao Shi, will be introducing the next speaker.
Thank you.
Next speaker shall be Professor Zheng Zhongwei, doctor, who's actually now serving as the Healthcare Scientific and Development Center director there under the umbrella of National Health Commission. He was actually the vice chair of Chinese Medical Sciences Academy, as well as the vice president of Peking Union Medical College. And also during COVID-19, he was actually chairing the R&D task force for vaccines during COVID-19, who was responsible for the COVID-19 vaccine related R&D, as well as the use of the vaccine in China. He was an influential figure in that task force. Professor Chen, he will be talking about the emerging pandemic preparedness for the an emerging pandemic. Please. Thank you, moderator. I would like to thank you so much for the conference, for your invitation. After I have got the invitation from Chair Zijian, I was kind of hesitant. Why is that? Because for me, myself, I was actually a physician, but for this time, I feel privileged being able to be here during the COVID-19 as one of the task force. Actually, I was actually the leader in the task force for the integrated prevention and control for COVID-19 under the leadership of the State Council during COVID-19. So in the future, faced with the disease X, what are the scientific preparedness do we have? After I have been trusted with this subject, I was also reflecting upon the past. Well, looking back at those years, especially during COVID-19, for the prevention control for the pandemics during the past few years, I have engaged into the R&D for the vaccines, for the integrated prevention control for COVID-19 under the leadership of the State Council. I have got some self-reflections. So from the scientific perspective, I'd like to share with you my personal opinions, my heartfelt feelings, and also for now, what are we doing in responding to the potential pandemics? What do we have scientifically? So 2 parts of my presentation. I'd like to give you the introduction. The first is that for the scientific innovation to pillar the prevention control of COVID-19, reflection and looking into the future, as well as the new normals, new requirement for the scientific preparedness and innovation. From here, we can see that in responding to COVID-19 in China, we have had multiple important time points to remind us that our work is well done. For that, we have a benchmark, which is in 2020 SARS. In 2002, we have the SARS. Back to 2002, we can see that after the SARS was identified from the identification to the identification of pathogens, it's about 6 months since the onset. And also the background was very complicated, but for this time, from the very start, to the identification of the pathogens of SARS, we spent about a week. After the full genomic sequencing, 10 days. For the whole genome sequencing, after the development of the testing reagents, 14 days. For the conditional approval of vaccines, we spent 1 year. But for 2 months, we have put the vaccines into clinical use.
So we researched and developed the specific medicines. It only took 2 years, but we only took 1 month to give 3 drugs and 3 prescriptions. So compared with SARS, this time we changed and developed a lot in the process. Science plays a very important role because after SARS, our country organized and deployed a series of key scientific research projects so that we can handle the COVID-19 pandemic more calmly. So we can see since 2005, we carried out specific and thorough analysis towards SARS, especially for the problems. We treated them seriously. And since the 11th five-year plan, which started in 2005, our country deployed a series of key projects centered around life and health. One of them is the key infectious disease prevention control key project. We can see in the project we experienced 11th, 12th, and 13th five-year plans centered around AIDS, tuberculosis, and hepatitis. we carried out a series of work to reduce the infectious rate of the three diseases. And also, we kept improving our capacity and carried out the prevention control, both in Western and traditional Chinese medicine measures. So we have very good result in the three kinds of infectious disease, and we have made a achievement and progress in spotting new pathogens, spotting the source of infection, and ascertain the disease mechanism and research and development of new vaccines and medicines. And also in the same process, we have the key novel drug innovation key project and the major types and the domestic manufacturing of medicines and the traditional Chinese medicines modernization. We researched and developed a series of type 1 national level type 1 novel drugs and innovation drugs. And we have 24 resource platforms and 10 comprehensive platform, 14 GLP and 93 GCP. Here, just to give you an important example, the Jinpan Hospital in 2019 with approved GCP. So in this pandemic of COVID-19, this hospital has done a lot. So the two specific projects deployment, especially the novel drugs key projects, give us a lot of changes in development. We shifted from generic drugs to original drugs. We are shifting from the big medicine country to a powerful medicine country. Because of this specific project, firstly, we made huge progress in the rapid pathogen identification. In the 3-5-year plan, we built 151 kinds of virus detection methods and virus and bacteria's whole genome testing. This plays a very active role in the COVID-19 pandemic. WHO said that we use a record short time to identify the pathogen. And secondly, based on the key infectious disease prevention control project, we have the diagnostic reagents research and development. This plays a very important role in the COVID-19 and the SARS-CoV-2 virus detection. So in this short time, we can have the universal nucleic acid screening. This is incredible. Thirdly, based on the novel drug specific project, we have the innovative drugs comprehensive platform and the transformation of traditional Chinese medicine and the drugs clinical trial GCP platform. They all played an important role in the screening and development of COVID-19 treatment drugs. So we can still remember that at the start of COVID-19, we already have 3 treatment drugs and 3 prescriptions. And then in the later stages of pandemic, we have a series of innovative drugs. And also based on the infectious diseases specific project, we have the treatment optimization and the elimination of cytokine and the infectious disease and respiratory disease standardized treatment. This platform also played a very important role in the treatment of COVID-19. For example, like the micro-intervening stem cell treatment and the artificial liver treatment. And in vaccine research and development in the past 15 years, based on the specific project, we support the new and novel vaccines key technology development and the high efficiency screening technologies and the phenotypes of biology technologies and the scale up manufacturing of drugs. All of this technology plays an important role in the COVID-19 vaccine research and development. The 5 technology roadmap covers the whole clinical demand. And the 5 kinds of vaccines have been used in urgent times. And our vaccines have been exported to more than 120 countries and international organizations. In total, we provide 2.3 billion vaccines. And also we have based on the project, we have the experiment animal resources. We build a standard lab model platform so that the animal experiment can play a big role in the vaccine and drug research and development. Within 1 month of the pandemic, we have the first COVID-19 animal model. Because of the deployment above, we can have all the results and calmness as I showed in the first chart. We can imagine China has 1.4 billion people. If we don't have such a long-term preparedness, then faced with this COVID-19 pandemic, the results may be much worse. So here I can still recall when I worked in the vaccine task force, we often say we'd rather prepare and not use it instead of we have nothing to use because we didn't prepare. So I think there will always be novel infectious diseases, as the previous two speakers said, and we can remember entering the new century, we already have several rounds of infectious diseases, and the prevention and control is an important part of the community of common destiny for mankind. It has no race, it has no national boundaries. Secondly, it's also important for us in the infectious disease prevention and control. The research of infectious disease prevention and control should play the role of the national system, and we should carry out scientific research orderly, and we should have some front deployment, forward-looking deployment. Our infectious disease key project has been deployed for 15 years so that we can have today's results. And we should continue to carry out efforts, and we should not rush to get early results. As Chinese saying goes, that we should not start to prepare right before the instance, because it will be much more difficult, and the results will be much worse. So centered around today's theme, we need to be prepared for the next round of possible disease X. What should we do? Actually, we started the preparing work quite early. So now I'd like to introduce you currently in the public health sector, centered around the infectious disease, what are the new situation, new measures, and new requirements. As we can see, the 20th Party Congress report lists education, science, and talent at a very high level, and we raise clearly that we should achieve Chinese-style modernization and the rejuvenation of Chinese nation, and we should achieve that through science, education, and talent. Here, it mentioned we should improve the scientific innovation system and stick the key role of innovation in the modernization and speed up the innovation-driven strategy and have 4 phases. The 4 phases actually was raised during the pandemic by President Xi Jinping. That's his requirement for our science work. And previously, there were only 3 phases. Now we have the 4th one, that is, we need to face people's life health and make it clear we should achieve the high-level scientific governance and development. Under the big background, you may notice that we have the new round of scientific system reform, and we established the Central Science and Technology Commission. You may have noticed that the Vice Premier Ding Xuexiang is now the director of Central Science and Technology Commission, so he will personally lead our country's scientific innovation work. So in this background, China's Ministry of Science and Technology was reorganized. Some of its social functions were given to the certain ministries, like the functions related to science and health was transferred to the National Health Commission. And some organizations under the Ministry of Science and Technology were given to other ministries. For example, the Project Management Biology Center was now given to the National Health Mission, and also the High Tech Center and 21st Technology Center was now given to the Natural National Fund Commission, and the Agriculture Center was now given to the Ministry of Agriculture. So this kind of structural reform allow us to pay attention to science development, and also we should drive the science development in a coordinated way. Under this background, the National Health Commission organized the National Health Commission Scientific Innovation Leadership Group and published several measures promoting health, science, and technology development. We call it the 50 articles. So for the scientific innovation works leadership system, and technology system, it have very detailed arrangement. For example, here we have a 1 plus 2 plus 3 plus X. 1 means the National Health Commission. 2 means the CDC Science Division and the Disease Control Administration Bureau. And the second 2 means the Science Development Center and Biologics Center. And the 3 means the Academy of Medical Science and China Academy of Science and the Academy of Preventive Medicine Science. So X means all the hospitals, universities, and national key laboratories, and national clinical center, and national innovation center together. So in this way, we have very complete innovation system. Here there are some changes I'd like to share with you briefly. First, before we form the guideline, we need to have 3 lists. First is the key demands list. Second is key science question center list. The third one is key mission center. After we have the 3 lists, we will have the key mission list. Based on the key mission list, we can have our annual guideline. And also we need to select the best scientific research team and readjust the method. We can have some designated guarantee and different screening method, and also change the way of the experts committee, and improve the chief scientist management operation system, and improve the diversification evaluation system. And also in the transformation of scientific research work, we have some organization and deployment. So faced with the Future Disease Act, we need to prepare. From this picture, we can see faced with COVID-19 in early warning, prediction, pathogen identification, diagnosis, vaccine, population control and prevention, and treatment, we have made huge progress. But faced with the future, what should we do? How should we do better? I think in early warning and prediction, we should make efforts in different points. Our detection and pathogen identification time should be further shortened, and testing time should be shortened, and the vaccine research and development time should also be shortened, and our prevention and control should be more scientific and more targeted. So during the COVID-19 pandemic, we already started some deployment. Actually, in 2011, we already have the pathogen prevention control key project, focus on the key infectious disease mechanism and targeting points, and the source traceability, and key infectious disease clinical prevention control. We all have made some deployment and have started some work. So the next step is centered around the key and novel infectious disease. We also need to have some deployment last week. For the novel and urgent infectious disease, we have some special conferences. The aim is in the future, when we have raised the potential pathogen list, we should reach the international level and achieve the early and intelligent surveillance. And we should have our independent vaccine technologies and have the Chinese solution for the new and novel infectious disease prevention and treatment, and be prepared for the unknown pathogens and diseases. At the same time, for the existing major threatening diseases, we need to continue to make efforts. In mission deployment, it's just 5+1. First, application research and the surveillance of novel infectious disease, population prevention, clinical treatment, prevention, diagnosis, and treatment products, and made good predictions and judgment. So the series arrangement is our country's scientific development plans compositions. Actually, the scientific development plan in the infectious disease sector, we have a series of projects. For example, in national key scientific project, we have novel infectious disease prevention control and key novel drugs innovation. So in the near future, in the 15th five-year plan, we will continue the projects. And also we have the pathogen and disease prevention technology system research and biological security key technology research. And also we have the National Natural Science Fund. So we have a systemic arrangement and coordination among different sectors. But the key is through the national strengths we carried out organized scientific research work. So I like to use two recent conference to conclude my report that we should focus on our strategic target and make efforts to build a strong scientific country. Thank you. So thank you, Dr. Zheng Zhongwei. He introduced our scientific preparedness for the future novel infectious diseases, very comprehensive and very systemic, with a lot of information. He introduced our science management system and some technology preparedness. What impressed me most is his thinking. He talked about our science technology management should be forward-looking and have this forward-looking deployment. Indeed, without our forward-looking deployment in the 12th, 13th, and 14th five-year plan, we should not have been so prepared in face of COVID-19. Another thinking is we should continue to make efforts and should not rush. It's very important in science development. So again, I'd like to thank Director Zheng Zhongwei. The next speaker is Academician Chen Hualan. So she's a academician of CES and also the academician of the Academy of Developing Countries. He served in China Academy of Agricultural Science, Harbin Veteran Research Institution, Avian Influenza Labs Director. So he has been in the avian influenza virus and related basic research for a long time, especially in the avian influenza vaccines research and development. He has rich experience, and the vaccine has been widely applied in China and
So I'd like to speak now. So somehow some of the audiences are Chinese. So today I'm very happy that I can actually stand a chance to share with you our common measurement for the prevention control of the highly pathogenic avian influenza. What are the work harvests and the fruits we have harvested for the prevention control of it? To echo the previous, because we know that for the influenza virus is very complicated, high speed, many different hosts, airborne, land, etc., susceptible, highly susceptible, and for the mutations, easy to have the mutations. Of course, we have different fragments when it comes to the infection on the same cell, somehow there could be some recombinations, and for subtypes, so many H10, infected humans in China, etc. For H, we have 16 in subunits. Also, according to report from bats, we have H17, H18, and also from the wild birds. Somehow, these have been covered on different subtypes. As the vet doctor, my focus will be two subtypes, H51 and H7. They are highly pathogenic for them. Great impact on the birds. Without vaccination, 100% mortality will be expected for the H5 and H7 subtypes for these two viruses for the human health. Also great threat, and as of now, accumulatively speaking, about more than 2,600 globally have been infected by H5 and H7 subtypes. For the mortality, the mean is about 50%. In order to control the pathogens of H5 and G7 subtypes, not only for the animal health, but also it should serve the public health for the human beings too as well. And for now, globally speaking, in EU and US, we have the predominant subtypes. We have H5 here. I have depicted here some data as of 2005. Let's look at the prevalence caused by H5, 3 tides, 3 waves, Asia, Africa, EU, and America. It seems 2020, wave 3, which is also a big tide. From the colors, we can see that in EU and also in North America, in American continent, in terms of the prevalence, we have a very high prevalence. For y-axis represents the impaired poultry and birds, but since 2020, for the epidemics caused by H5. So let's look at the infected poultry is about 300 million. We have a further breakdown. For example, EU, for the mortality is about 100 million, and in North America, also another 100 million for the US alone, about more than 90 million, and also in Japan and South Korea, in Asia, in total also about 100 million. So for wave 3, for the impaired poultry and birds, it has exceeded the sum of the previous 2 waves, and also for the epidemics, now it is being spread, and also it's getting more and more troublesome and challenging since 2020. We can see at the very beginning, it was H5N5, H5N8. We call it H3B4 clade. It was identified in EU and then spread to Africa and Asia between 2020 and 2021 for this virus. We can see that during the seasonal provinces, it has got the overlapped with the low pathogenic viruses with H5N1, H5N2, N3, and 4, just want to name but a few. Among them, for H5 offspring clades, the most important viruses is H5N1. For that, from the illustration, we can see that very complex. For H5N8, it has provided the gene fragment of H1 and M, and others have provided other 6 genomic fragments for that. Back in Holland, it was identified in some wild bird in Holland, and later after its identification in EU, it has got a low prevalence, which is about 1 year later. It has surrogated H5N8, and it has caused the world's epidemic, and also with the bird migration, it has been spread in North America, and also from here, H5N1, later one identified in Holland, which was carried firstly in wild bird as of the end of 2023 on the poultry and birds, cumulatively speaking, about more than 13,000 outbreaks have been identified from the map. We can see that in China, with such a large country, for different sports, very few sports. So some people will ask, why is that? Why China, among the H5 epidemics, among the poultries in China, why so few cases? Different people might have different answers, but I can provide you the right answer as compared to other countries. For China, for the prevention control countermeasurement, we are different in EU and North America in the past. For those countries, including Japan, South Korea, and other Asian countries, they have been thinking that for the highly pathogenic avian influenza, it cannot be preventable by vaccines. So they will actually place those poultry and birds in a biosecurity cabinet if it's not successful once there is an outbreak. So somehow the viruses will kill the poultry in order to control the viruses prevalence, they will kill the others. But in China, dating back to 2004, and ever since then, we have the vaccination plus culling. So somehow, for those susceptible birds and poultry, we would like to have them vaccinated, but still the protection efficacy hasn't been achieved with about more than 175 million birds. So some might be missed. They were not covered by the vaccination. Once they have been infected, whenever there is an outbreak, whenever there is epidemics, we're going to have the cooling undone in order to support that. Like the vaccination plus culling, in order to foster the effectiveness of the implementation, we have the reference lab in place where I'm actually chairing the lab. We're actually among the reference lab for the WHO as well as the International Food and Organization. So somehow we are responsible for different work, like the active monitoring and vigilance, and we would like to know about the evolution of the emergence and the mutation and variants of different viruses. And in order to control the diseases, we have developed serial vaccines. Internationally speaking, they are quite advanced worldwide. The innovative vaccines, like inactivated vaccines, by using the reverse genetics and live vectored vaccines, like the dark plague vectored vaccines. We also have developed the DNA vaccines, or are indicated for the avian influenza. Depending on the monitored information, we're going to upgrade the vaccines as the end of last year. We have about more than about 320 billion doses have been distributed to China and many other countries, so that we have made contributions to the prevention control of avian influenza worldwide. 2 cases for illustration. To walk you through the fruits we have harvested for the prevention control of the avian influenza. One is about the H5. In those developed nations, they were not using vaccines a while back. They were thinking that it's for the mutation of influenza. The mutation is very quick. That was true. Somehow it's a high variability. So somehow for the protection efficacy and protection effectiveness by using vaccination, it will be compromised. Indeed, in order to make this vaccines more successful, the vaccine matters tremendously. We need to adjust the vaccines so that for the vaccines, it will be better matching the antigens contained in the vaccines versus the prevalent subtype. So we need to do a lot of monitoring and surveillance to support that. In China, we have the Disease and Control Center for animals, which is like the China CDC for humans. But for us, we're going to do a lot of work covering different provinces under the umbrella of that. Across different provinces, we also have the Provincial Disease Control Center for zoonotic diseases too as well, as the reference lab, which is mandated. We will have the sampling from different poultry farms and we're going to collect about more than 40,000 samples. After we have received the samples, we're going to actually do the isolation. We're going to analyze the antigens as well as the matched subtypes. If we have seen the antigen differences, we're going to upgrade the existing vaccines. Something we have mentioned, that is the inactivated vaccine development platform. By using a cell, we're going to produce a viruses manually. And ever since 2003 or 2002, we have established that in 2003, the first vaccine was actually developed from this platform. It was qualified. In 2004, it was distributed for this technology within a week. We can get a very ideal vaccine. And recently, FIO was having the conferences discussing about the highly pathogenic viruses. I was actually present over the conference. A lot of questions I was asked about was dated back 20 years ago. I don't know how can we actually answer that question, because it seems that for a lot of countries, they don't develop any upgraded vaccines. But China, we are a large country. For the wild birds, they have become the host or the vector for a lot of viruses from the north to west. They have different vectors, they have different carryovers, they become different vectors, and they were also free rendered. So via the monitoring, we have seen a lot of different subtypes have been transported to China. Some people from outside of China would say that China is actually using the vaccine, so somehow the viruses could trace back in China. So for some of the Chinese and the scientists, if they don't know nothing about the truth, they also would speak that I was speechless. But what can we do is to make sure that everybody will understand the truth. So something we've done during the past 20 years, we have monitored those clades where for those wild birds from the overseas countries, they have exported, they have imported those clades into China. We need to better control them from here. We have 10 H5 vaccine covered subtypes. They have been developed normally within 2 to 3 years. For this clade from China, it will be eradicated for this clade, for this serotype, just by vaccination. A lot of H5 imported viruses, they were eradicated. We don't need to have the cooling. So we were saying that we're all scientists as a vet. We're not gonna like a butcher. We need to use our technology to protect the animals. Something we should do as a vet doctor. Well, for some viruses, after its eradication, for this kind of vaccines, we will not have the dosing any longer. We will not have the vaccination any longer. Just like the 10 vaccines we mentioned, it was used just for some time, and then the vaccination was ceased. And also, as like I've said, that in EU and Japan and South Korea in 2020, H5N8, it was an outbreak. We know that for the viruses, anytime at some time point, it will be here. It will be imported to China at some point. So somehow we have faced our monitoring and vigilance. We have a sample about 40,000 samples, including wild birds and poultry and chickens. From here, we can see that for the chickens, half of them, like more than about 25 samples were actually collected from the chicken. No isolates have been identified, but from the wild birds, 300 were actually identified, and 20 have been isolated with this variant. So we shall see, no, the wild birds were not infected, were infected, and they were not vaccinated. After the isolation, we have done the antigens. So talking about the -11-12 for the antigens contained in the vaccines, there are some differences. On the one hand, we need to develop new vaccines. Another question we need to answer, that is to say, among the birds in the past, for those farms, they were using the old vaccines. Whether the old existing vaccines can still provide the protective efficacy against this new variant, we need to address this issue for Ministry of Agriculture So from the current farms for the vaccinated chicken and ducks versus unvaccinated ducks as the control in the lab, we're gonna have the challenge test on them. After the challenge test, I was so surprised to see the results. That is to say, it's just the old vaccines following the immunization schedule, whether it's going to be chicken or ducks in the face of the new variant. Though there are some antigen differences, 100% protection efficacy was achieved. 100% protection effectiveness was actually achieved. If you're interested, you can look at that as to why have we achieved so great protection effectiveness against even the new variant for H5N8 and H5N1 globally. During the past 3 to 4 years, about more than 300 million mortality for the birds and poultry because of the good protection for the vaccines. We have called about fewer than 10,000. Why is that? So for the existing vaccines, for the new variant, they can still provide very great protection efficacy and protection effectiveness. But for the H5N1, we have different clades, and it could be imported to China at any time. So still, we want to upgrade the existing vaccines like the Dash R14 for H5N1, H5N6, and N8. Still, by introducing those new vaccines, now we have the monovalent vaccine, very huge demand globally, very successful, and also have the H5. We also have issues related to H7 and 9. We have different clades. Also, after the vaccine, we think that for the goose and chicken and ducks, they were like sheltered. They're safe. So it's just the case for the H5 prevention control. Now I'd like to walk you through the control of H7 and 9 because in China, somehow, it's actually from the farms in 2017, in 2013 in China. Of course, for the poultry, lowly pathogenic, but in vivo, easy to have the replication, and also very high affinity for the human receptor. So somehow, in the very beginning, it was effective on human beings. From 2013 to 2017, September, we have 5 waves. Mortality for humans is about 40%. So among the 5 tides, whenever there is a human emergence or human infected cases, we would like to say that to stay away from the birds and poultry, try to refrain yourself from the meat. And somehow it was a great loss to the poultry industry, which is about 60 to 80 billion. From the monitoring and surveillance, we can see that since 2017, this was mutated into the highly pathogenic viruses around different base loci because of the insertion of different base anomic acid insertion. So somehow, in order to control the epidemics, we have developed the H7 bivalent vaccine. Since its license show in September in 2017 on the birds, we can see
importantly, so it can play a very big role in the prevention of human infection of H7 and 9. From this picture, we can see after use of the vaccine in September, there is no mortality. And in 2017, a lot of experts in WHO and many international experts predicted there will be much more cases than more than 700, maybe to some disastrous results. But after we use the vaccine, there is no issues like these. So here I like to see the poultry vaccine can play a very important role in the avian influenza prevention control. So here you can see, as President Xi Jinping said, we should move the checkpoint forward to stop the infectious diseases of animal source and human infection. Now, under the global H5 viruses pandemic, we strongly suggest you to use the vaccine to prevent the highly pathogenic avian influenza. And now we have an advantage. We have already got success in China, so European countries and US are now promoting the vaccination and immunization. So when you read the paper, they raise a lot of examples growing China's cases, like the successful cases. So last year we will have a conference that is the same is to rule out every barriers and improve the use of vaccination to prevent highly pathogenic avian influenza. Thank you, Dr. Chen Hainan. I think today you give us a very good introduction. That is, we should prevent human infection from the animal source. We should to pay special attention to the cross-species transmission of pathogens, especially she tells we should pay attention to H5 and H7. In 1997, H5N1 for the first time was transmitted from animals to humans in Hong Kong, and there were human infected cases. And in 2013, H7N9 in China had several human infected cases. And in the past, we know that in the past, it was very rare that H7N9 can infect humans. So the disease burden is not very serious. And in 2013, in the Yangtze River data, there were human infected cases of H7N9, and there were serious cases and mortalities. After that, H7N9 and H5N1 keep circulating around the whole world. So today, Academic Chen gave us a very good introduction from very good perspective. That is, we should prevent the human infections as the animal sources. How does China do that? What is the difference with other countries? And our practices are gradually recognized by other countries. So very good example. Just pay attention to human health, and the reports are delivered not just by the human health experts. We also hope there are experts like Academic Chen Hualan who focus on animal diseases prevention control and pay attention to the relations between human diseases and animal diseases. Just now in Academic Chen's slides, you must have noticed that the global birds immigration rate. So if we want to achieve harmony between man and nature, we need to pay attention to these risks. So very enlightening report. So now let's give the floor to Professor Tan to moderate the next session. Welcome.
Speaker is Professor Xu Yilong. Professor Xu is the director of National Institute of Pathogen Biology, Chinese Academy of Medical Sciences, and Peking Union Medical College, and the chair director of Asia Pacific Alliance for the Control of Influenza. So Professor Xu had actually in the past have been the director of the WHO CC in Beijing, and he's the founding chairperson for that center. And now inviting Professor Xu to talk to us about the effect of COVID-19 on the epidemiology of influenza and other respiratory viruses. Professor Xu.
好，这个谢谢谭教授的介绍。这个我这
For your introduction, this topic actually is given by the organization committee. As Academic Chen said, I have an English slide, but I will speak in Chinese. From 5 aspects. So I'd like to start with this slide. You can see this theme of the conference. It's an influenza conference. Today, we talked about from influenza to the comprehensive prevention control of respiratory infectious disease. Why? Because we can see from the upper and lower respiratory tracts, they are the largest public health burden. So from the picture, you can see in each 100,000 population, how many people will be infected by respiratory infectious disease, and the lower picture shows how many people will die from that. But the respiratory infectious disease is very complicated, not just influenza. Different kinds of virus, bacteria, pathogens will lead to upper and lower respiratory tract infection. So if we look at the top 10 pathogens, we can see each year their ranks are different, but mostly they are the same 10 kinds of pathogens, leading to the major disease burdens. We can see influenza is one important pathogen. And secondly, I'd like to share with you this time the COVID-19, the largest impact on our recognition. We should understand the non-drug intervention and its importance for the infectious disease prevention control. And we stress the importance of vaccines and drugs, of course. Science, especially medical science development, give us vaccines and drugs and different kinds of clinical treatment approaches. But before that, we concluded a series of non-drug intervention measures. It still plays a very important role. For example, the so-called non-drug intervention, including the individual and population-based ones, with their efforts, we have a lot of examples to demonstrate that non-drug intervention approaches have an important role in the prevention control of respiratory infectious disease. For example, influenza. During the period of COVID-19 pandemic, influenza accounts for 60.3%, RSV accounts for 60% and above. So non-drug intervention plays an important role for the respiratory infectious disease prevention control, not just for infection, but also mortality. Influenza mortality accounts for more than 70%, RSV accounts for higher than 66%. So here we can see a lot of papers and also the transmission. There's a Chinese scholars paper showing the infection in China and US. Although different countries may adopt different prevention control measures, but we all promote very effective public health measures. But if we let our guard down very rapidly, we can see the diseases will arise and bring about new problems. This conference, a lot of reports talking about this issue during the past 3 years of COVID-19 pandemic. So different ways where you lowered our disease burden, but will they come back? Will we pay the immune debt? Indeed, we see after the ease or after we successfully controlled COVID-19 pandemic, there are a lot of respiratory diseases rebounded. So we can see currently COVID-19 is still circulating around the world. There are still different rounds of peaks. But in the same period, we can see the global influenza. During the 3 years of COVID-19 pandemic, there was no data. So but after the COVID-19, we can see the rebound of influenza. It increased gradually around the whole world. In the world, we have a very strong influenza monitoring network. So in the picture, we can see there is a blank period, but in the picture on the right, we can see influenza virus still circulating in populations and keep changing and evolving. So only when we have very strong surveillance system can we see this. So this is the global situation after 3 years of COVID-19. We can see the B variant, B strains are no longer existing, but the other 3 strains are still circulating. not just for influenza. In China, our task force also did some work. I won't repeat them. The conclusion is the same. We can see the reduction of activity of influenza, and around the whole world, we can see the drops in burden. Here are some data. But the rebound of influenza epidemic in China after the NPI lifted. In China, we adopted the previous day we adopted the 0 cases measures. It effectively controlled COVID-19 at first, but it brought about another problem. For example, the activity of influenza in China is not the latest. US has the similar timelines with us, including other countries. So you can see the situation in the United States. Here, there are a lot of public health questions which we need to answer. We know that the NPI is successful. We know that very early, for thousands of years. But why it need to such a rebound in influenza? And the changes of the epidemics, for example, the seasons. For example, previously the influenza should circulate in this season, but now it circulates more in another season. So after that's the transmission patterns changes of the pathogens. I think it is because of very complicated biological questions which we lack answers. For example, RSV in southern parts and northern parts of the Earth compared with the pre-pandemic era, we have change of peaks, changing time of the peaks, and they have similar situations in different countries. In US in the North Hemisphere, or in Australia in the South Hemisphere, not just for virus, for the circulation of bacteria, you have similar situations. We have some hypotheses to illustrate it. For example, because of NPI, we didn't contact the pathogens for a long time, thus the immunity decreased within the population. But it's not just because of the lack of contact from the global perspective. COVID-19 also influenced the vaccination, the planned or unplanned immunity. It's a reality. This chart shows the drops in vaccination during the early phases of COVID-19 pandemic. Different kinds of planned immunity vaccines, they all dropped around the world. That's an important influence of the COVID-19 pandemic. Thus, during the COVID-19 pandemic, we missed a very important issue. At that time, due to 2 different reasons, the subjective population may increase. One is because of the challenge, one is because of contact pathogens. Before the end of the COVID-19 pandemic, we didn't strengthen the vaccination for like influenza. We did model research, for example. If before we end the COVID-19 pandemic, we can improve the vaccination of influenza, then to some extent, we can reduce the influenza pandemic. For example, the whole population influenza vaccination, if it increased higher than 50%, then the fluctuation may not be so big. We can look at the blue line. It means we vaccinate 90% of people, 19% of people. But China's vaccination rate for influenza will not be so high, so the peaks of influenza then become higher. But of course, vaccination is very important, but other changes are very important. There are now a lot of researches showing that, for example, social contact index, it will be totally different during and after the pandemic. And after the end of the COVID-19 pandemic, the TSCI, total social contact index, also changed. Because I'm not a model expert, but I read a lot of papers in the sector, you can see because of the physics distancing and the social contact index, then the individual's immune system may change, and then it may further change the population's susceptibility. And from the human perspective, we need to see from the pandemic or from the pathogen perspective. For example, influenza, we have a global surveillance system which is very strong. So when the circulation of influenza is not so active, the variation speed of influenza hasn't changed. It remains the same speed compared with the pre-COVID-19 pandemic era. So it's not the same with our imagination. So I retrospect the 3 years of COVID-19 pandemic. We have some beneficial experience and we have some lessons. As the previous speaker said, there will be new pandemic in the future. How should we be better prepared? We should learn from the COVID-19 pandemic. This is the picture concluded by WHO. It's very important. We can see here, if we want to prepare, we should prepare from 4 aspects. First, surveillance. Second, NPI. This is extremely important. Currently, it is very easily to be forgotten, and modern technologies like vaccines, whether or not we should store vaccines in advance, I think it's a consensus. But whether or not we should vaccinate in advance, we didn't have consensus for that. For example, now U.S. is now experiencing H5N1 vaccine pandemic. Whether or not we should give each American H5N1 vaccine, there's no consensus on that. Another important sector is clinical issues. Previous speakers have covered a lot. So I think the surveillance is very important. We can log in the WHO's website to know its latest multi-disease source surveillance, or mosaic surveillance framework. This is in line with the theme of this conference. Through this platform, we should shift from the single disease influenza surveillance to multi-infectious diseases mosaic surveillance. As Dr. Li Jun said, during the pandemic, we have built the surveillance system for 15 kinds of diseases. According to the WHO's 3 categories, we still need to step up in some sectors. For example, currently, for the detection and assessment of pathogens based on the epidemiology, we have very rich experience. But how to use the surveillance data and shift it into our public health policies? This is what we should pay attention to and what we should step up. For example, for pandemic, each year
So somehow it's a great advancement, but if we're going to stay tuned just here, talking about the value of the monitoring system, it will be compromised. But in order to translate that into policy, that's very important. So the other thing is about the vaccine issue. I'd like to, for my personal opinion, I think that for now, we need to have this scientific advancement in the past somehow for the vaccine. In the past, we have had great progress, especially we have addressed one issue, that is to say, the vaccines, whether it's COVID-19 vaccines or the influenza vaccines, it cannot keep abreast of the mutations of the variant. Once we have manufactured the vaccine, the seasonality has already passed, so we need to develop the broad spectrum influenza vaccine. It's going to be the future. I think that the technology might help to realize that. We have the emerging technologies, of course, for the scientists globally. We have established a lot of consensus, like the publication of the roadmap. It's also the collective wisdom probiotic global scientists so that we can make contributions for the prevention control of the influenza. That's it. Thank you. Your comments are welcomed.
I think we will take Fred. Sorry, I think we will take a break now because we are much delayed, and then after the break, and it will be your stage. Sorry about that. All right. So we will now have coffee and a rest of 20 minutes, and we have to be downstairs where we have breakfast and lunch. Okay. So we'll come back in 20 minutes.
因为我们前面的那个拖了时间比较长，我们提。
Have the tea break downstairs, and please be back on time after the tea break. Thank you. So the session will be resumed in 20 minutes.
I just wanted to see what the situation. How do I? This is advanced here.
This is for the next page, and this is for the previous page.
Very good.
Yeah, you can just do this.
Very good. Very clear. Let me think. Yeah, I'm happy to keep it. Most people have used it.
过往100年，流感大流行累计造成数亿人感染和数千万人死亡，对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年。 世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，至今监测网络已扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒。 中国在全球流感大流行防范方面发挥着关键作用。为积极应对下一次流感大流行，有效预防流感及呼吸道疾病给人类带来的健康威胁，促进全球流感专家学术交流与合作。 由中华预防医学会牵头举办的2018年世界流感大会在中国北京隆重召开。此后，大会每2年举办一次，每届主题聚焦当下流感防控面临的新的复杂挑战以及最前沿的科研进展。 将围绕从流感到呼吸道传染病综合防控的主题，邀请来自全球5大洲的90余名专家交流分享全球最先进的流感防控技术，为应对下次流感大流行做好充分准备，提升全球流感防控水平。
Hello everyone, I am Professor John Tam, and I am the Director of the Asia-Pacific Alliance for the Control of Influenza. Due to the COVID-19 pandemic, the last 2 conferences in 2020 and 2022 were organized virtually. This year, I'm happy to see that we are meeting in person at the BFA International Convention Center in Hainan Island. The main objective of the World Influenza Conference is to bring scientists, medical doctors, and public health policymakers together to raise awareness and discuss up-to-date developments in influenza control. While COVID-19 continues to affect our global health safety, we are expanding our scope to include COVID-19 and other respiratory tract infections with emphasis on treatment and prevention. I look forward to meeting all of you during the conference and wishing you have an enjoyable conference here in Boao. Thank you.
Dear colleagues, my name is Albert Osterhaus. I would wish you a very great conference and indeed have a lot of discussion and get a lot of new knowledge there.
I am Dr. L.J. Tan, co-chair of the United States National Adult and Influenza Immunization Summit, and we are delighted to welcome all of you to the 2024 World Influenza Conference.
Good morning. On behalf of ISERV, the International Society for Influenza and Other Respiratory Viruses, may I welcome you to the World Influenza Conference today.
My name is Salah Halawedi, and currently I hold the position of chairperson at MINASAN. I'm really thrilled to extend a warm welcome to all the attendees of the World Influenza Conference 2024 on behalf of MINASAN.
欢迎全球专家学者齐聚一堂。7月6日，中国博鳌见。过往100年，流感大流行累计造成数亿人感染和数千万人死亡，对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年，世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，至今监测网络已扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒，中国在全球流感大流行防范方面发挥着关键作用。为积极应对下一次流感大流行，有效预防流感及呼吸道疾病给人类带来的健康威胁，促进全球流感专家学术交流与合作，由中华预防医学会牵头举办的2018年世界流感大会在中国北京隆重召开。此后，大会每2年举办一次，每届主题聚焦当下流感防控面临的新的复杂挑战以及最前沿的科研进展。2024年世界流感大会将围绕从流感到呼吸道传染病综合防控的主题，邀请来自全球5大洲的90余名专家交流分享全球最先进的流感防控技术，为应对下次流感大流行做好充分准备，提升全球流感防控水平。
Hello everyone, I am Professor John Tam and I am the Director of Alliance for the Control of Influenza. Due to the COVID-19 pandemic, the last 2 conferences in 2020 and 2022 were organized virtually. This year, I'm happy to see that we are meeting in person at the BFA International Convention Center here in Hainan Island. The main objective of the World Influenza Conference is to bring scientists, medical doctors, and public health policymakers together to raise awareness and discuss up-to-date developments in influenza control. While COVID-19 continues to affect our global health safety, we are expanding our scope to include COVID-19 and other respiratory tract infections, with emphasis on treatment and prevention. I look forward to meeting all of you during the conference and wishing you have an enjoyable conference here in Boao. Thank you.
Dear colleagues, my name is Albert Osterhaus. I would wish you a very great conference and indeed have a lot of discussion, new knowledge there.
I am Dr. L.J. Tan, co-chair of the United States National Adult and Influenza Immunization Summit, and we are delighted to welcome all of you to the 2024 World Influenza Conference.
Good morning. On behalf of ISERV, the International Society for Influenza and Other Respiratory Viruses, may I welcome you to the World Influenza Conference today.
My name is Salah Halawedi, and currently I hold the position of chairperson at MINASAN. I'm really thrilled to extend a warm welcome to all the attendees of the World Influenza Conference 2024 on behalf of MINASAN.
欢迎全球专家学者齐聚一堂。7月6日，中国博鳌见。过往100年，流感大流行累计造成数亿人感染和数千万人死亡，对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年，世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，至今监测网络已扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒，中国在全球流感大流行防范方面发挥着关键作用。为积极应对下一次流感大流行，有效预防流感及呼吸道疾病给人类带来的健康威胁，促进全球流感专家学术交流与合作，由中华预防医学会牵头举办的2018年世界流感大会在中国北京隆重召开。此后，大会每2年举办一次，每届主题聚焦当下流感防控面临的新的复杂挑战以及最前沿的科研进展。2024年世界流感大会将围绕从流感到呼吸道传染病综合防控的主题，邀请来自全球5大洲的90余名专家，最先进的流感防控技术，为应对下次流感大流行做好充分准备，提升全球流感防控水平。
Hello everyone, I am Professor John Tam and I am the Director of the Asia Pacific Alliance for the Control of Influenza. Due to the COVID-19 pandemic, the last 2 conferences in 2020 and 2022 were organized virtually. This year, I'm happy to see that we are meeting in person at the BFA International Convention Center in Hainan Island. The main objective of the World Influenza Conference is to bring scientists, medical doctors, and public health policymakers together to raise awareness and discuss up-to-date developments in influenza control. While COVID-19 continues to affect our global health safety, we are expanding our scope to include COVID-19 tract infections, with emphasis on treatment and prevention. I look forward to meeting all of you during the conference and wishing you have an enjoyable conference here in Boao. Thank you.
Dear colleagues, my name is Albert Osterhaus. I would wish you a very great conference and indeed have a lot of discussion and get a lot of new knowledge there.
I am Dr. L.J. Tan, co-chair of the United States National Adult and Influenza Immunization Summit, and we are delighted to welcome all of you to the 2024 World Influenza Conference.
Good morning. On behalf of ISERV, the International Society for Influenza and Other Respiratory Viruses, may I welcome you to the World Influenza Conference today.
My name is Salah Alawedi, and currently I hold the position of chairperson at Hainan. I'm really thrilled to extend a warm welcome to all the attendees of the World Influenza Conference 2024 on behalf of Hainan.
欢迎全球专家学者齐聚一堂。7月6日，中国博鳌见。过往100年，流感大流行累计造成数亿人感染和数千万人死亡，对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年，世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒，中国在全球流感大流行防范方面发挥着关键作用。为积极应对下一次流感大流行，有效预防流感及呼吸道疾病给人类带来的健康威胁，促进全球流感专家学术交流与合作，由中华预防医学会牵头举办的2018年世界流感大会在中国北京隆重召开。此后，大会每2年举办一次，每届主题聚焦当下流感防控面临的新的复杂挑战以及最前沿的科研进展。2024年世界流感大会将围绕从流感到呼吸道传染病综合防控的主题，邀请来自全球5大洲的90余名专家交流分享全球最先进的流感防控技术，为应对下次流感大流行做好充分准备，提升全球流感防控水平。
Hello everyone, I am Professor John Tam and I am the Director of the Asia-Pacific Alliance for the Control of Influenza. Due to the COVID-19 pandemic, the last 2 conferences in 2020 and 2022 were organized virtually. This year, I'm happy to see that we are meeting in person at the BFA International Convention Center here in Hainan Island. The main objective of the World Influenza Conference is to bring scientists, medical doctors, and public health policy makers together to raise awareness and discuss up-to-date developments in influenza control. While COVID-19 continues to affect our global health safety, we are expanding our scope to include COVID-19 and other respiratory tract infections with emphasis on treatment and prevention. I look forward to meeting all of you during the conference and wishing you have an enjoyable conference. Thank you.
Dear colleagues, my name is Albert Osterhaus. I would wish you a very great conference and indeed have a lot of discussion and get a lot of new knowledge there.
I am Dr. L.J. Tan, co-chair of the United States National Adult and Influenza Immunization Summit, and we are delighted to welcome all of you to the 2024 World Influenza Conference.
Good morning. On behalf of ISERV, the International Society for Influenza and Other Respiratory Viruses, may I welcome you to the World Influenza Conference today.
My name is Salah Halawedi, and currently I hold the position of chairperson at MINASAN. I'm really thrilled to extend a warm welcome to all the attendees of the World Influenza Conference 2024 on behalf of MINASAN.
欢迎全球专家学者齐聚一堂。7月6日，中国博鳌见。过往100年，流感大流行累计造成数亿人感染和数千万人死亡，对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年，世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，至今监测网络已扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒，中国在全球流感大流行防范方面发挥着关键作用。
请各位领导、专家落座，大会即将开始。
After coffee and cake or whatever, and we had a great discussion just now on avian influenza vaccinations, and we have talked about the changes in epidemiology of respiratory tract infections affected by COVID, and as proposed as an after effect of the non-pharmaceutical interventions that we wear face masks and so on. But we are coming to a very important topic. I think this is one of the most important topics that we are nowadays, for all of you as doctors, how to treat patients who are suffering from influenza. So the next talk is going to be by Professor Frederick Hainan. His talk is going to be Advances in Research of Influenza Therapeutics. And Professor Hainan is Stuart S. Richardson Professor Emeritus of Clinical Virology and Professor Emeritus of Medicine at the University of Virginia School of Medicine. Fred doesn't need introduction. He's been well known. He's been always working on antivirals for many years. So go ahead, Fred.
John, thanks very much for your kind words. And good morning, colleagues. It's really a privilege to be with you here in this beautiful place in China. I'm not going to talk to you about how to treat your patients. I'm going to rather try to give you a technical update on recent advances with regard to the development of newer influenza antivirals. These are my disclosures. The most relevant one is at the bottom. That is that I'm a trustee of the International Society for Influenza and Other Respiratory Viruses, ICERV, and I'm representing ICERV at this conference. For those of you who are not familiar with ICERV, I just wanted to highlight that it is going to hold its 12th Options for Control of Influenza conference in Brisbane, Australia, later this year, beginning at the end of September. This conference has already received over 1,000 abstracts regarding different aspects of influenza research, but there still is an opportunity to submit late-breaker abstracts. ICERV is also organizing an RSV conference, the 13th International RSV Symposium, which will be held in Brazil next year. And so I encourage you to consider participation. Also, beginning with the pandemic, ICERV started a series of webinars, and this has continued through this year. This slide lists the 4 that we've had so far, most recently one on bovine influenza and other topics in virus evolution. Before that, at the end of May, we had one on recent antiviral developments for respiratory viral infections. And this is the outline of the speakers. Professor Cao Bin was our keynote speaker and gave an overview of recent advances with regard to antivirals for respiratory viruses here in China. And I know that he'll be talking later on to update you on the work that's going on then. I'm going to briefly highlight some of the new information that came from the other 2 shorter presentations. But I encourage you to consider participating in these webinars. They're free, but you do have to register. The next one will be in September with regard to RSV infections. Now, the development of antiviral drugs for influenza viruses has been a relatively slow process. It was over 30 years between our first class of antivirals, the adamantanes or M2 inhibitors, and the development of the neuraminidase inhibitors, and then another roughly 20 years until we had potent intravenous neuraminidase inhibitors and the major advance with regard to a polymerase inhibitor called baloxavir. Need to go. Now, that's the news, unfortunate news with regard to development, but the good news is that there's been a lot of recent progress, and I'll touch on some of that today, but this slide highlights the fact that we have 4 new PA endonuclease inhibitors and another PB2 inhibitor that have completed advanced clinical trials, all of these being developed here in China and studied initially in uncomplicated influenza. Also, there are several others that I'll touch on as we go forward. Just a few comments in review for you with regard to baloxavir. Because of its prolonged plasma elimination half-life, it's possible to use this as single-dose therapy in uncomplicated influenza. But the clinical efficacy in influenza A is similar to that seen with oseltamivir in otherwise healthy adults and high-risk outpatients, although it is a more potent antiviral, in fact, our most potent antiviral for influenza to date, also effectiveness has been established in children. However, it's important to recognize that it's more effective than oseltamivir in influenza B, and we've recently seen that it is also highly effective for post-exposure prophylaxis in the household setting. Now, one of the issues with any influenza antiviral drug is the issue of resistance, and with regard to baloxavir, it's shown in the diagram where it's intercalated into its active site. A specific amino acid residue, the isoleucine at 38, is the key pathway for treatment emergent variants with reduced susceptibility. And I'll show you some more data on that in just a moment. To remind you about the Capstone 2 trial, this was done in high-risk outpatients, and the primary clinical outcome measure was the time to improvement in influenza symptoms. On the other side of this slide, you'll see the effect on infectious virus detection in the upper respiratory tract. And for both influenza A, H3N2, and type B, baloxavir was much more effective than the placebo group, as expected, but also in particular more effective than oseltamivir. Now, that greater effectiveness than oseltamivir didn't translate into greater clinical benefit for influenza A, but it did for influenza B. In addition, not shown here is the fact that both drugs, and in particular baloxavir, reduced complications leading to antibiotic use, which is an important clinical benefit. Now, one of the issues that we've recently tested is the question of whether treatment with these drugs can reduce transmission of virus to close contacts. And this is a retrospective analysis of the Blackstone trial, which showed that baloxavir was highly effective for post-exposure prophylaxis with a point estimate of efficacy exceeding 80% in that household setting. What we were able to do is look at the secondary attack rates in household contacts who received a placebo or no antiviral treatment, but were exposed to an index case that received either baloxavir or oseltamivir. For those who received, where the index cases were treated with oseltamivir, the secondary attack rate was about 18 to 19%, whereas those in the households where the index case received baloxavir, that was reduced to just about 11%, which represent a 42% reduction, a very substantial additional benefit. And the modeling studies would indicate that this could make a major difference with regard to transmission of virus, not only in the household, but also within the community. Now, one of the issues I mentioned, of course, is the frequency of resistance emergence. And this is a series of patients who had the emergence of the isoleucine to threonine substitution in that amino acid at position 38. These variants, as shown in the red, can come up as early as 48 hours, and certainly by 3 to 4 days in. They're sometimes associated with a rise in viral loads in conjunction with their emergence, and they occur at a time when there are falling levels of baloxavir in the plasma. In general, though, that they're not associated with worsening of the clinical situation, although that is a concern in hospitalized patients and in more severely ill ones. To put this in some perspective for you, this table summarizes what's been learned about the frequency of emergence of resistant variants during treatment in outpatients and the risk of their transmission from person to person. With again, the first class of drugs, and specifically studies that were done with rimantadine, we know that there's a high frequency of such variant emergence both in adults as well as infants and children. Anywhere from 1 in 3 to 1/2 of these individuals will shed a resistant virus. Most commonly, the serine to asparagine substitution at position 31. And yes, these variants do transmit efficiently from person to person. There's no fitness loss. And that's one reason why we currently see widespread circulation of both influenza A H1N1 and H3N2 viruses that are resistant to this class of antivirals. With oseltamivir, there's a difference depending on the age of the patients and their immune experience. Much lower in adults, about 1%, will have treatment-emergent resistance. Higher in younger children, particularly with H1N1 type infections, where the histidine to tyrosine substitution at 275 plays a major role. And of course, this is the type of virus that we saw in 2007 to 2009 circulating in seasonal H1N1 virus, causing loss of oseltamivir effectiveness. With baloxavir, you can see that the frequency also of resistant variant emergence does depend on age, although it's quite high even in adults with uncomplicated disease, up to 10%, even higher in young children below the age of 5 years, where for an H3N2 virus, which is the highest risk virus for resistance emergence, has exceeded at least 30% in at least one study. There have been a few instances of person-to-person transmission of this virus, but not certainly at the population level. So this gets us to the issue of how to prevent resistance emergence. And this has been studied by, as you might expect, by combining antiviral drugs. And the Flagstone trial was done in hospitalized patients with influenza, where baloxavir or placebo was added to standard of care and neuraminidase inhibitor therapy, and that was mostly oseltamivir. And what's depicted here is a time to cessation of viral shedding with the combination group shown actually in the red. And that was quite short. The median time was just 24 hours, much less than half of that seen in the placebo group who received monotherapy with oseltamivir, so over a day difference. Furthermore, the frequency of resistant variants was reduced in the combination group. There were still some breakthrough infections with I-38 substitutions, but only in 1.5%, and that's much lower, as you recall, than has been observed in the outpatient setting. And also some neuraminidase inhibitor, oseltamivir resistant variants. But again, the combination seemed to reduce that risk by at least half. In this study, which was really underpowered, there was no difference in time to clinical recovery, but the overall 28-day mortality was numerically lower, reduced by over half. So that's encouraging, but clearly we need more data on the optimal treatment of hospitalized patients. And there's work going on to try to address that. The REMAP-CAP trial in hospitalized influenza patients in the United Kingdom, which is now being expanded to international sites, is addressing several different treatment domains, one of which is the antiviral domain. They're going to look at a randomization to either no antiviral treatment, oseltamivir alone, baloxavir alone, or the combination, and look at different durations of illness. So they'll be giving, I think, key data with regard to the value of combination therapy with regard to these antiviral agents. And a lot of, as you can imagine, secondary endpoints, including ICU, length of stay and mortality, and oxygen-free days will be collected as well. Okay, let me turn to some of the other agents which are in different stages of clinical testing currently. One of these is favipiravir, which has really been examined for a whole range of RNA viral infections. It's a broad spectrum agent that does inhibit the RNA polymerase, probably in part through a mechanism that involves viral immunogenesis. It was approved in 2014 for novel influenza viruses in Japan that were unresponsive to current antivirals. But with regard to antiviral efficacy in uncomplicated influenza, two large international studies which used the dosage indicated on the slide, found that really there were significant antiviral effects seen, but variable clinical efficacy that was not probably quite as great as historically observed with oseltamivir. More recent studies in COVID-19 would indicate that it was ineffective in that condition, in part because coronaviruses are less susceptible than influenza viruses, and was recently approved in Japan for treatment of severe fever with thrombocytopenia syndrome, which is, I know, a problem here in China. And that drug has been used here in part for that particular condition. Just point out that there's ongoing work with regard to another Bunya virus infection, Congo-Crimean hemorrhagic fever. Now, the problem with oral favipiravir is that its human pharmacokinetics are complicated. We found that in the outpatients with uncomplicated influenza, and that's depicted in the figure, the two different trial results, that the plasma levels, particularly at the target level of a 20 microgram per ml for the minimal plasma concentrations, a large portion, over 40% of the individuals failed to meet that minimum target. The blood levels, is shown by the wide range in the figure, were quite variable, and they actually decreased over time, especially, and this has been seen previously in study done here in China, in patients with more severe influenza, and this was also observed in Ebola. And part of this is because favipiravir induces and is metabolized by the enzyme aldehyde oxidase, and the blood levels depend on the aldehyde oxidase activity, the illness severity, the weight of the patient, probably the ethnicity, and genetic factors affecting AO activity, and possibly co-administered drugs. So it's tricky to use that drug. Now, this slide should have shown you the effects of what's possible with regard to using IV favipiravir, which gives much more reliable drug levels, and because of that is currently undergoing testing in CCHF. There we go. So although, again, you can notice that there is still substantial individual variability at much higher levels that should be effective in terms of inhibiting virus replication. Another drug that is a polymerase inhibitor, a PB1 inhibitor, is molnupiravir. This agent, as you know, is approved for SARS-CoV-2 treatment in many countries, but its antiviral spectrum is broad. It includes other coronaviruses, influenza, and RSV. And so it's interesting to note that it is highly efficacious in murine and ferret models of influenza, and there is an ongoing placebo and oseltamivir-controlled human challenge study where individuals are purposely exposed to influenza virus and then treated with one of these agents. So we'll look forward to the results of that study. Another study that has used the human challenge model has recently been completed with regard to this agent, CD388. This is a multimeric zanamivir moiety that is conjugated to an FC receptor, which in turn has been engineered so that it will prolong the plasma elimination half-life and increase tissue distribution, hopefully to the respiratory tract. So the antiviral mechanism here is primarily through zanamivir, but it has been shown in preclinical studies to have broad spectrum inhibition of seasonal and pandemic threat viruses. There's a low potential for resistance emergence because it uses zanamivir, and the company developing it proposes to use single subcutaneous or IM doses for prophylaxis throughout the influenza season. I think the drug actually would be important in an intravenous form to be tested in hospitalized patients. This next slide will show you some of the results from the human challenge study that was done, and it did have a significant antiviral effect when begun before virus inoculation in the noses of these susceptible volunteers. What's planned now is that there'll be about a 5,000 outpatient study that will examine the question of in non-immunized individuals whether it will protect them from seasonal influenza, and that's planned to begin during the upcoming influenza season in the Northern Hemisphere. I want to mention two other agents that have not yet made it into clinical testing, but I think are quite interesting. One of these is a broad-spectrum anti-neuraminidase monoclonal. So not surprisingly, if drugs targeting the monoclonal will work, that a sufficiently potent monoclonal that will inhibit the neuraminidase should be effective as well. They actually directly target the active enzyme pocket, and one of these has been shown to be inhibitory for seasonal influenza A and B viruses and shows really potent prophylactic activity against lethal infections in mice. And interesting, can be combined with anti-hemagglutinin stem antibodies and where it shows a synergistic activity. So this agent hopefully will be entering into initial clinical development shortly. And the final agent I wanted to comment on was again presented at our most recent antivirals webinar, and this is known as VNT101. This is a novel influenza A-specific inhibitor that targets the nucleoprotein. You can see that it's a fairly potent inhibitor in vitro with submicromolar inhibitory concentrations for a range of viruses, including H5 and H7 and 9. The mechanism of action is the disruption of the polymerization of the nuclear protein, which is necessary for its optimal function. Work has been done to confirm that that's the target through generation of resistant variants, which do confer fairly high level resistance to the antiviral effects. So it likely is an agent that will be used in combination therapy, but it has already progressed to the point showing favorable toxicology profiles and efficacy for both prophylaxis and treatment in murine models. So this is an interesting one to pay attention to. So to summarize then, progress has been made in developing diverse and more effective antivirals for influenza. The optimal treatment strategies in hospitalized patients, those who are critically ill and immunocompromised hosts, remain uncertain, and those are under study currently. We've seen treatment-emergent resistance with all widely available classes of influenza antivirals to date, which argue strongly for diversification of stockpiles. Large-scale trials are currently in progress to look at more effective therapies in severe influenza. These include not only antiviral combinations to increase potency and reduce resistance emergence, but also the role of immunomodulators. Others will talk about the latter during this conference. But the bottom line here is that wider and more timely use of antivirals will reduce morbidity and mortality in not only seasonal, but also zoonotic and pandemic influenza. Thank you for your attention.
Thank you, Professor Hayden. And Professor Hayden later on tomorrow is also talk about the use of antivirals in pandemic planning in terms of prophylactic and so on. So in the interest of time, the next person is going to talk on changing patterns and disease burden of RSV infection in Australia is Professor David Smith from Australia. Professor David Smith. Professor Smith is a clinical virologist and deputy chief pathologist at the Path West Laboratory in Queen Elizabeth II Medical Center in Perth. And David is also one of the directors of Apache. So, David.
Thank you, John, and thanks very much to the organisers for inviting me to speak on a very important subject. So respiratory syncytial virus is the most important respiratory viral infection of children, particularly those under 5 years of age, causing most often bronchiolitis or similar syndromes, but occasionally pneumonias, It's an important contributor to hospitalisation of children with respiratory virus disease, and around about 25% of those can be attributed to RSV. And infections in children, natural infections, are very common. But there is also a more severe manifestation of RSV in some older individuals, particularly those with pre-existing respiratory disease, those who are immunocompromised, and older adults as well. In temperate climates, and the lower half of Australia has a temperate climate, we see a very classic pattern of winter outbreaks. And when you see the graphs, just remember winter in the southern hemisphere is in the middle of the year. With a range of illnesses associated with others also. In our more northern subtropical and tropical areas, there's a much less regular seasonal pattern with more activity around the year. RSV, the virus, like a lot of our prime respiratory virus villains, is an RNA virus. And I don't want to dwell on this one, but the most important proteins and the sequences that code for them are for these surface proteins, the small hydrophobic protein, the attachment protein G, and the fusion protein F. And that's where neutralising antibodies are directed to. They're also very important in classifying and tracking the virus, both in terms of the major two antigenic types, A and B, but also when we look more specifically at the finer differentiation of our strains and clades, and its sequencing of these regions, particularly this C-terminal of the hypervariable region, the G protein, which we use for tracking the virus. But you'll see in this, we've also, of course, moved a lot now to whole genome sequencing to help us with tracking of this virus. This is what it looks like for us in Western Australia. It's pretty much the same for the whole of the temperate areas of Australia. We have had in the past a very regular and predictable RSV season that occurs in the middle of the year. There is some variation from year to year, but precious little. And you can see in the lower graph there that we have that very regular pattern, and that goes up to 2019 there, with also a mixture of types and subtypes. So we don't get single type seasons. It's multiple different strains of the virus which co-circulate. And this is true, of course, everywhere in the world as well, but the patterns might be slightly different. Now, this might look a little more complicated, but this was one of the earlier sequencing studies that we did, just looking at that bit of the G protein sequence to look at what was happening around the country. So this was conducted prior to the pandemic in 2016-17 with colleagues on the east coast of Australia. So Western Australia, which is the yellow one there on the left of the map, is about a few thousand kilometres away from Sydney and Melbourne, Victoria, New South Wales, in the southeast of the country. But we see quite a slightly different but similar pattern when we looked at the genotypes prior to the pandemic. That is that we had circulation of multiple genotypes, and whilst they varied a little, the genotypes were largely found in both sides of the country, indicating that there was very widespread across the country with the movement of people regularly. So to say we were surprised about what happened in 2020 is an understatement. Having had very regular patterns of RSV activity, it disappeared. Now, these are three different states. Two of the East Coast states are at the top and the bottom. If you look at that orange line, and in years prior to the pandemic, again, all of us had a predictable winter season of activity. Might vary in size a bit, but it was there every year. Then those grey bars represent the periods when the bar at the top indicates where there were periods of higher restrictions for COVID, that very narrow bar right up the top. But if you'll take my word for it, in 2019, of course, COVID appeared, and in early 2020, the pandemic really took off, and we introduced our restrictions. The restrictions that went into place, including border control and a number of public health measures, were instituted just before our winter season would normally begin. And instead of our usual RSV activity, of course, nothing happened. We eased off on our restrictions towards the end of the year with a reopening of schools and reduction of social control measures without reopening of borders at that time. And we saw then that there was a major outbreak of RSV in the summer, so beginning in November, December of the year. That is something that had never happened before. So we were looking at a major outbreak of RSV occurring out of the normal season. That gave us an opportunity to look at what essentially was a natural experiment. We had occurring in different parts of the country and looking at what differences may have occurred there to have a better understanding of how this virus gets around and gets introduced. So this one, I will explain. The graph on the left is a conglomerate of RSV sequences and these are whole genome sequences here, for several years within Australia, and the different coloured dots are different states. And up to the pandemic, we had our usual pattern of mixed strains. The little blue box up the top, which is magnified in the graph in the middle, was from the reappearance in that large outbreak of RSV, which occurred in 2020. And what was notable then was there was a monophyletic, so a single strain of RSV which caused each of the outbreaks. The top little thing with all the blue dots at the end of it is the East Coast isolates. The yellow ones down the bottom are the West Coast. Not only was it a single strain, it was two different single strains in the two sides of the country. It was clear that that was, again, both of those were extremely unusual patterns. So what we saw in the summer of in Western Australia was that we had a large unexpected peak. It was marked, and I apologise here, this next one in the, I think in the slides, those percentages are not in the right place, and I'll explain them to you in a moment. But the proportion of admissions to paediatric hospital with bronchiolitis between 2019 and the big season, the end of 2020, it went from having 20% of admissions related to RSV to 33%. So there was an increase in the contribution of RSV to respiratory admissions in children, despite the fact that there was a very late season in 2020. So the virus was behaving very unusually. There was also a shift in the age rate upwards. So the average age of children went up, and that appeared to reflect the fact that there had been a cohort of children who were not exposed to RSV when they normally would have been because of the absence of the virus in that season. So there were a group of older children which were still susceptible to RSV. It was interesting in the older children, in a Danish study in the older children, they had, though overall there was no increase in the severity of disease, there were some more atypical complications seen in the older children that led to intubation. So there were a number of changes in the behaviour of that virus. So what do we think happened in 2020? Well, what we found out is public health measures can work in terms of controlling respiratory virus infections. I guess that was important lessons in terms of our challenges to future outbreaks. But it created, as a result, a much larger susceptible pool particularly of younger children, that means children up to 2 or 3, who hadn't been exposed to RSV during that winter of 2020. That meant that the degree of immune protection within children was insufficient to prevent that exceptionally large outbreak. The other thing that also it showed us is that when you have those sort of circumstances, your outbreaks are not normally going to occur, not necessarily occur in the sort of conditions you normally had. It didn't need our cold winter conditions for the outbreak to occur, not unlike what we saw with pandemic influenza. The low population protection meant also the reason why we saw just a single strain presumably was because there were no real pressures for there need to be any more than one strain. There wasn't enough pre-existing immunity to control any single strain, so the single strain that got in was the one that took off for the epidemic. Again, that's important in terms of how we think what might happen in these circumstances in the future. This somewhat complicated but ultimately very pretty picture of the phylogenetics was an attempt to determine where we thought these viruses came from. It looked like we had 2 separate introductions of single strains of viruses into the 2 sides of Australia. Unfortunately, and while there were some, the ones down in the lower right-hand corner of the graph were the ones that came from New South Wales and Victoria, and the ones next to it from WA. There were some sort of suggestions of where it may have originated, but what it did point out was that for our region, particularly immediately between here and Asia, there is very little sequence information. And if we want to use these sorts of tools to guide us and give us information and understand where viruses come from, we need more data, basically. And the whole genome sequencing is an extremely powerful tool if we have enough sequences. What happened after that? Well, gradually it's gone back to its normal pattern, so that once you remove those unusual circumstances, it seems to settle back into its usual pattern. That shows, just for our state, just a very short summary of where we saw with RSV for those 3 seasons. We had a couple with funny patterns and unusual timing. We tended to have later seasons, nearer the summer still, but gradually it's gone back to being a winter season and seeing a mixture of types and of strains occurring at the same time. It was important to get this information now because in terms of understanding the viruses, as the monoclonal antibody therapies, as the vaccines are rolled out, we're not going to see the natural behaviour of the virus. So these are important opportunities to look at that. So there's this concept which has already been mentioned by Professor Shi of having an immunity debt. And where we create those circumstances where we have very good control of a viral infection, or any infection, I guess, in which host immunity is important in limiting it, then we create a larger susceptible population. That means that when we have these circumstances, we need to begin planning for how we're going to repay that immunity debt. And what we hope for in the future with things like RSV is when we get this, we can prepare by increasing our vaccination rates in order to address that immunity debt. Again, Professor Shi touched on this. It wasn't just RSV. This is a study by my colleague, David Foley, looking at human metapneumovirus, a very closely related virus. And that was also showed exactly the same pattern. That is, we went from having mixed genetic types circulating for human metapneumovirus to having, following the pandemic, it disappeared during the pandemic. Following the pandemic, we had reappearance with a single genetic lineage. So it was similar things were driving the behaviour of these viruses. It also looks like it's going to be similar for the para-influenza viruses, but maybe not for the adenoviruses. So there are many things for us to look at further to better understand the behaviour of these viruses. And lastly, I just want to recognise this was very much a national collaboration in a country like Australia with such a big geographic area and varying climatic regions and different patterns of population movements. It provides opportunities for us to compare and contrast and begin to understand why these differences happen. So the group there at Pathwest, including my colleague Chisha Sikazwi, did a lot of work there. Others at the University of Western Australia, the Perth Children's Hospital and the Telethon Kids Institute. At the WHO Collaborating Centre in Melbourne, where Ian Barr and Sheena Sullivan are, the sequencing and other New South Wales EPI came from University of Sydney, and many of you will know, of course, of Eddie Holmes and John Sebastian Eden, who took on a lot of the phylogenetics, and we worked with Vijay and his group at University of Hong Kong for the bioinformatics. Thank you.
Now the molecular biology and sequencing are really telling us a lot of stories and explaining why are we seeing less RSV, and then it comes back to it in terms of this, when the immunity changes in the population. So Professor Yang is going to introduce the next speaker.
好的，我们下面讲者是来
University, the U, and he has been working for the epidemiological study as well as the transkinetics study related to the infectious diseases. He will be talking about the trend in the global burden for the lower respiratory tract infection. Welcome.
Today I'm really honored to be here to present to you the topic on the trends in the global disease burden of lower respiratory infections. Here's my disclosure of competing interests. So the very first slide I would like to show is more of the ranking of the leading causes of mortality global-wide. So we can see that as the black arrow indicates, so lower respiratory infections, it ranked the fourth in the year of 1990 and then to 2019. And since the onset of the COVID-19 pandemic, it dropped to the 7th place. But here, one thing that's really worth noting is that COVID-19 here is ranked separately, which is the 2nd place. And also tuberculosis was ranked separately. And the etiologies of lower respiratory infections, it really varied from viruses, bacteria, and also to atypical bacteria such as Mycoplasma, pneumonia, as I think some of the speakers earlier briefly talked about this, and also fungi. And for this presentation, I will really just focus on pneumonia and bronchiolitis as kind of the definition for lower respiratory infections. And specifically, we exclude tuberculosis, pertussis, and COVID-19 here. And here, this is an overview of my presentation. I will briefly go over when, who, where, and what pathogens that are associated with lower respiratory infections. The very first table on the global disease burden of lower respiratory morbidity and mortality is shown in this table. And we can see that from the year of 1990 to 2019, almost 3 decades, there was a 19 decrease in terms of the incidence rate of lower respiratory infections. And for the mortality, the decrease is about 42%. And the main drivers behind this are the improved living conditions, vaccinations, and the access to and the improved access to and the quality of care. And moving on beyond the year of 2019, we know that the onset of the COVID-19 really changed the epidemiology of multiple diseases, and especially for infectious diseases like lower respiratory infections. And obviously, the non-pharmaceutical interventions played a role here. And as we've shown here, from the year of 2019 to 2021, there was further decrease in both incidence and the mortality. And the reason, as I mentioned, was the NPIs. And beyond the year of 2021 and towards now, the reduction in terms of the incidence and the mortality rate was not like a permanent thing. Really, taking here the US CDC data as example, it shows the national weekly report of emergency department visits for pneumonia among children. So we can see there, it's only during certain months, after 2020 and in the early 2021, we could see a low activity of lower respiratory infections. But after that, we can see the emergency department visits really went up and to a level that's comparable to the pre-pandemic level. And let's go back to the mortality rate changes, but now let's zoom into the different age bands here. So overall, from 1990 to 2019 and then to 2021, we could see a consistently decrease in the mortality rate for almost all age bands. But here, for the older age group, which is on the very right there, the reduction was much slower. And the reason behind this are possibly related to the lower vaccine efficacy in this age group, and also the lower coverage, as well as the presence of comorbidities, which were very common in the older adults. And even though we could see a reduction in the LRI mortality in young children, but such reduction was far from like a satisfactory level. So WHO and UNICEF, they had this ending preventable child deaths from pneumonia and diarrhea, and there are a set of goals that were set by 2021, and one of these goals stated that to reduce the mortality from pneumonia in children less than 5 years to a level that's 3 per 100 live births, which is approximately 6 per 100,000 in terms of annual mortality rate. So, but if we look at the regional estimates of mortality rate due to LRI, stratified by the social demographic index quintiles, we can see the last two quintiles, they really had a substantially higher mortality rate than the goal, which is set here, the 60 per 100,000. So we are far from a satisfactory level. And next, speaking of the regional variations here, this is a map that showed the global LRI mortality rate in the year of 2021. And we could see, obviously, in some of the countries, especially in sub-Saharan African countries, the mortality rate is high. But at the same time, we could also see, although it may appear a bit small from the screen, but some of the high-income countries like the United Kingdom, Japan, and perhaps Portugal here, they had relatively higher LRI mortality rate. And the reason for the higher mortality rate in high-income countries was largely related to the aging population. And going back to the low and middle-income countries, and obviously which had the much higher mortality rate, it is the poor access to and quality of care that contribute greatly to the high lower respiratory mortality rate. And here, using an example of RSV, we could see this really astonishing numbers here in terms of the proportion of the LRI incidence and the mortality in LMS in low and middle income countries. And here, using infant population example, LMSCs or low and middle income countries, they accounted for 90% of the infant population. But in terms of the RSV incidence in the community, it accounted for 96%. And when it comes to LRIs that necessitate hospital admission, it is 97%. But if we look at hospitalized cases, they only accounted for 87%, so even less than the share of the population, which obviously means that there was poor access to hospital care. And this was further highlighted in the mortality estimates, either for the in-hospital mortality estimates and or for the overall mortality. Again, low and middle-income countries, they accounted for 98% and 99% of the overall mortality. And also, if we compare the in-hospital and out-of-hospital mortality in these low and middle-income countries, we could see further disparities across different income strata. So here we stratified these countries by the World Bank income classifications from low income on the left to lower middle in the middle, and then upper middle on the right. So we could see that in low income countries, for every one RSV mortality found in hospital, there could be as many as 4.6 deaths found in the communities. This is really an astonishing number. It just means that, again, reinforces the issue of the lack to and the poor quality of healthcare. And next, let's further zoom into the etiologies of our LRI mortality. And here, this shows the global LRI mortality by different etiologies for all ages. And on the very top of the list, consistently, it was the the pneumococcus. And the second and third bacterial causes are Staph aureus and Klebsiella pneumonia. And here, by the way, Staph aureus, actually, the absolute number of deaths actually increased, which is different from the other two bacterial causes, and mainly due to the fact that we don't have a vaccine at the moment, and also there is the challenge of the resistance to antimicrobials. And for viral causes, it's mainly the influenza and the RSV that were on the top of the list. Although, if we look at the year of 2020 and the year of 2021, there was a really sharp decrease, much due to the implementation of non-pharmaceutical interventions. And for LRI morbidity by etiologies, again, we can see that pneumococcus was on the top of the list. But here, secondly, we could also see mycoplasma, which actually we could see an increased incidence over the years. And for viral causes is again influenza and RSV. And the numbers by 2019, if we compare it to the year of 1990, it also increased. But at the same time, we could see a very worrying category here called other viruses. So, and we really want to know what are the other viruses are. So the very first study that really looked deep into the other viruses is a multi-center study called PURGE, looking at the etiologies of severe pneumonia among young children. So across these 7 countries listed here, RSV is on the top of the list. And to follow, the next virus is human metapneumovirus, as one of the speakers earlier mentioned. And also, human parainfluenza virus was in the top 3 for some of the countries, and for rhinovirus as well. And for mortality, there was another multi-center study called CHAMPS, in which they took post-mortem samples from the children who died either in communities or in hospitals, and they used this minimally invasive tissue sampling techniques to really took long samples, took lower respiratory samples, and here this cytomegalovirus virus really was found out to be associated with a really high proportion of mortality, which was a bit surprising before the publication of this study. And to further move into the interaction of the different pathogens, I think this is a field that's relatively new, although the concept of this, I think, is kind of well accepted. And so here, taking an example from the study from Israel, which showed that during the COVID-19 pandemic, the incidence rate of pneumococcal disease or invasive pneumococcal disease, they decreased, due to the implementation of NPI, obviously. But at the same time, if they also measured the pneumococcal carriage and the density, and they found that there was little change in the carriage and the density. And this is quite interesting because there is obviously a mismatch between the disease and the carriage. And quite interesting, they found that the reduction in the incidence of pneumococcal disease, it was associated with the disappearance of multiple respiratory viruses, such as RSV, influenza, and the metapneumovirus, and which obviously supported the role of possible interactions between different pathogens. And next, this is a work that's currently still in working progress by our research group. And here we really wanted to know and compared the timing of the resurgence of different viruses after the start of the COVID-19 pandemic and after the relaxation of non-pharmaceutical interventions. And here, quite interestingly, if we compare among different viruses, they came back to circulation at a different time. So rhinovirus came back the earliest, followed by 3 viruses, RSV, the seasonal coronavirus, and adenovirus. And further, it was paraflu and metapneumovirus that's there, and lastly, influenza A and influenza B. And this also suggests that there was potentially possible viral interference or viral interactions, between these different common respiratory viruses. And to summarize, first, morbidity and mortality burden of LRI substantially reduced over the past 3 decades, and the most substantially decline was observed in young children. Slower decline was observed in older adults. The absolute counts actually they went up due to the aging population. And bacteria remain the main causes of LRI morbidity and mortality despite the increased vaccination coverage, mainly PCV and HIP. And highest morbidity and mortality was found for pneumococcus. Mycoplasma had a really high incidence rate, and for a high mortality rate, it was Staph aureus on the rise, and Klebsiella pneumonia, that's there. And for morbidity and mortality burden by different viruses, it is substantial, but compared to bacterial causes, it is still under-detected. I think here, although this is an influenza conference, but I'm glad to see that, we will say from influenza to other infectious diseases, which is good because we really need to, kind of escape from the shadow of influenza in terms of surveillance, right, or in terms of how we view respiratory infectious diseases, and really need to establish multiple pathogen surveillance with the new techniques, and also which will definitely help towards better preparedness for disease X and highlighting the importance or valuing the importance of One Health. And lastly, as we saw in the last few slides, little is known about the interactions of different pathogens of LRI. And that's all of my presentation. Thank you.
非常感谢李友教授他这个。
Much. You proceed from the global LRI, those problems with multiple pathogens, especially entering the aging society. You give us a very good reminder or warning. So to take some limit, let's invite our last speaker. Thank you for your patience. Professor Tan will moderate the last report.
Is the chairman of the Department of Medicine and Therapeutics, and the Stanley Ho Professor of Respiratory Medicine at the Hong Kong Chinese University. Professor He is going to talk to us about comparing clinical severity and treatment modality of influenza, SARS-CoV-2, and RSV infections in adults. Professor He.
Thank you, John. So I've been assigned the task to compare the clinical severity of the three conditions: influenza, SARS-CoV-2, and RSV in adults. So this topic is actually quite well addressed by this paper from the US CDC group. They actually performed a prospective multi-center cohort study of adults admitted to the hospital with the three conditions. That involved 25 hospitals in 20 US states. And the investigators were interested to look at the disease severity amongst adults hospitalized with RSV and compare it with the severity of COVID-19 and influenza disease adjusted by the vaccination status. And you can see on the right-hand side, during the study period from 2022 to May 2023, there were a lot of COVID-19 cases and some influenza cases and relatively less RSV cases. Now, in terms of the demographic, the patient with RSV appear to be younger than those with COVID-19. And then if you look at the immunocompromised conditions, patients with RSV appear to have more immunocompromised, relatively more patients with RSV have immunocompromised conditions compared to those with influenza. And the rest of the demographics are largely similar. And then we look at the symptoms reported by the patients. You can see that fever appear to be more common among patients admitted with influenza, whereas more patients with RSV reported dyspnea. And also, you can see the RSV patients, 83% actually received the COVID-19 vaccines, and 45% received the influenza vaccines. And interestingly, those admitted with influenza, only 36% received the influenza vaccine before, but about 73% actually received the COVID-19 vaccine. Now, when we compare the severity of RSV in terms of the in-hospital outcomes against COVID-19 by vaccination status, you can see that overall, most of the clinical outcomes reveal disease severity among patients with RSV that was largely similar to those unvaccinated, with unvaccinated COVID-19 and unvaccinated influenza. But the clinical outcome severity appear to be much higher among the RSV patients compared to those patients with vaccinated COVID-19 and influenza. So this refers to the whole cohort, all the adults aged 18 years plus. You can see the odds ratio is actually a lot higher among the vaccinated subjects compared to RSV. When the investigator actually focused on older adults aged 60 years, basically they observed similar findings when comparing RSV severity with COVID-19. So the RSV certainly is more severe in terms of the in-hospital outcome compared to those vaccinated with the COVID-19. And the same occurred for those who received influenza vaccine. So when we compare RSV severity to those influenza patients by vaccination status, you can see quite similar results. So RSV disease, RSV more severe compared to patients who have received the influenza vaccines. The investigator also looked at the peak respiratory severity, which was classified by an ordinal scale. So it can range from 1 having no requirement for oxygen, and number 2 requiring conventional oxygen therapy, less than 30 liters per minute. And then those who receive high flow nasal cannula, more than 30 liters per minute, or NIV. And then those who require invasive mechanical ventilation and death. So when they evaluate the peak respiratory disease severity, patients with RSV had higher overall severity compared to the unvaccinated COVID-19 group and the unvaccinated influenza group. However, it is substantially higher overall RSV severity when they compare against the vaccinated COVID-19 group and also the vaccinated influenza group. The investigator also looked at the outcome within the subtypes, for example, RSV type A and type B, and they observed very similar outcome. And there were more than 3,400 patients with identified SARS-CoV-2 lineages. And BA.1 was the least frequent Omicron lineage. There were only 217 subjects, but they demonstrated the greatest severity. And then between 2020 and 2022 to 23, there was emergence of the Omicron variants with milder disease, and there was also increase in population-level hybrid immunity from infection plus vaccination, and also better clinical care, including the use of more antiviral. So as a consequence, the severity of COVID-19 has declined, and the severity of RSV is relatively high compared to COVID-19 from the Omicron lineages. The investigator also looked at the influenza subtype, comparing H3N2 and H1N1 during the study period. H3N2 predominated the analysis period, accounting for about 73%, but there was actually lower or similar severity compared to influenza A, H1N1. So this study actually provides very interesting data, and the findings suggest that before RSV introduction in the US, RSV disease was at least as severe as COVID-19 or influenza among the unvaccinated patients, and more severe than COVID-19 or influenza among the vaccinated patients hospitalized with those diseases. Now, in terms of treatment modality, for RSV, there was one controlled double-blind study of young adults published in 1983 involving 16 healthy male volunteers. They were given intranasal RSV inoculation, followed 2 days later by aerosolized ribavirin or water as control for 12 hours per day for 3 days. And you can see on the right-hand side upper corner, there was antiviral effect noticed after day 6. So the group that received lipolysed ribavirin had reduction in the viral load, but those who received water continue to have increase in the viral load. There were also improvement in systemic symptoms and fever, but no difference in terms of other minor respiratory ULTI symptoms. Now, aerosolized ribavirin, although with approval for use in hospitalized infants and young children with severe lower airway disease caused by RSV, it's rarely administered because of the unfavorable safety profile, teratogenic potential, and also quite questionable clinical efficacy. In terms of antiviral treatment for adults with RSV, there was no RCT data. So a lot of the treatment is based on expert opinion. So for example, Michael Eisen actually provided a very good review in BMJ in 2019, and also recently in UpToDate. For the adults, basically, the treatment is mainly supportive. And I have also tried quite a number of adults on ICS formoterol, which is a fast and long-acting bronchodilator, plus or minus oxygen for bronchiolitis with quite good response. And for the immunocompromised patient, antiviral therapy should be reserved for those who are severely immunocompromised. For example, those who have leukemia or hematopoietic stem cell or lung transplant recipients. For the hematopoietic stem cell transplant recipients and those with leukemia, the risk, the RSV pneumonia actually has a mortality risk of about 80%. So Mike is of the opinion that it is advisable to initiate therapy even though the symptoms were confined to the upper respiratory tract. If you wait till symptoms of lower respiratory tract develop, then the benefit would be not as good. So if treatment is initiated, Michael recommend combination treatment with ribavirin plus IVIG. And high titer RSV immunoglobulin may be used instead of IVIG, but it is often not available. And there were uncontrolled trials suggesting that combination therapy with liberalized ribavirin and IVIG is associated with improved survival in adults hematopoietic stem cell transplant recipients with RSV infection. However, aerosolized ribavirin is generally avoided because of the difficulty in delivery and also toxicity associated with the administration. So oral ribavirin appears to be a reasonable alternative to liberalized ribavirin. Professor Hainan has nicely summarized the efficacy of oral antivirals in experimental and natural RSV infection. So there are quite a number of agents targeting either the fusion protein, large polymerase protein, or the nucleoprotein. Zero here means that there was no effect on clinical recovery. So you can see the prisutovir and also the other agents, basically no beneficial effects in adults in terms of clinical recovery. And some studies actually were stopped. And then there's valmetovir with some reduction in the duration of symptoms in outpatient adults, with also some dose-related antiviral effects. And then this agent, EDP 938, no beneficial effect in outpatients, but there was some modest antiviral effects. Now, there are also other antiviral agents that may have some efficacy for RSV, but we need more clinical data. For example, sirosovir, which is a F protein inhibitor, remdesivir, and also molnupiravir. We need to have more clinical trial data. For treatment of COVID-19, there is a very good summary by the WHO. So for those who have non-severe disease with risk factor for high risk of admission to hospital, of course, we have Paxlovid or molnupiravir, depending on whether the patient has any risk of drug interaction. You may also consider remdesivir. For those who have more severe disease requiring supplemental oxygen, of course, we would use IV remdesivir. But if they further progress requiring more oxygen or even ICU support, then we need to use immunomodulating agents, including steroid, IL-6 receptor blockers, and baricitinib. Professor Hainan has already given a very nice lecture on the antiviral for influenza, so I'm not going to repeat, but I just want to highlight that, for example, oseltamivir, we have been using it for inpatients for quite a long time. And recently, WHO actually has a recommendation in draft being reviewed. Apparently, it will come out in about 4 weeks, according to Dr. Tim Ueki. And there is actually conditional recommendation for the use of oseltamivir for severe influenza. And for baloxavir, which is a more potent antiviral agent with greater efficacy against influenza B, the WHO guideline also recommend baloxavir for high-risk persons with non-severe influenza. And Dr. Tim Ueki is going to give you a more detailed presentation on the WHO guideline tomorrow with all the details. Now, how about higher dose of neuraminidase inhibitor? Well, about 10 years ago, we actually compared double dose of oseltamivir compared to the conventional dose for treatment of influenza A and also B. And we found no advantage of using double dose compared to the conventional dose in terms of clinical outcome and even the virological response. However, there was improved viral clearance using double dose for influenza B. And that is probably because the IC90 for influenza B is a lot higher than A. So if you give double dose, you have better viral clearance response. At the end of the treatment, after day 5, we noticed 40% of the patients were still positive after 5 days of treatment. So the implication is that the therapy for more than 5 days would be required in the severe cases. And then Jeremy Farah also reported in 2013 RCT involving the Southeast Asian ID network with cases of seasonal flu and some avian influenza. And they also noticed no difference in viral clearance or other endpoints between standard dose versus double dose. And then Kumar also reported some time ago the triple dose against the conventional dose. He noticed more patients on triple dose were PCR negative compared to those who received standard dose on day 5. The triple therapy have also been tried. So this was reported by John Bagel in 2017 using oseltamivir, amantadine, and ribavirin combination. He noticed that 40% of the patients in the combination group had detectable virus at day 3 compared to 50% who received monotherapy. However, for the clinical endpoints, there was no benefit in multiple clinical secondary endpoints, including median duration of symptoms, etc. So, and there were also some side effects on the triple therapy, more GIT related in the combination group compared to the monotherapy group. And there was also a study comparing 2 cohorts enrolled in prospective studies of oseltamivir monotherapy or combined favipiravir, oseltamivir. So these were hospitalized adults with severe influenza with respiratory failure. And the combination treatment led to improvement with 2 points drop in the 7-point ordinal scale. And the proportion of undetectable viral RNA on day 10 was also higher in the combination group compared to the oseltamivir group. And there were no significant differences in terms of mortality or other outcome. So the combination of favipiravir and oseltamivir may accelerate clinical recovery compared to oseltamivir monotherapy for severe flu, but this strategy should be formally tested in a large-scale RCT. And Fred also alluded to the Flagstone study showing that NAI plus baloxavir actually shortened the duration of viral shedding. But in terms of clinical outcome, there was no difference between the 2 groups. However, the limitation of the study was that only 39% of the subjects received baloxavir within 2 days of symptom onset. So that may be the reason. Okay. So this is my final slide. Thank you for your reminder. So in terms of influenza, oseltamivir effective in reducing mortality in hospitalized patients if given early, and these are largely based on cohort studies. Baloxavir is more potent with greater efficacy against influenza B. Combination antivirals so far have shown lower viral load more quickly, but do not improve clinical endpoints. And this is more likely due to cytokine dysregulation. So the role of immunomodulating agents also need to be assessed. I think we also need to see more RCT on timely use of antiviral combination, for sure. For COVID-19, we have the oral agents Paxlovid or molnupiravir for early infection without hypoxemia, and we use remdesivir for those who have more severe disease. For RSV, currently, just based on expert opinion, ribavirin and immunoglobulin should be reserved for the immunocompromised subjects. Thank you for your attention.
Thank you, Professor Hui. This extensive review of treatment, RSV, and influenza, and so on. So we will close for this morning's activity for the conference, and we will now proceed to have lunch. And because of the time, but we will have to come back at 2, which is we have 1 hour for lunch. Come back at 2, we'll start the session for the afternoon at 2 o'clock in the afternoon. Thank you very much.
好，咱们楼下那个自助餐2点，好，下午2点。
请各位领导、专家落座，大会即将开始。
Distinguished guests, please take your seat.
All right. Dear delegates, good afternoon. I guess you are all our good friends for the afternoon session. Together with Professor Zhang Yanping, I'm going to moderate the afternoon session, which is the keynote report for the afternoon. Altogether, we have 5 presentations. We have Professor Zhang Wenqing from Luzhou, Plenary William, Maria, and Eve, who will actually present. I'm going to moderate for the first 2. Zhang Yanping will actually moderate the latter 3. First one, I'm going to give the floor to Professor Zhang Wenqing, who's actually from WHO. And for Zhang Wenqing, he has been engaged into WHO for many years. Previously, she was actually the staff from the Chinese Preventive Medicine Association, and later in WHO. She has been working there for about 52 years, and also as of now, she has done a lot of work related to the COVID-19 response and monitoring. And also in China, she has also done a lot of work related to the iodine deficiency, as well as many other diseases. She's very familiar with the China situation, and she graduated from Zhejiang Medical University, which is right now very famous. And she obtained her bachelor's degree in Zhejiang Medical University. And she's actually working in Geneva now, and she'll be talking about extending influenza surveillance to other important respiratory infections in WHO Global Influenza Surveillance and Response System, GISAS. That's going to be her topic. Please, the floor is not yours. Please play the video clipping.
Good morning, the Chinese citizens. Thanks for the invitation. A great pleasure to present in the 2024 World Influenza Conference, also remotely. I'm Wenqing Zhang, the head of the Global Influenza Program in WHO headquarters, Geneva. I was asked to talk expanding influenza surveillance to other important respiratory infections in the WHO Global Influenza Surveillance and Response System, GISRS, or GISRS. GISRS is a global network driven by public health needs for influenza. It is a global foundation of influenza surveillance, preparedness, and response for more than 70 years. Currently, the system comprises 160 institutions in 130 member states. The Chinese CDC is a WHO-recognized National Influenza Center of GISRS and a WHO-designated WHO Collecting Center for Influenza in GISRS. The network has institutionalized and functioning capacity in countries with laboratory and disease surveillance integrated, response mechanisms exercised in every seasonal epidemics, and with enormous commitment from member states and support from global agencies and partners. Since its birth, GISRS has been coordinated by WHO via the Global Influenza Program. The participation in this network is voluntary, but need to go through official WHO process and to function under the WHO terms of reference. Over 70 years, the GISRS capacity and capability for influenza has been continuously developed and strengthened. At global scales and coverage, the network uses various standardized tools, generates data, analyzes data, including assessing associated risks, and informs policies and recommendations. GISRS is truly an end-to-end integrated global surveillance system for influenza. Since COVID-19 pandemic, WHO has been adapting and aligning the core capacities. It is obvious that the world needs to address all hazards of public health importance, Meanwhile, also need to address effectively specific threats and settings. In this context, expanding GISRIS perfectly fits into this development. Although GISRIS expansion started long before COVID-19 pandemic. Expanding GISRIS has been an ongoing function of GISRIS itself. It started with seasonal influenza in 1952. Since 1997, avian, variant, or swine influenza, pandemic influenza have been added to the GISRIS platform. Since 2015, respiratory syncytial virus or RSV has been added into this system. And since March 2020, SARS-CoV-2 has been added to the influenza platform. Looking at these expansions, they were all driven by arising public health needs, from vaccine R&D breakthrough which need evidence to guide vaccination policy, to monitor SARS-CoV-2 and co-circulations of respiratory viruses. For all these, GISRIS offered a functioning global platform with capacity and capability built in countries globally. The recent addition of SARS-CoV-2 serves a refreshed proof of concept for integrated surveillance of respiratory virus by GISRIS. In the World Health Assembly in May 2022, Member States commended GISRIS for its rapid leveraging for COVID-19 pandemic response, its integrated surveillance, as well as the Pandemic Influenza Preparedness Framework, or PIP framework. Member States, in their interventions, supported loudly the development of GISRIS Plus or expanded GISRIS, and offered advice on way forward. Among those, a couple member states cautioned the expansion process that it should not undermine or weaken the existing GISRIS system and its crucial role on influenza. In addition, non-influenza virus sharing should be subject to Nagoya Protocol and other national access and benefits sharing legislations along the expansion of GISRIS. Before we move further, let's clarify some terminologies. After the World Health Assembly 2022, GISRIS Plus was renamed as Expanded GISRIS after broad consultations. Expanded GISRIS is also shortened as e-GISRIS, and expanded GISRIS surveillance means integrated surveillance of GISRIS. One reason for the success of this long-standing global network is the collaborative spirit and buy-in of the entire system. On its 70th anniversary in 2022, the Global GISRIS meeting concluded its high-level strategy towards its 100 years, i.e. 3 pillars. One is to enhance influenza surveillance preparedness and response. One is to advance the ongoing integrated GISRIS surveillance and develop GISRIS Plus, or now we call it expanded GISRIS. And the other is to strengthen GISRIS system. The meeting also defined its operational model, i.e. by engagement with external resources, connecting with them so that they are affiliated and collaborated. All of these are concerted towards the global goal of respiratory surveillance, preparedness, and response. 1 year later in Abu Dhabi in 2023, the GISRIS Global Meeting further shaped out the path of GISRIS towards its 100 years. It concluded with the primary objectives of the expanded GISRIS, i.e., to monitor epidemiological and clinical characteristics and biological patterns, to provide evidence base to inform public health actions, and to function as part of the early warning surveillance. The secondary objectives of the expanded GISRS were also defined through the meeting. Meanwhile, the meeting also highlighted essential actions for WHO, we'll come to that later, and also for countries. One essential action for countries is to review and reflect its surveillance inside the country. Which part is must have, which part is nice to have, which part is strategic reserve, and which part is already existing, which part need to be sunset, transitioned, or reproposed. With all this happened or happening, let's have an overview of the expanded GISRS. The overarching goal of expanded GISRS is a stronger GISRS with an efficient global system of integrated surveillance and response to influenza and other priority respiratory viruses with epidemic or pandemic potential. Always, expanded GISRS is still GISRS. Now, the very next question is, what is the expanded part of GISRS or the scope of e-GISRS? Here is the definition. Priority respiratory viruses are defined as those that are known pandemic threat or are an emergent novel threat of pandemic potential or are unknown epidemic threat where surveillance can directly inform prevention and control. And it can be integrated effectively and seamlessly into the existing GISRS operation. So from the definition, we know that SARS-CoV-2 and RSV are under the scope here. They are a set of principles that will guide each and every decision and step of GISRS expansion. First is the people. People is always in the center since the beginning of the network GISRS. It is the life of the network in two folders. One is that GISRS members is the spirit of the global system, as always. And second is saving people's life is a fundamental goal of GISRS, as always. Then, the public health needs, it is a driver of GISRS. A point here is that the expanded GISRS will add, but also will remove additional viruses, scale up, but will also scale down surveillance operations for certain viruses, and will adjust surveillance methods according to public health needs. Country ownership, it is the key to the sustainability of the global system, as always. And the global coordination is the key to the optimal outcome from operation of the global system. This is decided by the nature of the respiratory viruses and the varying status of technology development. And capacity building, it is the energy or the power to enable the system functioning in a proposed for, measured, and sustainable way. So now, with the outlines of the design of expanded GISRS in mind, let's have a look at where we are now. So, of 194 member states, 178 have already integrated SARS-CoV-2 into the influenza system as to date. The remaining 16 member states, as listed on the right side, as we can see, mainly small islands. So for this, the WHO Global Influenza Program is working with regional offices on tailored strategies to address the needs from these small islands. Now, let's take a glance at the expanded GISRS virus detection capacity. which has been monitored through the WHO's annual EQAP program of Gizzard. Last year, the EQA panel comprised inactivated virus of influenza, SARS-CoV-2, and also included an ISV as control. 90% of the participating laboratories demonstrated all correctness for influenza, while the percentage is much higher for zoonotic influenza. 88% all correctness for SARS-CoV-2 and 98% for ISV. This year, the EQA panels are being distributed for PCR virus detection. Also, a panel for influenza antiviral susceptibility monitoring is available. In addition, a panel for influenza sequencing is being piloted. For ISV, EQA panels this year for virus detection and sequencing are being distributed. Via integrated surveillance of expanded distress, the priority respiratory viruses are put together to generate relativeness of surveillance, monitoring, and assessment. Here is an example of influenza and SARS-CoV-2 circulation in community. Such relativeness can support national policies, especially in resource-scarce countries. So, what is in the pipeline then? Although the integrated surveillance of distress has been ongoing in the past dozens of years, the process of expanded distress now is to strengthen and, very importantly, to standardize, to officialize, and to sustain varying components of the expanded distress operation. For this, a strategic priority list and a roadmap, as well as terms or reference of expanded distress, are being developed. Talking about distress terms of reference, those for influenza are already existing, although they are mainly on laboratory surveillance and include those in the Annex 5 of the Pandemic Influenza Preparedness Framework, PIP framework. Currently, one component on seasonal influenza is under revision to reflect the Nagoya Protocol and national ABS legislation needs. For expanded gizzards, laboratory terms of reference for ISV, for SARS-CoV-2, and novel virus, as well as epTORs, are under development. In closing, for influenza surveillance, preparedness, and response, there is a global influenza strategy, which was adopted in the World Health Assembly 2020 by member states. Expanding gizzards falls heavily under Objective 2 here, surveillance monitoring and data utilization, although it is a foundation for all other objectives. So there are still 6 years left to work towards achievement of the goals and strategic objectives set up in the global influenza strategy. So, by 2030, jointly with you all, Gizzards aims to achieve 100% global coverage, so that Gizzards becomes truly a highly functioning, fit-for-purpose, country-owned and globally coordinated global surveillance system. Here, coverage means functional coverage. For small islands, they may be alternatives rather than designating a national influenza center. By then, outputs from Gizzards will include high quality and capacity of lab functions, timely and quality data reporting, and surveillance and analytics tools, their utilization, and results being generated and distributed timely. And by then, the outcome from Gizzards will include closest possible real-time monitoring and high-quality projection, and best possible risk assessment and countermeasures. So colleagues and friends in the World Influenza Conference and more globally, Let's work together on the frontal influenza and other respiratory viruses to save more lives at both interpandemic and pandemic or emergency periods from influenza and other respiratory viruses. Acknowledgement goes to the WHO's Global Influenza Surveillance and Response System, GISRS, GISRS associated national, subnational surveillance systems, countries hosting GISRS institutions, WHO Global Influenza Program in WHO headquarters and WHO regional offices, as well as GISRS partners. Thank you very much for your attention.
好，大家给点掌声。虽然他也听不到啊。
Not here, very clearly stated. Apart from influenza, we need to monitor so many other diseases. I heard that WHO now has some difficulties in financing, so they didn't increase the burden for different countries. If you have this experience, capacity, and funding, it will be surely beneficial to expand the surveillance. But I think still there is a gap to treating real patients. Now let's go forward to the researcher from the Peking Union Hospital Medical College. And the Vice Director of Pathogen Prevention and Control, Dr. Feng Zhao, is also the commission of the New Democratic Association. He's also Hainan CDC's outstanding representative. He's also the WHO Novel Influenza Vaccination Warrant Value Evaluation Committee's expert and one of the members of National Expert TAC, also the CPMA Vaccination Association's director, mainly focused on epidemics and population medicine. She published a lot of important papers and won 8 provincial and ministerial level awards. Today he will talk about epidemiology and incidence of influenza co-infection with common viral and bacterial respiratory pathogens. So very related with the previous speaker.
Bacterial respiratory pathogens，有请冯路钊博士。
Thank you, Mr. Liang. Distinguished experts. Dr. Zhang Wenqing introduced GISRS and global surveillance strategies. I will supplement something. So this is in line with the respiratory infectious disease, multi-disease surveillance, and joint prevention and control. Compared with conventional hospital-based or public health institution-based lab test approach is a little different. The normal testing model, of course, respiratory pathogen detection and surveillance is very important. We can surely understand that because in one season, different pathogens may have co-infection, and maybe these infections cannot be differentiated without detection in terms of their clinical symptoms and they have very similar manifestations, but actually they have different pathogenic mechanisms and different treatment models. Thus, it's quite important to have this multi-pathogen detection. It can help us to carry out a rapid diagnosis and treatment. Of course, in China, the respiratory multi-pathogen surveillance network in China, as introduced by Dr. Li Qing, is based on the previous influenza surveillance network. We initiated the multi-pathogen surveillance network This year we have seen some trend. Here I'd like to introduce the DTC testing, or direct-to-consumer testing. So in short is DTC testing. It's based on some in vitro diagnosis and medical devices and directly to consumers or general public. Predominantly for clinical disease surveillance, including the blood glucose surveillance for diabetes patients. It can lower the cost of care. And during the pandemic of COVID-19, like the antigen testing of COVID-19 is a form of such testing. Compared with medical institutions testing, it can move the checkpoint forward and can reduce the waiting period and can spot the virus circulation earlier. So we are cooperating with Meituan Health to launch this project in 2023. August, Meituan initiated the multi-pathogen DTC testing program covering 12 respiratory pathogens like mycoplasma and some respiratory viruses. The model is consumers can use the online app to place an order and get the testing service. And then the delivery man will give the testing kit to the homes of the citizens. They will take the samples like the oral or nasal swabs by themselves, and the delivery man will give the samples to the third-party labs. On average, within 3 to 4 hours, they can get the test results back, all the 12 pathogens, which are negative, which are positive. And Meituan also have online doctors. According to the testing result, the doctors can give the patient some drugs and some suggestions. The project was initiated in Beijing and Guangzhou in August and then expanded to Shenzhen, Shanghai, Nanjing, Hangzhou, Chengdu, 7 cities. So it's a rather timely test result. We compared the model taking influenza and COVID-19 with as an example. You can see the blue line is the D2C testing. The upper one is influenza, the lower one is COVID-19, and we can see the positive rates trend consistent. And compared with conventional surveillance, it can be more timely and more and earlier we can find the circulation status of the disease. So you can see this kind of approach can be a very good supplement for our current surveillance system. And we also analyzed from last October to this May the operation situation of these. You can see in 7 cities there are more than 500,000 people get tested. And it's not paid by the government. Actually, it's paid by the patients themselves. Thus, for the government side, the cost is very low. And here, most 85% of the patients have shown at least one pathogen positive, among which bacteria positive, like the Staphylococcus. This share is very high. And another 41% positive and non-bacterial infection, including virus or mycoplasma. So it shows the share of such infection is very high. And we can see the general positive rate, the top 3 positive rates. SARS-CoV-2 have 9.2% of positive rate, and then influenza B, and then influenza A. So for different cities, the situation also varies. For example, in Beijing, have a high detection rate of RSV and IFV. And in Guangzhou, it's mainly IFV A, and M pneumonia and the HADV. So the situation of virus also differs in different regions, and according to the different times, we can see the models of pathogens also have some differences. Like in Beijing, from 2023's August to now, the main peaks were caused by the Mycoplasma pneumonia, and then influenza A and influenza B, COVID-19 and rhinovirus. But in Guangdong, it's first Mycoplasma and then influenza A and then adenovirus. So the adenovirus has a more higher detection rate compared with Beijing, but it has no rhinovirus situation like Beijing. And in Shanghai, since December, we find the situation is rather similar with that of Beijing. And as I said before, if we take influenza as a topic, we usually can detect influenza virus together with other pathogens. So the singular influenza virus detection rate for children under 18 years old is 11%, and in adults between 18 to 59 years old is 20%. So we can see the detection positive rate for influenza virus in adults group is higher. At 82% of influenza positive population, we can see 81% of them have co-detection of influenza and other respiratory pathogens. In children between 0 to 5 years old, 3.6 have RSV virus, and also 7% have HADV. And also in children between 6 to 17 years old, there are 2.8% co-infected with mycoplasma. And in the elderly above 60 years old, 8.2% of them co-infected with COVID-19. But more commonly is the co-infection with some bacteria. So we can see this surveillance model, although it has been operating for half a year, it's a exploration of respiratory multipathogen surveillance mode. This D2C testing can help us provide us timely feedback of results. It can guide rational use of anti-infective drugs. And also it can reduce risk of cross-infection caused by waiting healthcare facilities. Here I'd like to add something like last year during the peak of pediatric respiratory infection. In some big hospitals, there was long queue of sick children. They need to wait here for several hours or even dozens of hours. So it may have a high risk of cross-infection, and it have very huge burden on the parents. And also, during the peak time, the medical institutions' capacity cannot satisfy all the testing needs. So this D2C model can serve as a supplement to provide diagnostic testing outside the healthcare facilities. And if we include this into our national surveillance system, for example, can we take it as a channel of our multi-channel data? We need to consider some ethnic issues like the consent and anonymous data. I think it can be a new source of data of surveillance. In the future, here are some recommendations for improving D2C detection patterns. For example, now different all of the labs are the third party that we can further improve their quality control and consistency. So the D2C testing must be safe, effective, and traceable, accurate, and need to satisfy the criteria, meeting the criteria specified in regulations, clinical guidance, and international standards to guarantee the quality and efficacy. And also for China, this testing model, I think we can encourage them. It can serve as a way to benefit people. And then we can unite some healthcare professional associations and regulators to carry out management and quality control. So this is a very good way of exploration. And in the future for the D2C testing, we also need to carry out scientific education to help the public perform D2C testing and interpret the results correctly. This is the first project D2C cooperating with Meituan. The second one is based on our project in Chongqing, Wanzhou. It's based on a medical facility, but it also have community investigation and health surveys investigation. In this way, we can estimate the incidence rate of influenza and the hospitalization rate. It's quite simple. According to WHO's influenza disease burden guideline, like the pyramid-like picture, we have the health record from the medical institutions and take samples to test for influenza, and then we carry out the investigation of social community health service use. And then considering the sensitivity and specificity of the influenza, then we can deduct the incidence rate. So it has three parts. First, hospitals, clinic, acute respiratory infection, and hospitalized respiratory infection. And second is other medical institutions. Apart from the health record we collected, we use big data to see all the hospital visits. And the third part is health service utilization investigation. Based on the investigation of hospitals, as I said, we are cooperating with Chongqing Municipal Disease Control Center. In Wanzhou District, we selected 7 medical facilities, 1 3A, 2A hospitals, and 4 community health service center, and then use AI and SARA samples. We include it into our surveillance system and select part of the samples of the cases and give them questionnaires and take samples and send to labs. This is the procedure in the hospitals. Also, in medical institutions, apart from the records, we're also using the electrical health record, and we trained a model. It's a binary encoding machine, and we also use with this evaluation, the sensitivity and the specificity are both very high. So apart from the 7 hospitals data, we for the whole Wanzhou districts, their medical institutions use this method to recognize their hospital visit and ARI number. And thirdly, we carry out the health service utilization investigation. So apart from the 7 medical institutions, we want to see what's a published-based situation in 52 states. We take 52 communities, and in each communities we take samples of several hundreds of people to estimate in different communities and different districts what's the share of their residents seeking medical services in the hospitals, and then we can deduct the incidence rates of influenza. So it's a 3 parts. First, research on the hospital's health record and the extraction of medical institutions information, and plus the health service investigation, then we can estimate the real influenza cases and the incidence rates and hospitalization rates. From the October 2021 to August 2023, we included 6,800 patients. And then we can see the shares of different hospitals. Here, in the 6,000 patients, 14.5% have positive influenza test results. And most of them are between 15 to 50 years old.
So for the children, it is also here, and also we also have the specifications related to the clinical symptoms and manifestations. Let's look at the estimated instances between the season of 2021 to 2022, out of 9,829 out of 100,000, whereas hospitalization 83 out of 100,000. And between 2022 to 2023, instance of influenza is about 12%. And hospitalization somehow for the second season as compared to season 1, it's a lot higher, which is 441 out of 100,000. That's the estimation apart from the surveillance of the influenza. For those diseases and viruses, we have conducted the multi-pathogenic detection, just like I have presented just now, apart from the influenza, right? The adenoviruses, RSV, rhinoviruses, as well as the metapneumoviruses, all these. In the past 2 seasons, there is some co-infection and co-circulation. So in the future, by adopting the similar ways, we can estimate the instances of RSV and many other similar pathogens. We can actually calculate the estimation regarding instance as well as hospitalization on a population basis, and also for the bacterial detection. We have the Streptococcus pneumonia, 33.3%, Hib 33.4%, and also Streptococcus aureus, and also similarly a high detection rate. So just in a nutshell, to sum up for these two, I think that we would like to encourage that based on the existing surveillance network as well as the innovative direct-to-patient testing models, we can actually establish the network encompassing different diseases types, and so that we can provide the evidences to inform the integrated control and prevention of different infectious diseases. And also we can actually adopt the traditional assay monitoring surveillance with the electronic hospital records to inform our decision making. At the very last, I would like to thank all the partnership for the great contributions to the studies. You are all welcome to visit our School of Population Medicine. Thank you. All right, thank you, research fellow from Luzhou. Next, we should like to give the floor to Professor Peng Liwen Liu to talk about his presentation. Professor Peng is actually the world's famous virology scientist and the scientist of public health. He graduated from Oxford University in 2001. He joined into Hong Kong University of Hong Kong. He's actually now the chair of a School of Public Health in University of Hong Kong. He has been studying the emerging viral diseases and infectious diseases for more than 20 years, and now he is engaged into the MERS and SARS-CoV-2 studies. He will be talking about the effectiveness of genomic sequencing and surveillance on global dissemination of SARS-CoV-2. 非常感谢。
Our team basically worked on emerging infectious disease, in particular viruses, for the past 20-odd years, and now talk about H5N1 in 1997, pandemic H1N1, H7N9, and then SARS, MERS, and COVID-19. So we have been working on these emerging infectious disease using multidisciplinary approach. We have so many colleagues, Greek scientists work together to try to use this approach to try to understand these pathogens. And we work closely with WHO, FAO, and other healthcare organizations. The overall aim is try to develop evidence-based control measures to try to prevent the spillover or try to mitigate the risk. And then we are now is one of the WHO reference lab for H5, COVID-19, and COVID-19. Right now, today I'm not going to talk about all these findings, but I just want to focusing on using NGS, next generation sequencing, to understand the spreading of the disease in the community. So, I mean, in the past few years, we have been trying to use molecular epidemiology to understand the transmission of COVID-19, right? And we try to sequence these viruses for the patients so that we can able to establish epidemiological link between clusters so that we can understand the transmission better. Right now, for the first 2 years, we did a great job. So we managed to try to suppress COVID-19 spreading in the community. So we don't have that many cases. So we can manage to try to sequence about 25% of all cases in Hong Kong, including both imported and the community cases, so that we can have a good gist about the transmission pattern in the community. So that we know that a lot of the cases actually coming from, shown in green here, these are imported cases. They are coming from travelers. And then for those highlighted in blue, these are the local community cases. And we can tell that using this phylogenetic analysis, there were 3 major introductions into Hong Kong in the first 2 years, and then cause a super spreading event in Hong Kong. In fact, we can manage to understand the transmission of these diseases quite extensively. For example, we can basically try to show that aviation can facilitate transmission. We do find in-flight transmission of SARS-CoV-2 in the plane. We also managed to show that COVID patients can transmit the disease to their own pets. Also, the infection of SARS-CoV-2 in individuals could be possible. And in fact, we are using this NGS analysis to demonstrate this evidence. And in addition, we're also able to use these phylogenetics or genomic sequences to understand the transmissions in Hong Kong. So in particular, we managed to show numerous introduction of SARS-CoV-2 variants into Hong Kong. And we managed to show that some of these variants managed to try to spread within a hotel and thereby in the community. So these are all great science. But then what I want to highlight is not only about the scientific finding, we can use this finding to inform public health policy, like what kind of PPE that you need to wear, how you manage the pet, and how about vaccine policy, and also other like non-pharmaceutical interventions in the community. So all these findings can manage to inform public health policy, right? So that we can able to control the disease better. Right, I'll just give you 2 examples. One of them is one of the outbreak causing the 4th wave in Hong Kong in 2020. We know that there was an imported cluster in a hotel, right? As shown in here, imported cluster, and it caused a spreading in the community, in the hotel, and some of these infected individuals spread the disease into nearby regions, causing another 2 clusters in 2 places. And thereby, this disease spread into community and caused the wave 4 of COVID-19 in Hong Kong. And with this evidence, Hong Kong government also tried to develop another policy to try to control the imported traveler, so that they actually will be sent to a designated quarantine hotel, so that we can manage to try to monitor these individuals closely. The second good example is about the introduction of our Delta variants into Hong Kong through infected hamster. In January 2022, we managed to show that imported hamster, which were infected by COVID-19, SARS-CoV-2, managed to spread the disease in the pet shops. So that subsequently about 100 individuals acquired the infections. Again, using genomic surveillance, we managed to show that the virus was originally coming from infected hamsters, and actually there are multiple variants in this infected hamster, and they were all infected in Europe, and subsequently spread to the Hong Kong and caused a minor outbreak. Right, I mean, there was a huge implication about this, because for controlling the disease, like COVID, I mean, we have been doing a lot in controlling the transmissions within individuals, in the community. But now this evidence showed that maybe infected animal can be a vector for SARS-CoV-2, and so that they may able to move around from city to city, country to country, and facilitate this spreading. And there are now ongoing transmission of SARS-CoV-2 in some of the wild animal in US. So what I'm saying is we really have to take the One Health concept in controlling emerging infections. Right, now, the other thing that I want to highlight is using this phylogenetic data, we can manage to estimate about the SARS-CoV-2 transmission in the community. During the wave 4, basically introduction of Omicron, we know that there were about there were a lot of patients get infected by Omicron, but there were only about 1.2 million officially reported cases in Hong Kong, which we believe is underreporting. By using our genomic surveillance data, we do modeling, and then estimated that about 50% of the entire population in Hong Kong were infected during the wave 5. So again, using sequencing data, we can estimate the disease burden in the community so that we can have a more accurate information to provide to the government or other healthcare institutions so that they can have a better information to design their policy. Right now, talking about the transmission in the community, now I'm going to switch to an angle about the sequence, how to use NGS to understand the sequence diversity within an individuals. Now, I mean, in the early days, in early 2020, we managed to characterize some of the patients. We know that severe patients tend to shed longer period of time and then have a more higher viral load than mild cases. So we did ask ourselves, do individuals actually have different virus sequence diversity in different individuals? Like, for example, whether severe patient will have a more sequence diversity, viral sequence diversity than the mild cases? Or does the viral load affect the sequence diversity in the individuals? Right, so what we did is actually sequence several thousands of individuals and try to analyze the minor variants of these SARS-CoV-2 genomes. So, I mean, to cut the story short, what we can tell is this viral diversity within individuals have no relationship with disease severity and also viral load. So basically, we didn't find any clear correlation at all. But what we found is that the transmission bottleneck between individuals is very narrow, only 1 to 3 virions. So suggesting that only a few variants can able to pass from one individual to another individual. So we were quite interested about it. And then we also found out that, this is a good news for us, vaccinations did not affect the virus sequence diversity within an individuals. So which is absolutely good news for us because there were anti-science groups saying that vaccines can induce variants and then try to discourage people to be vaccinated. So I think this is a clear evidence, at least in our study, showed that there were no evidence to show that vaccine can drive the virus evolution, at least in the individual level. Right, now the other thing that we were very interested in is about the variants. Actually, some of the VOC, we found that, as shown in the left panel, some of the variants like Omicron and Delta, they tend to generate more sequence diversity than the ancestral virus. So again, maybe that explains why the virus actually start to evolve more and more. Right? Now, the other interesting features is, we know that when SARS-CoV-2 infect into individuals, they try to generate subgenomic messenger RNA. We found that different variants actually have different patterns in terms of the subgenomic RNA expressions. Without going into the details, I just want to focus on the right top panel engines. Some of the variants like Delta and Omicron variants, they seem to generate more engines than the other two. And we also found similar observation in other Omicron variants. Without going into the details, what I want to say is different variants actually tend to have different subgenomic RNA messenger expression profiles. But most importantly, we found very interesting features. We tried to compare the asymptomatic and the symptomatic case. What we found was ORF7A tend to have a difference. For those who have severe clinical outcome, ORF7A subgenomic RNA seems to express higher than the asymptomatic case, right? And then when we go through the literature, we found that ORF7A may associate with pro-inflammatory cytokine expressions, and also its expression can suppress autophagies. Was that related to the clinical observation that we found? We are working on that. But we do find that there were a couple of outbreaks in the world that caused by ORF7A deletion mutant. And what they observed was for those infected with this deletion mutant, they tend to have a milder diseases. So again, I don't know. Maybe this is something that we should go for and try to understand what ORF7A do in the patients. Right now, the other thing that I really need to go through it very quickly, we also try to work with engineers to try to do wastewater surveillance. We managed to use wastewater at the sewage treatment plant, and then thereafter we trace back and managed to show that some individual buildings could contain COVID-19 patients. And we managed to show that, like shown here, right? So you can see that there we found wastewater surveillance, found some buildings actually become positive in their sewage. And with this, we managed to use a community testing and able to find some of the COVID-19 patients in that building so that we can able to isolate these individuals and prevent the further spreading in the community. Right, and we also further use the genomic surveillance and NGS to try to sequence those viruses in the wastewater. And those graph on your right basically is the clinical data coming from clinical specimen. You can see there are variants of BA2.X and then BA4 and 5 as shown in here. And this pattern absolutely match with what we found in the wastewater surveillance. So when we do the sequencing, we found overlap. I'm suggesting that maybe wastewater could be useful for monitor the variants, the disease burden of different variants in the community. In fact, we can manage to show that there were individuals' variations within sites, suggesting that maybe some of the cluster, some of the area have the outbreak caused by another type of variants. Right, and we also use this type of wastewater surveillance to monitor flu and also monitor Mpox, novavirus, and rotavirus. Without going into the details, we believe that may be a potential for using wastewater to be used as indirect surveillance to monitor the disease burden in the community. But I would like to warn you that this is at the very early phase of using this wastewater to try to inform public health. There's still a lot to be learned from this type of surveillance. So don't try to assume this data absolutely correlate with the clinical observations. Right now, finally, for the last few minutes, I would like to just switch back to the surveillance in about COVID-19 in individuals. Right. For the first 2 years, we have been trying to do active surveillance for incoming travelers to Hong Kong, because Hong Kong is actually one of the highly connected cities in the world. I mean, in 2019, Hong Kong ranks as a 10th in terms of connectivities, in the aviation business. So a lot of people coming into Hong Kong, and of course, with this intensive surveillance in Hong Kong, we managed to detect a lot of VOC and VOI quite early than the other countries. So by testing this incoming traveler, we believe that may help us to try to monitor emerging variant better. In fact, we detect Omicron a day before WHO announced that this is important. Doing intensive surveillance in incoming traveler may have an edge to try to monitor the diversity of the viruses. So with that, we basically ask ourselves, if we want to do our global surveillance, should we do it in airport? Or should we do it only in the community? And then how many countries, how many clusters, what are the samples need to be tested? So nowadays, I mean, right now, our team is developing simulations using phylogenetic data and try to do simulation and try to come up with better strategies to do a global surveillance of emerging variants, or maybe the next pandemic variants as well. So what we did is basically we do computer simulations using different type of parameters like travel volumes, populations, infected cases, and so basically we just try to use different parameter and in our computer modeling. And on top of that, we use our phylogenetic data to try to fit the data to these simulations. Now, I don't have the data to you at the moment, but we do find some interesting observation. Number one, now this is typical finding that we will find in most of the country when the country have a moderate surveillance and detections. And also sequencing activity. So you will anticipate that if they do some level of surveillance, you will able to detect some individuals, both in the imported cases and also in the community, right? And a few days later, you start to find new emerging variant if you have some low level of sequencing activities. But if for countries, if they have a very intensive surveillance, they basically almost are able to identify the infected case and detected it and sequence it almost at the same time, because they actually test all the individuals intensively. And this apply for the imported traveler and also in the community, right? So this is a good thing to tell. Right now, if for regions or countries that have a very low sequencing activity or low surveillance, what do we expect is they will able to identify new variant or identify infected cases late, and they probably may not able to detect these new variants in the country being circulated for a while, right? So now in a simulation, we basically can tell you may need to adjust your surveillance and also your detections and sequencing activity in different time points, so that you can able to optimize your activity and detect the variant early. So now, as I said, we actually using a multiple parameters into this pharmacodynamic analysis. So I'll just give you another example is, so now we just try to adjust our sequencing capacity by reducing it or enhancing it, right? By reducing it to 10 times or 100 times to enhance it to 2 times. And you can see that if you reduce activity, sequencing activities, basically you will delay your detection of this emerging variant in your regions, right? This is what I expect. And then when you increase the sequencing activities, you will have a better chance to detect these emerging variants earlier. Now, this is only one parameter. And now we are also focusing on how much percentage of imported traveler and a community sample you need to sample. So if you go for all this sequencing activity to imported traveler, right, you will end up in this. Maybe you have a range about 10 to 30 days delay. But if you switch to the community, you can see that basically if you have a right matrix, right combination, you can able to detect it almost within the 10 days. So now these are the only 2 parameters. But right now we are actually asking us how many testing sites, how much sequencing effort, and where we should do the surveillance. So now we are using the global data to try to do such analysis. And the computer is running. I have this data just a few days ago, so I cannot able to share too much about this. Hopefully, maybe next time I can manage to tell you the framework of this global surveillance activity. Right, now this is my summary. I just mentioned about the epidemiology of SARS-CoV-2 using NGS. And then we also showed the wastewater surveillance seems to be a very useful tool to able to monitor the disease burden in the community. And finally, I'm just telling you that we are working on computation modeling so that we can able to optimize the surveillance activity at the global level, right? At the end, I would like to thank my colleagues from School of Public Health, from another department, and those people from China and overseas. Thank you very much.
谢谢范教授，内容呢信息量非常大。
Very informative. It gave us a lot of information for us in pathogenics and also in epidemiology. Thank you very much, Professor Pan. Next speaker is from UK, Professor Maria Zambon. She's a UK Health Security Administration. We know that their function is the surveillance of infectious diseases and provide professional microbiology and epidemiology knowledge and carry out the nationwide disease outbreak investigation and also help different infectious diseases risks suggestion to the government. For years, Professor Zambo has been in clinical virologist. She has a lot of experience in RNA virus and antivirus vaccines. Her own research team for a long time has focusing on respiratory disease virus and surveillance and comprehensive clinical project in many research on influenza and other respiratory virus. Today, she'll talk about integrating surveillance in primary care in the era of genomics. Welcome.
Good afternoon, everyone, and thank you very much to the organisers for asking me to provide an update on our primary care surveillance in the United Kingdom. So sorry not to be with you in person, but hope that the conference is going well and that this talk has resonance with other talks in the symposia which address the question of surveillance. I thought it might be helpful to start with the legacies of the pandemic, and one of the important things for all of us has been the significance and contribution made by data sharing, exemplified by our hosts in China sharing the very first sequence of SARS coronavirus on the 10th of January 2020 through the international sequence sharing platform of GISAID, which has well over 20 million sequences since that date from countries all around the world. But just as important as the concept of sequence sharing has been the agreements on information handling, since the complexity of the sequence that has been shared would have been made much more difficult for acting upon if there were not a common association or a common way of interpreting information. And I've included here a picture of the medieval concept of the Tower of Babel, where nations were unable to come together to complete an agreed structure because they could not have ways, or they could not manage to communicate with each other about how to do things. So not only information sharing, but also common ways of interpreting data. And I think we've also learned in the United Kingdom the importance of having adequately powered, simple trial designs to look at interventions as exemplified by the recovery study, which was set up very fast but with very simple endpoints, which allowed clear and unambiguous assessment of the value of different interventions. And the importance and significance of data linkage. And I include here New England Journal of Medicine paper from 2021, where within 3 months of the emergence of the Delta virus variant, we were able to assess through vaccine effectiveness and data linkage the impact of vaccination against the Delta variant. So the significance is not so much could we do the vaccine effectiveness, but the timeliness of that measurement over a very short period of time. Now, those legacies, I think, have translated to lessons learned within WHO, where the importance and significance of collaborative surveillance is well recognised. And going forwards, the intentions really are highlighted here: strengthened and integrated disease surveillance, improved diagnostic and laboratory capacity for pathogen and genomic surveillance, and collaborative approaches for risk assessment and response monitoring, which leads in a way to the concept of mosaic-based surveillance, meaning that there are multiple surveillance systems which together contribute to the whole, and that perhaps no one surveillance system provides an adequate sort of overview of all of the intelligence that's needed for managing. When designing surveillance for respiratory viruses, there are a number of priority objectives. We certainly need an early warning for change in epidemic disease. We need to understand how to monitor trends in morbidity and mortality, particularly when they tell us about our healthcare capacity problems. For example, the use of constrained resources such as hospital beds or intensive care units. And all of this should really be underpinned by a knowledge of what is circulating, when has it emerged, and anything that we might need to be concerned about in animal reservoirs. Thus, we have routine surveillance, trend analysis, analysis of healthcare capacity, and the ability to evaluate interventions underpinned by a strong genomic surveillance program. Surveillance program for influenza, which has been operational for many, many years through the GISRIS system, has provided a template of what we might need going forward for new viruses such as SARS coronavirus 2, or indeed when we introduce new interventions for viruses that we've tracked for many years, such as respiratory syncytial virus. We are, for influenza, in the era of genotype to phenotype. That is, we have switched from a historic analysis of virus isolates to analysis of virus genome, and we use the ability to isolate and culture virus to predict and confirm the observations that we have through genetic analysis. The things that we're particularly focused on by way of surveillance are the virus lineages, subtypes, and any amino acid signatures in any of those lineages which may be circulating as being relevant to disease burden. We're interested in the antigenic properties of viruses. We want to know whether circulating viruses match the vaccines that are being deployed in our populations. And we're certainly interested in any markers of drug resistance that have implications for how we use available antivirals. And as we have seen with influenza, the emergence of antiviral resistance can be a very significant public health challenge to monitor. Therefore, it is important to have genomic surveillance programs, or indeed surveillance programs, which allow the monitoring of these aspects also. Turn now to talk about the Sentinel surveillance in England, which is one of the oldest Sentinel systems in the world. It was established under Dr. George Watson in 1953, and true Sentinel surveillance really was established by Dr. Douglas Fleming in 1967, where over time he managed to introduce virologic sampling in 1993 with the concept of linked clinical and virological surveillance. Over time, the primary care surveillance has developed enormously in the United Kingdom, and on the map here you can see the different practices that are involved with their different electronic data capture systems. It should be said that this type of surveillance is possible in England because we have a National Health Service and every individual has a single registered doctor. The advantage of such a system, which covers a high proportion of the population, roughly 30% of the population, which is nationally representative, allows very near real-time reporting and a consistent approach over time for key clinical syndromes that are monitored, such as influenza-like illness linked to virologic sampling, so that you can see the clinical data linking to the matched virological sampling, or indeed another particular syndrome favoured by Dr. Douglas Fleming was the relationship of acute bronchitis or bronchiolitis to RSV in both children and adults, and over time that has proven its value, as we will see later. So we have had longitudinal reporting, clinical recording of influenza-like illness episodes since 1967. And over that period of time, we can see a secular trend decline in influenza-like illness reporting. The exact reasons for this, we don't have good explanation, but we can see the impact of the introduction of the age 65 plus influenza vaccine programs in the early 2000s, the introduction of the live attenuated childhood vaccine program in 2013, and the application of adjuvanted vaccines for the elderly in 2018. The start of virological sampling is shown here in 1993, and also the impact of two pandemics on this longitudinal data. What we learned through the virological sampling is that we have co-circulation of influenza viruses. Every influenza season is different in the subtypes of influenza which circulate and the proportion with which they circulate, but also the kind of political and clinical consequences which come every winter season. there is something different happening every year. Through this pioneering Sentinel primary care, we've also been able to develop the test negative design for estimating vaccine effectiveness using Sentinel influenza-like illness patients who are then swabbed. We know from their patient data whether they've been vaccinated or not, and we link together the influenza test positive and test negative results to give us a vaccine effectiveness estimate in the same population that are actually being sampled, providing a very efficient means of surveillance not only of circulating viruses but also the impact of interventions such as vaccine. Now, using this system between about 2010 and 2017, one of the things that we observed in the vaccine effectiveness, irrespective of the circulating viruses, really in the elderly particularly, was a very poor influenza vaccine effectiveness that was seen, which led in 2017, early 2017, a decision that we needed to do different for our elderly, and what that meant was the introduction of an adjuvanted trivalent at the time influenza vaccine for our over 65s as a way of improving the immunogenicity of vaccines in the elderly. So here I am linking the clinical work with the virological sampling, the observation of what's circulating, and the impact of the intervention applied to feed back into a loop for policy change to drive health improvement in a particular segment of the population. However, along comes a pandemic, and primary care surveillance itself also needs to adapt with the emergence of a new virus, because, as was evident really during 2020, the infection with SARS-CoV-2 or the clinical syndrome of COVID-19 overlapped quite considerably with the previous syndrome, influenza-like illness, but also with acute respiratory infection, which from a perspective of a GP and clinical management are overlapping disease syndromes, but not exactly the same, whereas influenza-like illness was considered to be quite a distinct and discrete subset of acute respiratory infections. And really hitherto in Europe, most countries had been monitoring influenza-like illness, with a few countries monitoring acute respiratory infection, which is actually numerically a much greater number of individuals presenting to primary care. So one of the things that our primary care colleagues have done is to expand and adapt the clinical surveillance, creating a hierarchy arising from the first clinical assessment of acute respiratory infection, giving a number of different subsets of acute respiratory infection, that of influenza-like illness, as we've had historically, but also now considering exacerbations of chronic lung disease, a lower respiratory tract infection, or upper respiratory tract infection, so that we actually have a clear hierarchy from acute respiratory infection into subsets of what might be more defined clinical syndromes. Attached to this have been the adjustments in our virologic surveillance program, where pre-pandemic the focus was on sampling influenza-like illness and testing for influenza types and subtypes, but also respiratory syncytial virus and human metapneumovirus. to coming out of the pandemic, where we're actually testing now for a much broader range of viruses, including SARS-CoV-2, seasonal coronaviruses, rhinovirus and enterovirus. And following the incident of unknown hepatitis in pediatric population, also including adenovirus. This together gives us a picture of positive samples by pathogen across winter periods, and here we can see the interplay between the influenza in navy and the seasonal coronaviruses, or the RSV in mauve. And typically for us, RSV is a pathogen which we can rely on circulation during November and December towards the end of the year, whereas influenza is much more flexible in when it actually turns up. But we can see a cumulative picture of which viruses are circulating through the period of the year. And in particular, we note the significance of or contributions coming from rhinovirus throughout this. We use this information to give us vaccine effectiveness estimates by age. So here highlighted are the H1N1 vaccine effectiveness estimates for 23-24. And what we can see is typically when we compare those in the older age groups, we can see that H1 vaccine effectiveness is typically better than the H3 vaccine effectiveness data, and in the children we tend to see much better, not so much shown this year, but we do tend to see rather better vaccine effectiveness delivered through the live attenuated vaccine program than the inactivated vaccines in the older age groups. We're also able, through this type of analysis, to look at clade-specific circulating virus vaccine effectiveness. Here shown is 23-24 data for the two circulating H1N1 clades, which differed in their predominance over the course of the winter months, but for which, when we do the aggregate analysis, we can see that there are some significant differences between the vaccine effectiveness against infection through different subclades. So this sort of analysis is in its infancy, but is a very powerful tool for looking at how well vaccines are performing and the sort of outcomes of strain selection to give us as strong as possible strain selection information. A similar analysis is possible also for SARS vaccines, this time by vaccine type and by different risk groups. What you can see here plotted is estimates of vaccine effectiveness with increasing time from administration of dose 2 vaccine and the administration of dose 3 vaccine. So shown beautifully is the waning of effectiveness with time from vaccination, and therefore the necessity and importance and indeed effect of the third dose of vaccine. We also see the importance of the different risk groups and the necessity for close monitoring within those risk groups. And we can use that data to develop a better understanding of circulation of RSV in the community to tell us or to provide us with a baseline of genome diversity before the introduction of RSV vaccines, which for the United Kingdom we expect to have a programme from the 1st of September for all over 75s and maternal vaccination. So monitoring viral diversity through these programmes is going to be important as well as developing systems for managing or for monitoring vaccine effectiveness in the way that we have done for. Most recently, we also have picked out a zoonotic infection of H1N2 unexpectedly through our routine surveillance programs, which, as it turned out, appear to have taken place unrecognised in a section of the country where we have the highest density of pig farming, yielding again the information and the importance of detailed sampling in association with population clinical monitoring. So my conclusions on this is that sentinel primary care surveillance is a very powerful tool, and when coupled with virologic surveillance provides insights on strain circulation and the impact of interventions. For all of us, improving data linkage arrangements definitely add value for assessment of healthcare impact and the effectiveness of interventions. We have used this system as one of our mosaics contributing to respiratory surveillance, but it is a key system for us. And the assessment of burden of illness due to different respiratory viruses is work in progress, particularly relevant for development of interventions for exacerbation of chronic lung disease. We've also seen, somewhat unexpectedly, that sentinel surveillance is useful for emerging zoonotic threats. So if I could just acknowledge all of the many teams that are involved in this work, and particularly those UKHSA Colindale, the virus teams and the epidemiology teams, and also our close collaborators in the Royal College of General Practitioners at the University of Oxford. Thanks very much for listening.
感谢Zenborn 教授，是我们对
understanding regarding the surveillance, especially the function of the system in monitoring the respiratory infectious disease. The very last speaker is from Eve Lacris from the US. Dr. Lacris is actually from Minnesota University, Vice Chair, the Center of the Infectious Disease Study and Policy Study. He has been working in WHO, Geneva, especially he is actually the leader for the task force of Zika viruses, as well as the chair of the Camp of Refugee in Medicine Sans Frontières and also during COVID-19. He has also chair in the South Coronado Indiana Medicine University, and he has been working in US CDC in Atlanta for 23 years for now. He's actually doing some of the monitoring surveillance. He will be talking about the roadmap on the advances in vaccine R&D for influenza and other respiratory viruses. Welcome.
Thank you for the invitation to speak with you today, and sorry I couldn't be there in person, but appreciate the opportunity to share information about our work. I'll be speaking today about roadmaps to research and development, or R&D, for influenza and other respiratory viruses. I'll start by talking about our R&D roadmap for influenza vaccines, and then I'll end by talking a bit about R&D roadmap for broadly protective coronavirus vaccines. Just for background, we know that influenza vaccines are the cornerstone of public health, but we also know that improved vaccines are needed, both for seasonal and for pandemic influenza. We know the seasonal antigen selection may result in mismatches with the circulating virus, and the seasonal vaccine effectiveness can be quite variable. There are a number of programmatic challenges for implementing annual vaccine programs worldwide, and broadly protective or universal vaccines are clearly needed to protect against emergence of novel strains with pandemic potential that may emerge in the future. We need vaccines that are more effective, more durable, more more broadly protective, and suitable for use worldwide. With the recognition for this need for improvement in vaccines, the global community came together and formed the Influenza Vaccines R&D Roadmap project. It was built on the need for a comprehensive, coordinated strategy to accelerate influenza vaccine R&D. It was coordinated by CIDRAP, but with the involvement of 147 subject matter experts from over 100 organizations in over 20 countries. The Influenza Vaccines R&D Roadmap forms a framework to prioritize R&D. First, to improve the production and effectiveness of strain-specific seasonal influenza vaccines, and second, to advance the development, licensure, manufacturing, and distribution of universal or broadly protective influenza vaccines. The roadmap's a 10-year plan for prioritizing and coordinating flu vaccine R&D across 6 major topic areas, and those are shown on the right. So those include vaccinology for universal flu vaccines, vaccinology for seasonal flu vaccines, virology, immunology, animal and human models, and finally policy, finance, and regulation. The document includes 24 strategic goals with 112 milestones to achieve those goals, including 37 high priority milestones. So just to give a sense of examples of what these IVR strategic goals and milestones look like, they're designed to be specific and time-bound to accelerate R&D. So for example, under strategic goals for vaccinology for seasonal flu, here's an example to further assess the role of existing and new adjuvants to create next generation improved seasonal flu vaccines. And the accompanying milestone would be by 2026, with a specific date, determine through clinical studies what existing adjuvants substantially improve immune response, particularly in young children. And then, for example, a second example under virology section is to enhance the ability to forecast viruses that are likely to circulate in the upcoming season. And that's accompanied by a milestone by 2025 to develop, standardize, and implement methods to improve antigenic characterization, and on other additional examples like that. After the IVR plan was launched in 2022, CIDRAP started coordinating the IVR monitoring and evaluation program. And this program is made up by basically 3 major components. First is the program on universal influenza vaccine technology landscape. And this monitors the R&D pipeline of universal influenza vaccines, next generation vaccines, and broadly protective vaccines. Second is the IVR Monitoring, Evaluation, and Adjustment, or MENA program. And this tracks research progress toward each of the IVR goals and milestones. And the third project is complementary to the other 2 in that it is the funding tracker that monitors funding and investment in influenza vaccine R&D. The Monitoring Evaluation program compiles and disseminates information on the status of R&D. It does this by ongoing systematic review, but also funding awards, industry reports, conference abstracts, patents, policies and guidelines, a wide variety of information sources that are compiled and posted on an open access site at the CIDRAP website. So all this information is available as a one-stop shop all together in one place. The objectives of the program are to advance a comprehensive agenda to accelerate flu vaccine R&D. And secondly, to identify persistent challenges in R&D to accelerate progress. It highlights research and investment in high priority activities and facilitates information sharing for improved coordination to improve efficiencies and reduce redundancies. And finally, to review ongoing progress and to adjust the goals and milestones accordingly. So looking first at the first component of the program, which is the universal influenza vaccine technology landscape. This is a database that tracks information on vaccine candidates that are universal, broadly protective, or next generation vaccines that are either in clinical or late preclinical development. It's continuously updated, and the results are publicly accessible on the CIDRAP website. And here's the results of the current status of the pipeline. It demonstrates that there are currently 211 vaccine candidates in the developed pipeline. The vast majority, 172, are in the preclinical phase, and we have 26 candidates that are in active clinical development through phase 1, 2, and 3. It's also worth noting that none have yet been approved, so we still have much work to do to cross the finish line in this area. But there are a number of exciting new investments that you can see occurring in this discovery pipeline, including 4 combination COVID and influenza bivalent vaccine candidates that are under development now. And these are all done across 6 platforms. So this slide summarizes what is on the website across the 6 platforms that are being developed, that are under development. So this lists, for example, the platform on the top, and then underneath each of the boxes is the specific candidate and the manufacturer. On the website, if you scroll over and click into each one of those, it will then produce additional information on the status of the research that's ongoing for each of those candidates. I think another thing worth noting here is just the important progress that's been made, particularly in the, and those are all, there's more activity there and a lot of important progress. So the second project I wanted to talk about is this monitoring, evaluation, and adjustment project that tracks progress against all of the IVR goals and milestones. Again, there are 112 milestones, and 37 of those are high priority. It's exciting to see that we already have 14 milestones that have been completed, including 5 of those that are high priority, as well as a full 2/3, 67%, shown here in yellow, that are already in progress. The summary also highlights where we need continued research activity, as 22, or about 20% of the milestones are not yet started. So one of the nice components of this project is you can identify where there's been important progress and exciting progress being made. So if we look at the milestones under vaccinology, for example, we have accomplishments in that vaccine candidates with broad-based immunity have advanced to phase 1 trials. And secondly, we have a number of promising vaccine candidates that advanced to phase 2 and 3 trials, including in high-risk populations. Other accomplished high-priority milestones in animal and human models. We now have the availability of validated reagents, viral stocks, and harmonized assays that are available for animal studies. And use cases have been developed for controlled human infection models, or CHIM studies, including ethical and safety considerations. Under policy, finance, and regulation, there's been a summary completed on lessons learned from COVID-19 that can be applied to influenza vaccine R&D, including study design, manufacturing, and global distribution. And that finalized report was developed by the National Academies of Science, Engineering, and Medicine. So this is a screenshot of our 3rd component of our activities, which is the funding tracker. And this monitors progress in funding and investment for each of the goals and milestones. So I don't know how well it's visible from this slide, but the top area here outlines the 6 top general topic areas of the IVR. So that's virology, immunology, vaccinology, et cetera. The second line then summarizes the strategic goals, and within each of the strategic goals lists the milestones and demonstrates specifically where there is funding for each of the activities and the milestones. If you are on the website, you could scroll over each of these It would provide information on what the milestone is and specific information on the funding activities and projects that are being supported. The funding tracker summarizes now 350 projects that have been funded since 2020 and 2023, and those can be found open access on our website. I think the final point about the importance of this work is not only the compilation of information, but also the convenings of stakeholders and funders. We have annual meetings of the IVR task force, which informs the review of the IVR goals and milestones. And that's in partnership with the Global Funders Consortium for Universal Influenza Vaccine Development. So that's an opportunity to share up-to-date information on the status of vaccine R&D that directly links the research that's been completed with the funders making decisions on where progress still needs to be made. The summaries of the IVR task force meetings are available online and again are open access. So switching now from influenza vaccines, I'm now going to talk about the R&D roadmap for broadly protective coronavirus vaccines. Similar to what we were talking about with influenza, there's a need for more durable and broadly protective coronavirus vaccines. We know that SARS-CoV-2 was the third coronavirus to spill over from animals to humans over the past 2 decades, and I have no reason to think that we're not at risk for seeing another spillover of another novel coronavirus. We have a number of challenges with the current SARS-CoV-2 vaccines. We know protection wanes over time, and they just provide limited protection against new variants that continue to emerge. We need coronavirus vaccines that are more durable and more broadly protective. And we need a proactive approach to accelerate R&D now to be better prepared for the future. So with that understanding, the Gates Foundation, Rockefeller Foundation supported work to develop an R&D roadmap for broadly protective coronavirus vaccines. This is a comprehensive plan for a coordinated global effort to accelerate R&D for broadly protective coronavirus vaccines. It organizes a large and complex research agenda. It summarizes key barriers and knowledge gaps, identifies specific time-bound R&D strategic goals and milestones to develop vaccines that are suitable for use in all regions of the world. Ultimately, it's a tool to coordinate research and investment among an array of stakeholders. The process of the roadmap for coronavirus vaccines was developed in the same way as we did for influenza. It was developed by more than 50 scientific experts from around the world to build this new vaccine strategy. We first established a steering group of global experts and then conducted a comprehensive literature review. We drafted the roadmap, which was vetted through a series of workshop meetings. We collected feedback through broad dissemination of the draft, and then revised and ultimately published the roadmap online. The roadmap summarizes gaps and barriers and it identifies goals and milestones in these 5 content areas. It's structured according to virology, immunology, vaccinology, animal and human infection models, and policy and financing. It covers 20 strategic goals with 86 specific milestones that are aligned with each of those goals. We focused a lot on the broad dissemination and open access of the coronavirus vaccines R&D roadmap. We want this to be a living document that is used and read as fully as possible. We made the full roadmap publicly available on the CVR website, and we did a launch to advance the visibility, outreach, and utility of the program. This included a webinar, including representation from the US White House, and which is shown on the right. We published the results in a peer-reviewed manuscript and commentary that was open access in Vaccine. We did quite a bit of media outreach, including press releases and social media toolkit, all to ensure the wide availability and utility of this work. So to conclude, I just want to emphasize the critical need we have to accelerate R&D for improved and broadly protective vaccines, both for influenza and coronaviruses. These roadmaps serve as a tool that can advance a structured and comprehensive plan for research and the funding community to accelerate a coordinated program. The monitoring and evaluation component facilitates open access sharing of information that highlights the progress and identifies gaps that can strengthen the work that's ongoing. I want to close by thanking the team who does the hard work of collecting all the information that we compile and post for available use. They really have done such a great job in digging into the details of this work. I want to thank you again for the invitation to share this information, and I wish you all the best for a successful meeting. Thank you so much.
谢谢莱克格雷兹教授，做的关于这个。
Lacrit sharing about vaccines in influenza and COVID-19. Vaccine is the ultimate weapon for us to guard against different kind of disease. I believe with some multiple care and support, vaccine will have further development. Now let's have a 20 minutes break. And the next session will be moderated by Mr. Li Chuanle and Hong Zhao from CPMA and Peking Union Hospital.
对人类健康、生命、经济造成巨大损失。在西班牙流感大流行爆发30年后，1947年，世界卫生组织启动全球流感防控项目。1952年开始建立全球流感监测网络，至今监测网络已扩展到129个国家。1977年，中国国家流感中心加入 WHO 全球流感监测网络。通过持续监测，及早发现新型病毒，中国在全球流感发挥着关键作用。为积极应对下一次流感大流行，有效预防流感及呼吸道疾病给人类带来的健康威胁，促进全球流感专家学术交流与合作，由中华预防医学会牵头举办的2018年世界流感大会在中国北京隆重召开。此后，大会每2年举办一次，每届主题聚焦当下流感防控面临的新的复杂挑战以及最前沿的科研进展。2024年世界流感大会将围绕从流感到呼吸道传染病综合防控的主题，邀请来自全球5大洲的90余名专家交流分享全球最先进的流感防控技术，为应对下次流感大流行做好充分准备，提升全球流感防控水平。
Hello everyone, I am the director of the Asia Pacific Alliance for the Control of Influenza. Due to the COVID-19 pandemic, the last 2 conferences in 2020 and 2022 were organized virtually. This year, I'm happy to see that we are meeting in person at the BFA International Convention Center in Hainan Island. The main
请各位
Okay, distinguished experts, now let's continue. This is the second session of the afternoon. I will co-moderate this session together with Mr. Fenglu Zhao. Professor Fenglu Zhao, he already made a speech. And also, Dr. Liang Xiaofeng introduced him. I'm from CPMA, the Vice Secretary General of CPMA. I'm very glad to co-moderate the session with Professor Fenglu Zhao. Next speaker is Arnold Model. So he's from Michigan, Ann Arbor University Public Health College, professor in public health and epidemiology. He mainly researched on acute infection-related epidemiology and prevention control, especially influenza and other respiratory infectious disease in tropical and temperate different populations. Evaluation in vaccines and antiviral drugs. He once led Michigan's respiratory tract infection research and has been engaged in SARS-CoV-2 vaccines research and development, and also have observational studies in vaccines and other drugs. He is also an NIH Allergy and Infectious Diseases Consultation Committee's member. He once served as the president of U.S. Infectious Disease Association and won Alexandra Award and U.S. National Infectious Disease Funding. So he's a very senior infectious disease, especially respiratory infectious disease expert. So now he will give us a speech about the prevalence and clinical characteristics, outcomes of RSV influenza infection in adults hospitalized with acute respiratory illness. So now welcome.
I hope you are not able to be with you, and I'm going to use the opportunity to try to give you some information about the new RSV vaccine usage in the United States. We now have 3 RSV vaccines licensed for older individuals to join the influenza vaccine as a way to keep older individuals out of the hospital during the winter season. RSV is something which is relatively new compared to influenza. We knew that influenza was an important pathogen since the Middle Ages. It was reported first in 1562 in a story about what was going on during the time of Queen Elizabeth in the UK. The virus was first identified in 1933 in the UK, and then by Dr. Francis in the United States in 1934. And we've had vaccines available for influenza since 1943. RSV's a relative newcomer. We know, for example, that RSV was first identified in 1956 and then was associated with childhood diseases, mainly bronchiolitis. And it's only recently that we've begun to associate RSV with more severe disease in older individuals. We looked at RSV when we were doing a household study many years ago, and this is from data from serology during our household study almost half a century ago. And we compare here type A and B influenza infections with RSV infections. And you can see on the right that RSV is a main pathogen in younger individuals, but it infects people throughout life. Influenza is much more flat across ages. Incidence is high in young children with type A and remains high throughout life. With type B, this may be an artifact of the tests that are used, the serologic tests, but it peaks in young adulthood and continues on throughout life. So RSV was not really recognized until recently as a pathogen in older individuals. It was associated only with younger individuals with bronchiolitis. Now, comparing influenza with RSV is somewhat difficult because there's greater variability year to year of influenza than with RSV timing, even though RSV does vary from year to year. With influenza, the outbreaks are going to be different depending on what type or subtype shows up. H3N2 is going to be more severe in older individuals than H1N1 or type B. And we have the issue of influenza vaccination. Many of our populations of older individuals are heavily vaccinated, 70, 80% vaccinated in the United States, and therefore to compare frequency of influenza with RSV is a bit of a problem. Now, this is a summary of seasonality, and in many areas of the United States, the virus is most common in late fall and into the winter season. Peaks are often in December, January, February. It often starts before flu does and ends often before influenza seasons end. But you can't really generalize because each year there are differences. The situation in China may well be different because you have different patterns in the south and the north with influenza, and the pattern with RSV may vary as well. Now, the frequency of infection has varied from year to year. Summary is that in an influenza vaccinated population, RSV may actually approximate the occurrence of influenza in some years. In some years, you may see more influenza. In younger individuals, we know that RSV is less prevalent than influenza during young adulthood. And young adults typically are hospitalized with influenza during the winter season. So there is some variability here, but it's very clear that RSV is an important pathogen in older individuals. And what they develop is sometimes pneumonia, probably an infection leading to hospitalization with pneumonia is more common with RSV than influenza, but influenza causes greater numbers of hospitalization, so it's very difficult to generalize in terms of the severity. Now, this is a classic study looking at the etiology of pneumonia in an American population. And in fact, the most common pathogen turned out to be rhinoviruses in this study, which may or may not be the etiologic agent, because rhinoviruses infect people and they may be present for a long time after a common cold. So this may be an artifact, but influenza is very clearly the second most common. And down the line is RSV and also metapneumovirus. Again, variation from year to year, but clear occurrence of RSV causing pneumonia. The clinical severity is also difficult to generalize on. There are some points that do separate RSV from influenza from a clinical standpoint, but the individual case, it's really difficult without doing virology to know whether you're dealing with RSV or influenza. Wheezing, nasal congestion, and bronchospasm are often more common in RSV, and I'll show you some results of a study we did where we showed that it actually resulted in longer hospitalizations than cases of influenza, even though there were fewer RSV hospitalizations. And this is a study that was carried out by Nelson Lee in Hong Kong, and you can see where the significant differences are. More chronic conditions in RSV infected individuals, more chronic lung disease, more wheezing and bronchiolitis and bronchial symptoms, more lower respiratory symptoms, and these are all individuals hospitalized for RSV or influenza. And very often, there is more necessity for oxygen in individuals who have RSV than influenza. Here, the frequency, you can see, was about the same in this particular year. A few more RSV cases than influenza cases, but again, this is hard to generalize from year to year. This is a study that was done over many years in the UK, and looking at frequency, this is attending the general practitioner, and it looks at flu, and it looks at RSV, and flu is as common as RSV in some years. In some years, they saw more RSV than influenza, and here we're looking at hospitalizations, and with hospitalizations, you can see the flu is more important here. And then in later years, that they're about the same in frequency. So again, you don't need to say which wins or loses in terms of numbers. Mainly it's influenza that is more common, but RSV is present from year to year. This is a study we did over a 2-year period in hospitals in our area of Michigan. One of them is our teaching hospital at the University of Michigan, and the other is in the middle of the city of Detroit in a real urban population, and we're basically a suburban population. And here you can look at the seasonality in these years and the frequency, and this is total acute respiratory infections hospitalizations. And you can see influenza is much more common in this year and still more common in the next year, but with RSV accounting for some reasonably high frequency. If you add up both RSV A and B. There are two types of RSV. If you add them up, you'll almost come to the level of influenza in some of these months. Now, what about the characteristics? In general, we found in this study that obese individuals were more likely to be hospitalized, and these were not just overweight, but truly obese individuals. And if you look at 50 to 64-year-olds, you'll see that RSV is was more common than influenza in this population. But if you go further out in age, you will find that influenza is more common. And here you will see those with influenza vaccination, and influenza vaccination rates were high, so that you are preventing many of the cases of influenza in this population. But the interesting thing is that RSV goes down in age more than influenza does as a cause of hospitalizations. Influenza is more common in older individuals, but in younger individuals who are less likely to be hospitalized, RSV is an important pathogen. Comorbidities. Comorbidities tend to be more common in the RSV individuals. And this is the proportion of those who are positive. And you can see that with RSV, patients are more likely to be positive for comorbidities than with influenza. And it's mainly, as in Nelson Lee's study, respiratory comorbidities that are important in this population. Models to look at what can differentiate. We've talked about obesity. We've talked about comorbidity and chronic obstructive pulmonary disease, more common in cases that are RSV positive than those that are flu positive. And we'll talk about duration of hospitalization. Next, and very clearly, the length of stay of greater than 7 days was much more common in RSV than in influenza, even though we know that influenza is typically more common than RSV, even in vaccinated individuals. And pneumonia, again, influenza is more common, but as a proportion, pneumonia is more common in those that get RSV typically than in those who get influenza. And these differences are statistically significant. Now let's bring us bring us to the present day. We've shown you data that go back a number of years. Now this comes from our household study of people of all ages, and I'm showing this to you mainly to talk about year-to-year variation. So, and you can't really go by the height of the bars here because the scales are different. Here's influenza, and influenza, as you can see, the bars here, these are expanded by double. So influenza is probably twice as common in our study as RSV. But here you can look at the important viruses of RSV in red, human metapneumovirus in blue, and parainfluenzas in brown. And you can see the year-to-year variation. And here is the pandemic. And it all stopped during the pandemic. And in the next year, it came back. And we had a big RSV year. And you can see year after year, you see these patterns recurring. And this is data from the CDC in the United States. And this is from October to April in 2022 to 23, so only a year old. And you can see the the frequency of hospitalizations and deaths, and this is only RSV. You can see how it goes up with age, but is still present in the 60 to 64-year-olds, and it results in hospitalizations, it results in ICU admissions, and it results in deaths, and you can see the increase in death rates as you go up in age, the 75 to 79-year-old age group, and the 85 greater than 80-year-olds here. And finally, let's look at COVID and influenza and RSV together. And again, these are recent data. And here is RSV. And you can see that RSV is more likely than the other conditions, especially individuals who are vaccinated, to result in the need for invasive mechanical ventilation and even standard oxygen. You have to go to influenza here to see the need for standard flow oxygen, which often is very commonly used as almost a standard in hospitalized individuals. So, in summary, influenza is a disease that has been recognized for centuries. Influenza in the northern hemisphere, in the temperate zone, causes outbreaks that you can recognize without having to actually test, because you can detect influenza when many people are coughing and they need to be hospitalized for respiratory disease. RSV could only be recognized after cell cultures became available, but you can also recognize RSV being present because of hospitalizations of your very young children because of bronchiolitis. And now we know that at the same time, older individuals are being hospitalized with acute respiratory infection requiring mechanical ventilation and with deaths, longer hospitalizations and deaths occurring in a portion of them. The development of RT-PCR in general changed our understanding of the epidemiology of both. Recent studies have confirmed the importance of RSV in illnesses resulting in hospitalizations, especially in older individuals and those with underlying conditions. And as I pointed out, the RSV hospitalizations go down further in age. And in the United States, one of our vaccines has just now been licensed for those down to age 50 years of age. It's difficult to distinguish RSV and influenza in hospitalized adults, although there may be differences in seasonality and other characteristics. Flu usually occurs later than RSV starts and can go on further. But you need tests to be able to treat influenza. Right now, we have no therapy yet for RSV, but we will have vaccines to prevent it. So we're a step ahead with RSV. Frequency of both in severe illnesses in adults will vary from year to year, but RSV tends to be less frequent, but present also on a year-to-year basis. So thank you. I hope I've helped to update you as to the RSV situation in the United States. They are now working on the possibility of a vaccine for metapneumovirus, which is nearly as frequent as RSV. So the new developments continue. Thank you.
好，谢谢阿诺德教授的精彩报告。
has pondered over the RSV vaccines since the isolation in 1956 globally for the R&D development road, as well as the updated epidemiology, clinical threat, disease burden, and some of the prevention control measures. Especially, he has presented to us the seasonal influenza versus RSV. It's fair to say for RSV, in terms of the R&D, we have reached some advancement. Still, there's a long way to go. We need to further study and better prevent and control the RSV prevalence. That's it for today's topic. Next presentation is going to be moderated by Professor Feng Lu Zhao. Thank you, Vice Chair. The next presentation is actually from School of Public Health, University of Hong Kong, Michael Chang. His study interest covers by utilizing ex vivo explant to isolate the epithelial respiratory viruses to study the correlation between the tropism and the pathogenesis of emerging respiratory viruses. He has got a lot of interest since 2009. Professor Chen has been awarded as ESI's high influential scientist. He has published over 120 publications, and he has got some update for his topic. He will be talking about the novel human respiratory tract platforms to study the tropism and pathogenesis of emerging respiratory viruses.
Me to share our, platforms that we usually use for the risk assessment of the viruses. Normally, that can be, pandemic viruses or the viruses actually identified from normal surveillance. So I would actually start with the routine, kind of standard platform they're using as a risk assessment, using for SARS-CoV-2. And then we see some advanced technology in the recent development of human respiratory tract platform. So as you may know that the SARS-CoV-2 and the variants actually happening in 2019. In the very beginning, less is known about the transmissibility and the pathogenesis of these viruses. So we use our ex vivo expand models of human respiratory tract to kind of study the tropisms and also the transmissions and also the replication kinetics of these viruses. So at that time, we put the viruses in comparison. We put the SARS coronavirus 1, we put influenza viruses as a comparison panel. And then when we do the ex vivo infection, we find out that the the SARS-CoV-2 replicate much higher in the human upper respiratory tract. So it somehow kind of predict the transmission of these COVID viruses much higher than the SARS-1 and also the MERS coronaviruses. But on the other hand, this SARS-CoV-2 replicate less effectively in the human lung, in somehow reflecting the less severe disease of these COVID viruses when compared to the SARS coronavirus 1 and also the MERS viruses. And then this ex vivo organ culture model, we also can expand it into human eye, the conjunctiva tissue. We also find that this SARS-CoV-2 virus is able to infect and replicating quite effectively in the human conjunctiva, may serve as additional entry portals for these viruses to human. The good thing of human ex vivo experiment is that apart from we study the replication kinetics, we also can study the cellular or tissue tropism of the viruses. So that when we do the immunohistochemistry, as you can see from here, SARS-CoV-2 viruses replicate much higher, induce much more antigen staining in the human bronchus tissue when compared to the SARS-1 viruses, the MERS viruses, and also the pandemic H1N1 viruses. And on the other hand, as agree with the replication kinetics of these viruses in the human lung, the infection are far lower compared to the other viruses. And then, as I mentioned, we are able to study the cellular tropism, and then we're able to show that these SARS-CoV-2 viruses can infect the human ciliated and the mucus secreting cells, and also the cup cell in the human bronchus epitheliums. But on the other hand, the good thing is, apart from replication, we also can study the pathogenesis of the viruses using these ex vivo experiment models. We studied the pro-inflammatory cytokine and chemokine responses after these cells are being infected with SARS-CoV-2 viruses. But in general, we show that the SARS-CoV-2 viruses are less potent inducer of pro-inflammatory cytokine and chemokine, suggesting that it may be a mild disease in inducing a lung damages. But as you know, the viruses keep evolving. There are a lot of variants, the VOC and VOI coming out. And then there's a big outbreak of the Omicron variants of the SARS-CoV-2 viruses. And then at that time, again, we use our so-called well-known ex vivo experiment model to predict the Omicron variant compared to the original SARS-CoV-2 viruses. Even before the clinical observation, we showed that in our models, the Omicron viruses replicate much, much higher than the Delta, Beta, and the original SARS-CoV-2 viruses. Somehow this ex vivo model happily to predict the clinical observation of the significantly higher transmission of the Omicron viruses compared to the original SARS-CoV-2 viruses. And interestingly, we also demonstrating in the human lung tissue a much less infection and replication of the viruses. Somehow predict the clinical observation in the human populations. But then, of course, the viruses keep moving up and the variant keep coming out. And nowadays, I mean, the JN1, the BA2.86 is the dominant viruses. We are again using the similar platform to predict what actually happened in the current circulating variants of the SARS-CoV-2 viruses. And this is a complicated slide, but in general, it's a very interesting study. Along this evolution of these viruses, in the more recent circulating strain, like the JN1, we find these SARS-CoV-2 viruses variant lost their tropism in the bronchus, in the airway tropism. The infection rate in this bronchus has been decreasing. But on the other hand, we show that the lung also decreasing. But I haven't shown the data here, but we also use the human gastrointestinal ex vivo experiment models. We show that there's an increasing in the intestinal tropism of the JN1 variant viruses. So, I mean, the viruses keep evolving, and we use the platform actually help us to predict what actually happening in the clinical observation. And again, we show that although they have changed in the tropism, but they actually have a similar cellular tropism in the human bronchus tissues. And also there are much less infection of the recent circulating JN1 variant in human lung as well. But then, these ex vivo experiment is useful, but they have their limitation because not all the laboratories are able to assess to freshly isolate the human lung tissues. But then more recent advanced technology development is something called the human respiratory tract organoids. So we have managed to isolate some of the human adult stem cells from nasal or nasopharyngeal regions in order to isolate this so-called organoid, which is a mini airway, mini bronchus, and mini lung structures. As you can see here, they maintain a very highly physiological relevant structures as like human airway, with the cilia moving, with the mucus secretions, and then they express nicely the receptor for both influenza, like the salicylic acid receptors, and also the receptor for the coronaviruses, like the ACE2 and the DPP4. And we have been trying to validate the use of these organoids in comparison to the ex vivo expand model we are using. And these slides show you, we compare head-to-head the ex vivo expand after infection with a panel of influenza viruses, and then compared to using the airway organoid, we saw that a very similar replication kinetics of these viruses in the two models. And then, again, we studied the cellular tropism between the ex vivo expand and also the organoid. They actually replicate perfectly between the two models. And again, the cytokine and chemokine replication profile also show that they are highly relevant to each other. That means we can use organoid to replace the ex vivo expand model to study as a risk assessment platform for emerging respiratory viruses. And the good thing of this airway organoid, because we can actually isolate them and then freeze them down in the liquid nitrogen and then regenerating them for immediate use. And what about these organoid platform to study SARS-2 and influenza viruses directly? So we studied these airway organoid comparing influenza B and influenza A viruses, show that they are able to replication in these airway organoids, and also more avian influenza like H5N6, H5N8 also show they are able to infect these airway organoids. And then the good thing is, apart from airway, we can also isolate human nasal and nasopharyngeal organoid, which belongs to upper respiratory tract. So as you know, some of the SARS-CoV-2 viruses, they're mainly infecting human upper respiratory tract. So then we have a more useful tools as a platform to study these viruses' replication. So we use the human nasal organoid to study the replication kinetics of this BA1 and also the XBB variants of the SARS-CoV-2 viruses, and also show that they're actually replicating really well in this nasal organoid. And we can see the differential difference between different variants of these viruses as well. But then, as you know, all individuals are different, and then they may behave differently to different virus infections. So how can we deal with this, different characteristics and personalized responses to different emerging virus infection? I showed the data here, as you guys may know, in terms of the SARS-CoV-2 infection, the COVID disease, more severe disease was happening in the elderly when compared to the kids. And also, the study is showing that, the male actually developed more severe disease than the female, and also the smokers actually develop more severe disease in COVID-19 than the non-smokers. So then, how can we address this in terms of some generic organoid? Are they able to predict, or as a very useful risk assessment platform for them? So can organoids help? So then, we want to develop something like the personalized respiratory organoid platform for more personalized medicine and screening, and a platform for individual assessment of infections. So with a non-invasive sampling of human adult stem cell in the nasal or nasopharyngeal regions, we're able to generate a personalized organoid platform for individual assessment of emerging infections. So we established a broadband of this personalized organoid platform in different regions of our airway, including the upper airway, the conducting airway, and also the lower lung airways. And then we saw that in comparison to the organoid isolated from the kids compared to the adults, they did show some physiological differences in terms of the structures of the organoid we developed. And then we believe this broadband of respiratory organoid can be a very good representative of a platform to do a very unique risk assessment for emerging respiratory viruses. So these are some of the data we try to compare between the pediatric samples organoid versus the adult organoids. We compare the BA2 Omicron variants infection between pediatric versus the adult organoid. We saw that the BA2 replicates slightly higher in the pediatric versus the adult organoids. But the cytokine expression are pretty similar between the two populations of different age. But adults are able to stimulate more interferon-stimulated gene than the pediatrics. But then what about other respiratory diseases, right? You know, respiratory disease may actually contribute to different responses upon infections. So we try to further distinguish our personalized platform into healthy airway, smoker airway, COPD airway, and also the asthma airway. So as you can see from the individual who is suffering from different respiratory illnesses, through a non-invasive sampling collection, we are able to generate a disease-specialized, personalized organoid platform. As you can see here, they show distinguished morphology differences in the organoid developed from these individuals. This is the really healthy smoker, healthy individual. This is the smoker individual with a lot of global cells, and not the COPD airway, and also the asthma airway. But what happened to these organoids when they upon infections of the SARS-CoV-2 viruses? So we actually try to infect the airway organoid between smoker and also non-smoker upon SARS-2 infection. As you can see from the figure here, for the non-smoker organoid versus SARS-2 infection, and this is a smoker organoid, the red color represents the cells being infected with SARS-2 viruses. The smoker actually get more infection of the SARS-CoV-2 viruses, and then the replication of these viruses is significantly higher in the smoker when compared to non-smokers. And then about the ultrastructures, as you can see here, which is the structure of the cilia. As you can see from here, the structures of the cilia of the smoker after SARS-2 infection are actually damages. The 9+2 pattern minus the central movement. So these cilia are not actually moving very well. As you can see from here, for those non-smoker, after infection, the cilia are still moving quite random motions. But then, for those smoker after SARS-2 infection, the cilia actually lost the function to beat, randomly. So, I mean, from this platform, we are able to see the differences between these respiratory viruses upon, different emergent respiratory virus infections. This is another, respiratory disease organoid platform we have been developed. This is the COPD patients. We actually try to distinguish between healthy, mild COPD, and also the severe COPD patient. As you can see from here, in terms of the morphology of the organoid generating, they are actually distinguished phenotypically the COPD phenotype. So we believe these platforms are unique and a good risk assessment platform, not only for studying the infection, but also is a very good platform to screen potential therapeutic for individuals. So in summary, I present the ex vivo expand model that we have been using it as a gold standard, as a risk assessment platform. We've been using for many years for influenza and many other emerging infectious viruses, including SARS-CoV-2. And then more recent advancement in the technology, we have the organoid platform. We develop a biobank of human upper and lower respiratory organoids. And then we also develop some personalized organoid platform with different age differences, gender, healthy, smoking, and also disease platform. We hope this application also to study emerging infectious disease, but also as a very good personalized platform for precision medicine and also for drug screening. And then I would like to, finish my talk by thanking a lot of, collaborators and my team in Hong Kong U, and thank you for the invitation. Thank you.
Thank you for your wonderful presentation. Michael Chen 教授啊，利用就是给我们展。
Result using the nice respiratory tract epithelial and the lungs organoids model to evaluate COVID-19 influenza and SARS virus transmission pathogenicity and its damage to the lungs. In the future, we can have more novel respiratory disease risk evaluation and its pathogenicity and drug development is a very good platform. So thank you, Michael Chen. Now, please continue the moderation. So now the next speaker is Dr. Richard Zhao Quibi. Judas Pediatric Hospitals work and also WHO Animal and Avian Influenza Research Center's director in 2011. He has published a very important paper. So he's called the hunter of influenza from 2010 to now. The World Animal Health Organization (FAO) swine fever, swine influenza commission's member. Also a H1N1 Research Outstanding Award winner, and since 2000, he has been in the U.S. Pork Association and Influenza Association. In 2004, he won the Public Health and Epidemiology Leader Award in Scientific American. So today he will talk about updates on recent global epidemic of animal influenza. So welcome.
First, want to start off by thanking the organisers for the opportunity to present to you all today, and then also secondly, apologies that I couldn't actually make it in person. I hope everything's going well. What I want to talk about is a little bit of an update on influenza at the human-animal interface. It's been a very, very active period over the past couple of years. I want to summarise a little bit of that and then come around the last few slides to talk about what's going on with bovine influenza at the US now. So if we look at influenza, it's a true One Health pathogen. Its primary reservoirs are these aquatic birds of the world, and it's from that host that the viruses sporadically spill out into other hosts, whether that be more production animals, both poultry and mammals. And it's usually from those hosts that the virus then spills over into humans. Not so much direct transmission from this natural reservoir species into humans, whether that's a property of the virus or the fact that we don't actually get much interaction between more of these wild species and humans. That's a little bit unsure. But lots of activity going on. There's a whole soup of different viruses of all different subtypes and genetic makeup circulating in this population. And it only sporadically spills over into some of these other hosts. Some of the problem with influenza, particularly from a perspective of preparedness, is there are many, many different flu viruses in these animal reservoirs. And these are just a couple of pictures from some sampling sites that we've had over the years. This here is shorebirds in Delaware Bay area of the east coast of the US. These are shorebirds that are migrating north from South America, from the bottom of North America, and they stop over to feed on horseshoe crab eggs in Delaware Bay as they migrate northwards. And every year we go up and sample these birds as they stop over. Depending on the year, anywhere from 3 to 4 up to 30% of these animals can be positive for influenza. And if you think how many birds that is, that's an enormous amount of virus getting shed into the environment. And certainly there's no recorded instances where those viruses have directly spilled over into people, but certainly a lot of transmission within birds on that population. The other side here, and another well-known host of influenza, is swine. This is a pretty typical commercial swine operation in many parts of the world. A study we did a number of years ago showed that you can, in at least the US, you can walk into any given swine operation, you've got about a 25% chance of finding influenza within that herd. Again, meaning there's a lot of virus circulating, a lot of virus in those environments. Yeah, we do know that these viruses can sporadically spill over and infect the human host, and also some evidence that they can go from these hosts back to avians as well, particularly turkeys, the odd spill back to wild birds as well. But if we look at these populations, there's a huge diversity of influenza viruses. As I said, different subtypes, different genetic makeups, different biological and phenological properties. Some of those are at risk, humans are at risk of catching those, some of them probably not. We don't have a really good handle on exactly what differentiates those viruses with true zoonotic or pandemic potential from those that don't have any. I also want to mention that, just because you have a whole host of these influenza hosts together in one environment, it doesn't mean flu will necessarily be present. And these are just a good example of this, again, from a couple of our more longitudinal surveillance sites. The one on the left here in Bangladesh, in the live poultry markets, particularly in Dhaka. If you go into these environments, you see some of the viruses we know have zoonotic potential, so H9N2s and H5N1s, and we'll talk about those a little bit later on. Every market you go into, every month we sample these, every month we find those viruses, so they circulate endemically within these environments. On the other side here, this is work headed by Mariette Ducates, who went into Western Africa with a lot of partners and looked at fairly similar environments, fairly similar on birds there. We searched a long time for influenza and didn't actually find it. This was a number of years ago now, and some things have changed a little, but just because the birds are there, the humans are there, it doesn't necessarily mean the virus is there. So you've got to actually do surveillance, you've got to do longitudinal surveillance, go back to these sites over time to know how influenza behaves, how often is it there, is there peak in activities, and of course all of those, the answers to all of those questions are important for both control of the virus in the animal populations, but also for reducing the risk to human health. This here's a slide, a summary slide. There's a bit too many details on here, but really just going over the number of zoonotic infections, so instances where some of these viruses, influenza viruses circulating in animals, have popped over into humans and caused confirmed human infection. The period, all these were detected from September 2020 through to early last year. I really want to bring in a couple of points here. One, that this is happening around the globe. So this is not just a Southeast Asia problem. It's not just a European problem. All continents now have seen human infections with influenza viruses of an animal source. If we look here, there's also a range of different subtypes. So H5s, again, we'll talk about those a little more, but avian subtypes. We have H9s, again, avian subtypes. But we also have the H1s and the H3s, which are influenza viruses that circulate in swine, and again spill over from the swine reservoir into humans. So every year we detect these infections. It's different set of viruses in different locations with different exposure and different clinical outcomes as well. And if we look at that a little more detailed here, this is a World Health Organization slide. Just each square here represents a human zoonotic case from mid 2019 through to early 2024. The different colors represent different types of influenza virus, so different subtypes of virus. Most of them represented here are from avian hosts spilling over into humans, but a lot of these are also, the greens are from the swine reservoir. So again, these more endemic swine viruses that spilling over into humans. If you look at for the most recent of those, so just from the last 6 months, we can see a range of influenza viruses. Again, the H1s, swine, the H5s, avian, the H9 avian, and the H10 avian as well. So again, just to reiterate the fact that zoonotic infection is rare with influenza viruses, but it does happen. It does happen reproducibly. It happens in different places, and it happens with different viruses. So the risks, both to human and agricultural health, is everywhere, and it's from a number of different sources. Just to look at a little bit more detail at some of these more recent human infections, particularly the clinical severity I wanted to bring in. A lot of the H5 infections really manifest as a more severe, often fatal infection. The exposure history for these people infected is exposure to poultry, and the age range varies, so it even goes from the very young through to the elderly as well. Often it's, at least with severe infection, it can be those with underlying conditions that have the most severe form, but that's not always the case, and sometimes it's previously healthy people that get infected with these viruses and have very, very severe disease. The swine viruses, so the H1s down here, tend to be a little bit more mild, although it can cause severe disease. And again, often at swine exposure is the underlying cause for these infections. Those people have been in contact with swine. Clearly the swine have had flu and the viruses have changed species, but that's not true in all cases, and often, well, not often, obviously, every now and again there are instances where we don't know the source of infection, how those people became infected. So I want to switch here for a little bit and now sort of concentrate a little bit more on the H5, because I think, you know, in terms of the past 2 or 3 years, this is a subtype of influenza that has really changed the most. And, you know, although the other viruses still cause zoonotic and pandemic risk, this is the one that is making the most noise. So sort of a refresher on H5N1, so it's a subtype of avian influenza. It is one of these highly pathogenic forms of the virus. Started off in southern China back in 96, 97. For a number of years it circulated primarily within that region, then spread out in the wider Southeast Asia region in the early 2000s, and subsequently then spread through the movement of migratory birds into Africa and Europe, and this was about the mid-2000s period, and that was kind of the pattern for many, many years. But what we've seen over the past couple of years is that these viruses have changed, and they've changed a lot, both in terms of the genetics of the viruses themselves, but also the property as well. This is a work by Vijay Dhanakasaran from the University of Hong Kong and his team. The top just shows the number of sequences of H5 viruses appearing in public sequence databases and the genetic clade from each of those viruses. And you see for a number of years, from mid-2000s to sort of for a period of about 10 years, fairly low activity. The virus was still there. It did cause outbreaks, it caused problems, but both in terms of the number of viruses sequenced and also the number of confirmed poultry infections on the bottom here, there was a period of fairly low activity. But then something changed. This virus evolves, as all flu viruses do. It reassorted, so it mixed gene segments between different flu viruses. It mutated in HA and became this 2344 genotype. And with that, there was an explosion of viruses out there, and concomitant with that, an increased number of poultry infections. And that again exploded again somewhere around in mid-2021, where we saw this so-called 2344B version of the virus move around the world. It displaced most of the other H5 viruses that were there prior to that and caused a huge number of infections in both poultry and wild bird populations. And it really changed sort of the ecology of H5 as well, which had primarily, and I won't go into the details of this too much, really changed it from primarily a virus that was driven by poultry outbreaks, particularly poultry outbreaks in Southeast Asia, to a disease that was driven a lot more by wild birds. On the blue here, over time you can see the blue increases, meaning the influence of wild birds increases, and also the epicenter change. So it wasn't just a Southeast Asia center of diversification anymore. It became Africa and also Europe. And this didn't just change ecology, it also changed the geographic distribution of these viruses. So up until this point, there had been one introduction of H5 viruses into the Americas. It came in through Alaska, down into Canada and then down to the US. That virus circulated for a period of about 6 months and then disappeared. Since 2021, late 2021, when we've had the first detection of these 2344Bs, we've now seen multiple introductions of this virus into the Americas, at least 6. I think really highlighting how much different this particular version of H5 viruses are compared to what was there previously. And these viruses have now seeded North America and of course now down into South America, where they've had a lot of impact, particularly in sea mammal populations and wild bird populations. From a human health perspective, the good news is that these viruses, although they're spreading geographically, they're sampling different hosts, they are still very much bird viruses. So we know from decades of research what makes flu viruses prefer the avian host versus the mammalian, or particularly the human host. And if we look at the different properties of that, whether it's the receptors they prefer, the pH of HA activation or inactivation, or just a general signatures, molecular signatures in the viruses, these H5 viruses from around the globe are still very much avian-like, which of course is a good thing from human health perspective. There are some mutations that have occurred upon infection of mammals with these viruses, and we'll talk about that next. But predominantly still very much avian viruses that are poorly infectious for humans. One thing a word of warning with that, I guess, although they're still avian-like, single amino acid changes in the genomes of these viruses can make them switch from being avian-like to mammalian virus-like as well. So currently they're here, but of course the big concern from a human health perspective is that they'll gain these mutations that will make them more able to infect the human host. And when we think that's more likely to occur, meaning these mutations that will make them more mammalian-like, it's when they do infect mammals, of course. And that's another signature of these 2344B viruses over the past 2 or 3 years, is that have infected a wide range of mammalian species. This is a little bit abnormal. Probably a lot of this is driven by the fact there's so many more birds infected with this virus. The birds get sick, the birds die, and they become much more easily predated upon by a lot of these scavenging mammals. This is just data from the US, is illustrating, but 19 different species of mammals, over 150 individual events now. But still, as I said, luckily, apart from a few key mutations in the polymerase proteins, still limited evidence that even upon infection of these mammals that these viruses are changing, which again is reassuring, but something we need to be concerned of. And this is not limited to the US, even though these are US numbers. This is happening across Europe and across Asia as well. So this virus has been given the opportunity to sample more mammalian hosts, gives it more opportunity to change, to evolve in ways that we just don't want it doing. I want to sort of just come the last few slides here, explain what's going on in the US. So this H5 virus has infected a number of hosts we didn't even know could be infected with influenza. And towards the end of March of this year, there was a detection of the H5, the 2344BH5N1 viruses in dairy cattle in the US. So this is a host that I think none of us really expected to be infected with the virus. If we look at where we are now, there's a number of states across the US that have confirmed infection in cattle with this particular virus. Originally, it was driven by cattle movement, so infected cattle moving from one state to the next, bringing the virus with them. But there's some recent introduction. This is not the most up-to-date map I have, but some work out of Michigan, again suggesting that now the virus is also moving a little bit by people. So whether that's trucks or common workers between dairy farms, and even from dairy farms into poultry farms as well. So the virus is still very active right now. And it's still moving. It's certainly no suggestions right now that it's headed towards resolution. It's really interesting in terms of this particular virus. Manifests originally as mastitis and drop in feed and milk output from these cows. And if you look at where the virus is in these animals, there's a huge amount of virus in the mammary glands. So in milk there can be 10 to the 8, 10 to the 9 infectious units of virus per mil. So that's a lot of virus in these environments. Not much respiratory tract, a little bit every now and again in urine, but not much compared to milk. And so the current theory is that this is how this virus is getting moved. It's going probably through the milking process from one cow, infecting an udder, and then infecting the next udder through contaminated milking apparatus. So an unusual way this virus is moving. We're still learning lots about this every single day. So every day there's new information coming in, and some of the information is starting to come in from experimental challenges now. So I think in the next few weeks we're going to learn a little bit more about how this virus is moving around. And of course we're all wondering what the next steps of this virus are going to be, and what this virus is going to do in the coming weeks. If we look at the phylogeny of those viruses, what we do know, this was a single introduction, probably occurring in late 2023, early 2024, so a period of time where it went undetected, but it's a single introduction from wild birds into cows, and then it spread within cow populations, and from cows, in some instances, back to poultry populations. So probably a fairly rare event that these H5N1's infecting cows, but it has happened here, and it's, as I said, it's continuing to spread. There's been 3 human infections the US CDC has reported in conjunction with this, all of them dairy workers, and all of them had signs of conjunctivitis. So high viral loads in the conjunctiva, not so much in the respiratory tract. And this is consistent with other avian influenza virus infections of humans. The receptors for those avian viruses are in high prevalence in the conjunctiva. So luckily, at least of now, no real full-blown pneumonia, although one of these individuals did report respiratory illness as well. So human cases are being detected, but luckily to date still very mild. So to finish up, just hope I've stressed to you all that there is lots of influenza activity at the human-animal interface. And this is truly a One Health problem, and a One Health solutions are needed, because this increased activity has been driven by agricultural, environmental, and human changes in behaviours. We're now looking at H5. We're talking about H5 specifically. It's now endemic in most regions of the world. And the current risk, luckily, for that virus is low. So it's a virus that doesn't want to be infecting humans, but it's not zero. And of course, it's flu, it's a virus, it changes. And so this is where we are today, and we don't know where we're going to be tomorrow. So all I can say is it's time to prepare now. So I want to thank a lot of people involved in this. And also, again, thank you for the opportunity, and thank you very much for listening. I hope the rest of your conference goes well.
谢谢 Richard 的精彩报告，他的
Thank him for his wonderful tomes. Also, we have learned a lot over the report. He has pointed out to us that for the zoonotic community, starting from years ago, they have begun the surveillance of the zoonotic influenza. He has got a systematic picture for us, and also in the morning, academician Chen from the China studies and cases. And also, Richard has given us a global picture, especially for birds, especially the updated information for the avian influenza detected on mammals. It has got different clades, evolutions, etc. In particular, over the conclusions, he mentioned that for H5 in Asia, EU, and many other countries and regions, these will have the potentials for future transmission in China. I think that we know that. Just like he has pointed out, we know that we have the birds. It has become the clustering of the birds, seasonal birds. Also in China, we are a large country where the poultry and butcher and dairy products are also quite booming and popular. We don't know how or when can we actually have that transmission, or when are we going to expect that imported case. I think that we should advance the One Health concept from the action to the concept, and then back to policies. We're going to actually give a greater catalyst to steer up its advancement. Thank you. The next speaker is actually from Public Health School, University of Hong Kong, Jessica Wong, back in Canada, University of Ottawa, studied statistics, later got the bachelor's degree in public health, and also PhD in that. He's Her study will be about epidemiology of infectious diseases, as well as the optimization of the real-time and retrospective study based on the population to estimate the epidemiology of influenza. She also taught some senior models related to biostatistics. She will be talking about public health and social measures for mitigating risk and impact of epidemic influenza. Welcome, Dr. Wong.
Today, before starting my talk, I want to show a raise of hand who has wear a mask today. I saw one hand here, with a few other hands in the back. Great. So today I'm very happy to be here to share with you our latest finding on non-pharmaceutical intervention, or also known as the public health social measure. At the early stage of the next respiratory virus pandemic, there may be delay of getting the vaccines, or there may be delay in the effective antiviral supply. And to mitigate the pandemic influenza, there will most likely that we need to have non-pharmaceutical intervention, which comprise of the following measures. Personal protective measures, for example, hand hygiene or face masks, isolation of sick individuals or quarantine of exposed individuals, and school closure and workplace closure, as well as the travel-related measures, and etc. This is like the Swiss cheese concept of applying different layers of intervention at the same time. And for some objective of MPI during the epidemic or pandemic is that we try to delay the start of the epidemic, as well as to delay the peak of the epidemic and to reduce the height if possible, and try to spread the cases over a longer period of time so that we can buy more times and save life. And then we can wait for the vaccine to be available. Before COVID pandemic comes, our group published 3 papers on the MPI evidence base in the EID journal, which categorized into 3 different categories, including the travel-related measure, personal protective, and environmental measure, as well as the social distancing measures. And in those 3 publications, we try to show what's the evidence base so far. And on the right-hand side here shows the draft that we helped the workshop to do at that time. It was published already in the 2019 version. And with COVID come, and with also the latest evidence on influenza, we try updating our latest guideline, which have the following new 5 categories. Similar to before, we also have personal protective measure, including, for example, hand hygiene or hand hygiene or face mask. Environmental measure, we have got surface and object cleaning, ventilation, etc. We have got a new categories now called targeted measure, which include isolation of symptomatic and or infected individuals, contact tracing, quarantine of exposed individuals. And also we have got travel-related measure as before. And then the last category is community-wide measure, which include school measures and closure, workplace measure and closure, and etc. And today, I would like to share with you the latest finding from this latest evidence. In total, we have got 22 MPIs measure included in this updated review, and there are more than 400 papers included in this review, and 1/3 of them are from the influenza evidence, and the other 2/3 are from non-influenza evidence. For each of the MPI, when there are lots of RCT, we would just include the RCT, for example, the hand hygiene and face mask measure. If there's only few RCT, but there are lots of observational study, we will include both the RCT and observational study, the measures including respiratory etiquette, surface and object cleaning, etc. If there's no RCT, but there are lots of observational study, we will include only the observational study, which the measure including ventilation, isolation of symptomatic or infected individual, and etc. If there's no RCT, but there's only few observational study, we will also include a simulation study. For example, the contact tracing and modifying humidity. and etc. Now I would like to show you some of the summaries of a few of the measures. I'll start with hand hygiene. For hand hygiene, we have found 12 RCT with more than 2,200 participants. And in those RCT, there's only 2 strongly positive studies, which are the cluster trial in school settings in Egypt and Bangladesh. In the top plot here showing the evidence combined with hand hygiene and face mask result, we were able to pool the measure together and get a pooled risk ratio of 0.91. You see that this risk ratio is positive, favor hand hygiene, however, it's not statistically significant. And for evidence with hand hygiene only, we're not able to pool because it's too heterogeneous. The recommendation we give for this measure is that hand hygiene is strongly recommended to reduce the transmission of influenza in community because there's mechanical study showing that hand hygiene can remove or inactivate the influenza virus on human hands. And in the absence of harm when implementing hand hygiene, it is effective at reducing the transmission of other infectious disease as well. Next is face mask. The top panel is the same. And then for mask-only results, we were able to pool those results as well. The pooled risk ratio is 0.88. It favors mask, but as well it is not statistically significant. We would give conditional recommendation for this intervention, such that for individuals who are symptomatic or tested positive for infection, we're strongly recommended them to wear the surgical mask at all time when in contact with other individuals to reduce the spread of influenza to the other people. And also in the epidemics or pandemic of high or extraordinary severity, other individuals in the community are recommended to wear masks in the crowded indoor settings to potentially reduce the spread of influenza from, for example, the asymptomatic individual, as well as to reduce the individual exposure to influenza virus in the community. For isolation of symptomatic or infected individual, we found 12 observational studies. There are mechanically possible studies for isolation of this measure to reduce the transmission, but we found only limited evidence. The overall effectiveness of this measure is moderate, and when used in combination with other intervention, it may improve the effectiveness. We give strong recommendation for this measure. We try to say that volunteer home isolation is the basic package we recommend in every circumstances, and mandatory isolation at home or in a facility may be considered in exceptional circumstances such as the epidemics or pandemic of high to extraordinary severity, so that we can achieve containment. For school measure and closure, we found 1 RCT and more than 200 observational studies. For school measures, for example, increasing the space between desks in school or reducing the mixing between classes, our main finding was that if school remain open during the epidemic or pandemic, the school measure can be considered in order to reduce the influenza transmission. And then the next 3 are the school closure definition. For planned holiday, the transmission of influenza decreases when there's routine school holidays, but it may increase after the school reopens. For reactive closure, we found that the effectiveness was generally limited. Lastly, for proactive school closure, we found that this measure had a moderate impact of influenza transmission. We give conditional recommendation for this intervention. The proactive school closure of the early childhood care or educational center, primary or secondary school can be effective at reducing the community transmission of influenza. And we should consider it during the epidemic or pandemic of high or extraordinary severity. And if possible, we should use this measure in combination with other school measures. For workplace measure and closure, we found one RCT and more than 40 observational study. Our workplace measure, our definition, for example, is including the teleworking from home, and then the policy of sick leave and pay leave can be loosened. And the main finding that we found for our workplace measure is that this measure is effective, and the intervention using in combination with other measures can further strengthen the effect. For workplace closure, it may have modest impact in reducing the influenza transmission. We give conditional recommendation for this intervention. We say that for remote working from home should be encouraged if possible. And for other workplace measure, it can be considered with a gradient of intervention based on the severity of the pandemic. We looked at this plot earlier in my talk, but how does it apply to COVID? When COVID comes, it could still substantially overwhelm the health care capacity, because even if the mitigation are still successful, we still have quite a lot of number of cases per day. Because we know that COVID is quite challenging to control, it is because COVID is more transmissible than influenza, and we have got no population immunity at the start of the pandemic. And there are some studies showing that at the start of the pandemic, it was estimated that there is only 5%, there is around 5% of infection which require oxygen treatment, and then there's around 0.5% to 1% are fatal. So it's a very large number of infection which could overwhelm the healthcare system. And most of the COVID infection were very mild, and therefore it's very, very difficult to identify in the community. And the contagiousness is very high at the time of symptom onset, so that the isolation of cases is often too late to prevent the onwards transmission. And when we try to use MPI for COVID, we can use it to buy times and save life until the effective treatments or the vaccines are available. For containment, or we call it local eradication, which we thought that is not feasible for pandemic influenza, but during COVID, it's demonstrated that it's feasible in mainland China and some other locations. There are many studies attempt to estimate the impact of MPIs, particularly for social distancing policy on the COVID transmission. There are changes in different individual behavior, which is also very important. However, there isn't straightforward method to determine the impact of each of the individual intervention, because many of the measures are applied at the same time. These two studies here try to estimate the effectiveness of the MPI of COVID in Europe, and both of the studies found out that lockdown are very effective in reducing the transmissibility of COVID. This free randomized control trial of face masks was published during the COVID pandemic. The top one here is a study from Denmark. In that study, they randomized 6,000 individuals to either the face mask group or the control group. And in the study, they found that the face mask group has got lower incidence of infection compared to the control group. It's positive effect, but it's not statistically significant. But the limitation of this study is that it's underpowered. And then the second study is the Bangladesh study, in which in the study, they randomized 600 villages in the rural area of Bangladesh, and then to either the distribution, give them the cloth mask, or put them in the control group. And in the result, after the follow-up period, they found that the seroprevalence of the cloth mask group compared to the control group was reduced. So it's also positive effect, but it's not statistically significant. And the limitation of this study is that usually for this type of study, we will use rapid antigen tests or PCR to identify the virus. But instead, in this study, it's used serology. So there still needs some discussion on the finding of this study. And lastly, this third study here is a study conducted in Guinea-Bissau, in which is already very high mask use in the control group. So at the end, they didn't find any reduction in the COVID risk. Some people may criticize about face masks. They think that even after wearing face masks, there are still people infected. In this editorial published by our team, try to show that our mask is not perfect, but there may still having some changes when you wear a mask. It may still be good. This study shows the example of contact tracing of the use of the NHS COVID apps. That in this study show that there's the reduction of the total disease, total case burden. So MPI is not just useful for influenza, it can also be useful for COVID and other infectious diseases. I would like to end the talk by sharing 3 lessons or changes that I learned after the COVID pandemic. For intervention, we don't use just one measure at a time. We need to think about what is the objective we want to achieve. If we want to achieve a better objective, we can use the measure in combination with the other measure. So we can use multiple measures at the same time. And for the COVID lesson that we learned is that during COVID, there are some measures that we implement in the right time. However, it may relax it too late. Using the school closure as an example, we know that it's implement the right time. We are able to control for the transmission of COVID, but we may think that it will be too late to stop the school closure because it's continued for too long. So the children have no school for like very long period of time. So we can use this as a lesson learned for the next pandemic. And lastly, for the stringency, it's not just do the measure or not do the measure. We can think about using the recommendation instead of mandating it. Even though mandating it may increase, for example, using face mask as an example, it may increase the mask use. However, people may not have good feeling about it. People may not like it. And another example is the school closure. Instead of having school closed fully, we can have partial school closure, or we can apply school measure as well. To acknowledge the study, this study was done by a whole team of more than 15 people from the Hong Kong U team. And then we also thanks for the help from the Guidance Development Group conveyed by the WHO with more than 30 members from all the regions. And also thanks WHO for the financial support. Thank you.
好，非常感谢黄婉婷博士的精彩报告。
You shared us NPI's non-pharmaceutical interventions or public health and social measures evidence. For example, hand washing, face masks, lockdown, school closure, and limits of workspaces and their joint effect. I think all of these for us, for the future infectious disease, especially at the early stage, is a very important lesson. So thank you again. So now the next speaker, or the last one of this afternoon, is given by Dr. Wang Yeming from China-Japan Friendship Hospital. Previously, it should be given by Vice Director Cao Bing, but he failed to catch his flight. So Dr. Wang Yeming will do the report about recent antiviral development of respiratory viral infection in China. Welcome. Thank you, Mr. Feng, for your introduction. So, Mr. Cao's flight just took off, so I'm very glad and honored to report to you China's new antiviral drugs research and development and the key pinpoints. I'm also from China-Japan Friendship Hospital Respiratory and Serious Disease Department. These are some disclosure, main PIs of some investigations and funding support. So I will proceed from the three aspects. We know that the three viruses have the most serious disease burden and receive the most attention. The current antiviral drug development are mainly in the three sectors. Influenza, we are all very familiar with that. In the morning, Hainan introduced very thoroughly about the antiviral drugs in influenza. Here I'd like to introduce China's influenza antiviral drugs in its comparison with the international level. Because we know respiratory virus, it has a common property. It has very wide disease spectrum from a symptomatic one to respiratory failure. So we cannot put all of the patients together and research on them. So now internationally, we separate we stratify mild with no previous diseases, mild with risk factors, severe ones, and critical ones. From the current proof-based medicine, we can see antiviral drugs should focus on mild and critical patients, and we have oseltamivir and paroxavir. We have finished the phase 3 clinical trial and wait for the CDE's approval. So the paroxavir is the most important drug in recent years. It's a BA subtype inhibitor. It was first approved in US and Japan. So later we are mainly focused on the PA inhibitor, and also only one pharmaceutical drug company is based on PP2 molecule drugs. So most of the drugs are PA subset, and all of them have finished phase 3 clinical trial. The first one is the first one, GP 681, the PA subset. This is also RCT. We finished phase 2, and then we are doing the phase 3 clinical trial. So classical design. We include both children and adolescents in the trial, including the severe and critical population. Here we can see the share is 2 to 1. In intervention group is 2, and the control group is 1, and the clinical trial's result is positive. Currently, we can see, compared with the placebo group, we shortened the symptom time to 20.29 hours, but oseltamivir is 24 hours. But we cannot compare clinical trials in this way because we have different time, different population, and different strengths. So we can compare the 20.29 divided by the placebo time, so it is very similar with oseltamivir. And one important thing of this drug, because paroxavir has very high drug resistance, especially in pediatric population, especially H3N1 and 2 pediatric population, it has very high drug resistance rate. But in this research, for all the PCR positive patients, we did the next generation sequencing. We only discovered 3% have the drug resistant variation. So the second thing I want to introduce is all the other small molecule drugs have very similar design and have been submitted to CDE waiting for approval. So I believe next year we will have more domestic anti-influenza virus small molecule drugs. And now I'd like to introduce the critical patients. We know that after the approval of paroxavir, they have a Flexone trial, which has been published in 2023 in Lancet ID with a negative result. Before that trial, we were quite ambitious. We wanted to do a in hospitalized patients RCT to see the combination of the two drugs, whether or not can improve the benefits. At that time, we have favipiravir and cohort study, but we found that the concentration cannot be the standards. Then we choose Abidor. We know that Abidor is a very old drug. It can inhibit the virus. The mechanism was found in 2017. So we designed this clinical trial, started very early in 2017, and then we started to recruit patients in 2018. It's lasts for 5 years. So it's quite similar with the Flexon trial. We look at the patients with respiratory failure and with positive influenza virus and shorter than 7 days of onset of symptoms, and we use 100 of invasive and 100 of non-invasive ventilation. You can see after 3 years of pandemic, we use 5 years to complete this trial, and then we finished the study on March 1st, 2023, and then we checked the samples, including the viral load and also some co-infection and secondary infection testing. So far, we just got the results to be shared with you, but it's quite pitiful. The Abidor and Oseltamivir using results is still negative. We also have Flexon similar on day 14, the racial distribution. It has no differences. So far, domestically or overseas, for the critical influenza patients, all the antiviral drugs is negative. But enlightened by COVID-19 studies, most of the studies are shifting their energy on the antiviral drug together with the immunoregulator, like the RAMAP study and recovery time. They are using the antiviral drug together with the immunomodulator. We are using the C5a antibody together with the Oseltamivir and other standard care antiviral to see the monotherapy of standard care, whether or not the joint drug use can improve the prognosis of the hospitalized patients. So actually, it seems quite easy to get approval for antiviral drugs in influenza, like after the approval of favipiravir in 2018. In China, we have 5 small molecular inhibitors. It seems it's very easy to research on such influenza drugs, but COVID-19 drugs and RSV drugs face a lot of challenges. COVID-19 also have similar characteristics, very wide disease spectrum, and we can see the drugs in China and abroad, whether or not it's approved by FDA or CDE, is quite different. In global, the most widely used drugs are some Paxlovid, remdesivir, and molnupiravir. In China, we have some domestic-based antiviral. These new small molecular drugs, they're only approved in China because their population indications are different. But there are common characteristics. They have same targeting point, the RDRP inhibitor or 3CLE inhibitor. So here we can look at the SARS-CoV-2, its target point spot. It's a 2 important process. It's the RNA replication, the like molnupiravir, and RDRP inhibitor. So in the upper left, it's narrowstramvir. It's a small molecular inhibitor. Recently, the pharmaceutical expert, based on that, did some drug structures optimization Then we have the semi-trivial, very trivial, and arch-non-trivial. But it's not a drug targeted at COVID-19 and selected step by step. Actually, in this chemical pool, they have such a drug, so they use this to carry out the clinical trial. And then in 2021, it was approved. But in China, the approval process is rather slow. So from the drug screening to the phase 3 trial, we can see it's a new drug developed by West Lake University is now being reviewed by CDE. Here we can.
We have a time lag. Paxlovid had a very quick licensure, but after our development, after phase 1 on human beings, FIH, first in human, when it comes to phase 1 and 2, we have got the changes from the environment. That is to say, the Omicron variant, and also for the populations, most of them have been vaccinated with the COVID-19 vaccines. So somehow, for such kind of a scenario, originally speaking, in the past, it was indicated for the hospitalization or the severe cases as the endpoint to investigate the antiviral activity or clinical efficacy. Difficult for us to conduct further clinical studies for further evaluations because very low incidence rate for such kind of endpoint event before in Shanghai for Remdesivir, VV1116 have conducted such kind of clinical trial, but somehow the positive result is not obtained. So it was not approved by the Chinese agency, which is Center for Drug Evaluation. And later they have conducted another RCT trial, and eventually this was approved. But also for Paxlovid, for outpatient or with the population without the high risks, they have conducted this kind of trial in those targeted population, and hopefully they can actually produce the result as the clinical manifesting resolution. However, the positive result is not achieved. So how can we actually have the licensure of such a compound? But for the Paxlovid access, very poor. The price is very high as of now for Paxlovid. As of now, the cost is about 1,700 RMB. The pricing for a lot of average Chinese household families, even in some less developed provinces in China, difficult for us to access to that. So we need to resort to our Chinese developed small molecules to see if it has also got clinical efficacy from this one by utilizing the clinical outcome in combination with dexamethasone. But as we can see, the virulence has been reduced, and then the primary endpoint has become the clinical resolution. But in the end, the endpoint was established as the shortened time to onset as the composite endpoint for evaluation of clinical efficacy. But how can we actually evaluate the SARS-CoV-2 clinical manifestations and symptoms? We know about what we are, but how can we actually achieve that evaluation? We know that out of 14 symptoms, FDA's recommendation is that all the 14 symptoms can be used to evaluate the time to the shortened onset. But from the FDA guidances, it is not clarified as to how can we actually virtually evaluate and investigate the 14 symptoms. So before the phase 3, we were also quite hesitant because it was quite time consuming and costly for the for our compound. When we had the project, we were so careful. We also want to validate the clinical efficacy. So before the loosening of the social distancing policies, we have done some investigations among 2,000 Omicron infected population. So what about the duration of the symptoms? After investigation, starting with the respiratory tract diseases and symptoms, and later we have seen the delayed onset of the respiratory tract symptoms. And after that, out of the 14 symptoms, we have got our focuses, like the dysphagia, as well as myalgia and fatigueness. it's a very common symptoms. If we're going to include that, all the patient in, about over 40% cannot reach the end point of recovery. So eventually we have encompassed 11 symptoms, and as per protocol, these endpoints have been achieved, and this was published on New England. So let's look at the primary endpoint. That is the shortened time to onset by 36 hours for the antiviral efficacy. The differences, LS, least square mean is about a 5.6 log reduction. And for antiviral RSV, we have gone through the difficulties for the SARS-CoV-2 vaccines. As of now, for RSV vaccines, no RCT available. Another dilemma we have been stuck with for the antivirals for RSV. In China, it is also quite advanced. We have this compound, VP 5602, small molecules, phase 3 pediatric completed. It has been filed to CDE, but another trial should be done as according to the request from CDE, but the pace could be quick. The other one is small molecules from Pfizer. I think that in China, we are amongst the leading site to conduct a clinical trial for the sponsor Pfizer. Just a summary, several companies or sponsors have rolled out the RSV antivirals development. For example, we have a Jinshi compound VV6 indicated for SARS-CoV-2 for COVID-19, but now it has been converted to the RSV indication. Some of them are actually under the phase 2 and 3 development. Professor Zhao will talk about the phase 3 pediatric, but it's the findings from the phase 2. So let's look at the whole R&D development roadmap. A lot of difficulties as to how can we actually set the primary endpoint. We have talked about this issue over and over with CDE. Eventually, we can actually use this as the primary endpoint to investigate clinical efficacy of RSV at 48-hour. So we can see that the clinical manifestations have been greatly resolved and great improvement, especially at the age of month 6, a very great improvement in terms of the clinical efficacy endpoint. That's it for my report. Very quickly enough, I have walked you through the antivirus for influenza and, of course, SARS-CoV-2. We have got some difficulties for RSV. There are some difficulties. Of course, only the pediatric have got some findings, but for adult, since 2017, we have got 2 projects. But for the enrollment, since 2017, fewer than 100 for the enrollment subjects. So the most difficulty lies in the patient enrollment. Thank you. Thanks, Dr. Wang Yanming, by representing Dr. Cao's team for the antivirus for influenza RSV, SARS-CoV-2, or the compound development clinical trials updates. They have shared with us a very good picture. We have achieved something. However, for some of the compounds for the clinical trials, they were not conducted very smoothly. I think that for the antiviral development, somehow we need to spark on a longer journey. Congratulate Professor Cao and Professor Yanming's progress. Dr. Cao Bing will present tomorrow. So just keep our eyes upon the updates from the team. Dr. Cao, thank you so much. Dr. Yanming. I want to thank all the speakers and delegates for staying out here till the end. We have another important session, which is roundtable discussion, panel discussion. It's highly hoped that all the panelists will be presented over the podium. We're going to have some conversations with everybody, for example, for clinical management, as well as the countermeasures for the future pandemic. We're going to have some discussions. We should now give the floor to John Tam to chair the panel discussion session. Please, Professor John Tam. Do we actually put on, do we need to arrange more chairs over the podium? Because we might expect more panelists to come up onto the podium.
Sing. Oh. Thank you very much for coming up, and I think now we're planning for the panel, and we had identified 3 subjects that we should discuss in a panel like this. The first one is on improving clinical management and prevention for respiratory infections. So this is a topic I think many of you are clinicians, you are doctors. And of course, there have been a lot of presentations on treatments, antivirals, and all the associated antivirals in development, and effective policy and how to use antivirals and so on. So any of you have a comment to be made about treatment? What do we need in treatment? As all of us working on flu and maybe COVID and RSV, what do we need? What do we want? What do we want to see in the next 2 or 3 years? You have comment, someone? Dave, Lu Zhou?
那我就抛个砖，
Testing. This model
for the community-based respiratory infection. So this could provide information for the early detection and also clinical diagnosis of respiratory infection. In the future, in fact, in China, a lot of online doctor could give consultation and prescription to the antivirus and also the antibiotic to the customer. So I think this is a complementary the detection methodology for the early detection and also clinical management. This is the first, I think the one side. The other is focus on the high-risk people. If the people with high-risk conditions like the chronic disease, if they get the infection, the respiratory pathogens, they should go to the medical facilities for seeking the health care to reduce their risk of the severe outcomes. And in the future, the healthcare workers, I think especially in China, should pay more attention to the prevention, encourage the patients and the publics to get vaccination to prevent the influenza, the COVID, and also the pneumococcal infection. I think this is also the duty of the clinical practice. Thank you.
Thank you. You have raised a couple of very interesting topics that we have not covered. One is association of using rapid testing method in the application of antivirals. There's a lot of discussion everywhere. The other one is promotion of early reporting system so that we stop regular infection to go into more severe infections. So this is two very important topics. Yes, Lance.
So I have one thing to add. It's a little bit different. My perspective is that I was here through the whole pandemic, and so one of the things that's very apparent is that healthcare workers, nurses, doctors, ancillary healthcare workers are so valuable. They're just the mainstay of prevention and control, and so personal protective equipment, making sure that they're vaccinated, that they're early in the group that gets vaccinated, protecting the healthcare workforce is absolutely essential. And I think it's essential for COVID-19. I think it was essential for H1N1, and I think it's going to be essential for disease X as well.
So your comment actually leading to a lot of interesting discussion also is how can we making sure that our medical professionals are maintaining their health during a pandemic at the same time when there's surge in epidemics, surge of demand for hospitalization and so on. How can we maintain that? So there's also a push of vaccination, a lot of push for all these non-pharmaceutical intervention methods. And so it will be very important to address that.
I think that's right, and the degree of stress and burnout and moral distress among healthcare workers is very, very high. And so we need to, just as you say, John, need to pay very close attention to the healthcare workers.
Yes, David.
Look, there are a few practical issues in the delivery of therapies for influenza. There's one, it begins with the perception that it's a very mild disease, and it often is. And if there's an underappreciation of its significance, then there's less impetus for the system to find ways of delivering therapies. The second is you have to give the treatments very early if you're going to get maximum benefit. And that can be difficult to achieve if you're going to have to diagnose it and then get access to the drugs within that very short period of time that you've got to do that. There's an exception, of course, for the more seriously ill. And I think, and then the issue is, because it's specific for influenza, if you don't know it's influenza, then there's this whole discussion about, well, you're treating things that are not influenza, it's costing the system money. Is it economically beneficial to do that? How do you make them accessible? And we know that the uptake overall in the community in most places for oseltamivir for community infections is very low for all those reasons. So I think the issue of, as you said, of access to early diagnostics, which can be difficult to do, who pays for that? And then the early access to the therapies. When you're talking about people who have more severe illness, we then have got the issues of how you deliver that treatment to people with more severe illness. And I think that was discussed in Professor Haidan's talk, and in terms of how you might be delivering better therapies to those who are severely ill. And of course, we'd like antivirals which are maximally effective. And fortunately, so far, resistance has not been a great problem, but that was touched on with the use of baloxavir particularly.
Before baloxavir becomes in the market, which is a bit more expensive, but then the advantage of having only single dose. Based on oseltamivir experience, the recommendation is that not to test, just give antivirals anyway. But nowadays, the baloxavir becomes available and it's expensive. And people think that maybe testing now becomes cost effective in terms of, because for this prescription. At the same time, there's a lot of development of very sensitive and stable, robust testing methods that is rapid.
So
Yeah, so there's still a lot of very active discussion.
Yes.
Yeah, so I'm not a clinician, but I worked in public health for more than 20 years. So I just wanted to have my personal comment about the clinical diagnostics. So when we're talking about the clinical diagnostics, especially for pathogen diagnostics, the purpose for that is for the clinical treatment. So we needed to provide the antiviral drugs to the patients, no problem. But we needed to think about that, the pathogen diagnostics, not only for patient treatment, but also we needed to provide the information for public health. So we needed to move this forward. So my point is that, we can use different methods to detect the pathogens for the prescription, for the antiviral drugs prescription. But we needed to using this method to help the public health. So I think we needed to push forward the genomic, sequencing or genomic sequencing method, not only used for the public health laboratories, but need to move this forward in the clinical laboratories. This is reasonable. I really agree with the presentation today's may resemble the genomic surveillance. So, but when we recall that about 20 years ago, if you talk about genomic-based surveillance, the public health will not, will not agree with that. So, in summary, in short, I would like to comment and to say that for clinical laboratories, we need to combine the diagnosis method, especially genomic sequence method. Not only for the clinical treatment, but for the public health.
Thank you. Diane, you had spent most of your working life as a person who does surveillance, and you do a lot of detections. And also importantly, your part of your work is to look for antiviral resistance. So what do you think, as a person who do all this, how would antiviral treatment and patient management, how would it relate it to your work that you do, like reporting antiviral resistance and so on?
Yeah, thank you. And for antiviral, actually, we really perform antiviral resistance for many years. And as Dr. Wang Yimin just mentioned, that our results also show that the circulating influenza virus were all sensitive to the antivirals, no matter it's NA inhibitor or PA inhibitor. And from my aspect, and this topic is about the clinical treatment, I think even though that even the price of the antivirals is reduced, it's not that the more the better. Yeah, we need to also keep in mind the antiviral resistance mutation. So I think we have to focus on the focus on the high-risk population, for example, older or with basic disease and young children. Yes, and if, for example, we maybe start some study or push some study on the early use or early treatment of early preventive use of this antiviral for this high-risk population, especially when a family has kids. Yeah.
And I think also one of the biggest contributions you can also have is to make rapid or urgent testing of antiviral resistance, especially patients who are immunosuppressed, who are on transplants and so on. Then you have this urgent service say, oh, a virus isolated from this patient. You can tell them are they resistant or they're not resistant, and hopefully be able to help the laboratory work and the clinicians at the bedside put together
and then a good treatment regime.
Yeah.
Yes.
Treat youth.
Yes. Is there, from the audience, is there any comment you want to make on this topic? And just raise your hand. I think they can give you a microphone. I think we've covered quite a bit, so we can move on to the next topic, which is on experience gained from COVID-19 on future respiratory infections. So COVID-19, we all talk about COVID-19, we all learned from COVID-19. A lot of things we talk about in the early days of influenza, control measures and so on, had never really applied in the sense like what we did with COVID-19. So what do you think? Wu
Yeah, the COVID-19 pandemic is over, but what's the next pandemic? I think we cannot predict. But I think we should think about some questions. The first, what kind of surveillance system could detect the next pandemic pathogen? The existing surveillance network, like the influenza and also the comprehensive, the collaborative surveillance system, and all other using the AI, the big data technology to detect the novel pathogen. The second question, I think, is as you call the presentation by Professor Liu Poon. Yes, when the next pandemic occurred, what should we do? What we need to give some preparedness on the scenario-based preparedness, including the NPI, especially for the vaccine and antiviral drugs is not available at the beginning of the pandemic. So we should build the capacity to the modeling to give more understanding on what kind of public health and social measures should take in the early stage of the pandemic. So we need to build the capacity building, the capacity to simulation, so the modeling study, and also to compare with the decision making. I think this is two important questions for the future, and also this is the lessons learned from the COVID-19. Thank you.
Yes, I think yes. With all this experience that we had so far, COVID-19, flu, we're trying to refine our early responses of a possible pandemic to better. But that's only talk, academic talk, and academic exercise and so on. But how are we going to put that into the system is something that we need to do. Yes, Lance.
So one of the major heroes of the pandemic response, I think, was the laboratory. And, you know, the laboratory made an invisible virus visible even in people who were asymptomatic and was absolutely essential in early identification of any outbreak or importation. And so now and the other thing that happened during COVID-19 that was very impressive was the digitalization of vaccines, the digitalization of all of the testing. And so on everybody's cell phone, you could have your last SARS-CoV-2 test, you can have what vaccines you had, when you had them, when the next vaccine is due. And so combined with this emphasis on AI, being able to comb through data, find signals, even evaluate signals, I think the big data platform has so much to offer because it helps to integrate the clinical healthcare system, the public healthcare system, and to make that seamless. I think the point was made earlier today that one of the key things with the system in China is that everybody has a unique health identifier, and then it makes it possible to do studies, set up studies, identify signals very early. So I think the big data platform will be continue to become a major asset in the next pandemic.
Yes. Also, you bring in the important part about communication and public platforms of communication. So there's a lot of, seems like, especially at the peak of COVID, and you have all these negative comments coming out from the media and all of this. So, but this is a system where we have actually check and balances. Now there are some really actively what they call fact-checking algorithms, so that they can use AI to check whether this thing that's been circulating in the internet, is it real? Where's the evidence? It will automatically pull out experiences. Something that's amazing. I was looking at these things. So great. Yes, David.
Yeah, thank you. It's certainly something that's consuming a lot of thought at the moment in terms of how we might detect the next one at an early stage. And I completely agree with the potential to use big data and AI as ways to analyse a whole stack of features that are occurring demographically that are going to give you clues that something unusual is happening or is about to happen. In terms of the detection systems, we've certainly made major advances, both in terms of the rapid tests, which are important, but also in our ability to characterise new potential pathogens very quickly, and that's continuing to improve, and also our ability to look for much a broader range of pathogens, and we're moving more and more into multi-pathogen detection systems in the laboratories, including going into the metatranscriptomics and those sort of approaches, which will slip into the routine system. The gap is that by the time you pick them up in laboratories, it's probably in the community already. We're just saying less we'll find it, we'll characterize it as early as possible. Something else is going to have to tell us that it might be there. The other group I think that is important is the astute clinician, the ones who say, this person has just been somewhere unusual and this doesn't seem right. Picking that patient zero as early as possible, at least you may be able to implement your prevention methods earlier.
Thank you.
Yeah, so so one of the biggest lessons learned from the pandemic is that we could not identify the intermediate host yet. So even we did a lot of work until today. So I think we need to think about globally how to establish kind of surveillance to identify the intermediate host. So that's one point. Another point is that, so we are talking about the integrated surveillance system. For example, we integrated the different pathogens surveillance system. That's good, but how to detect earlier? We believe that when the virus spill over from animal to human, so if we, just as David mentioned, that if we detect the patient in the general population, it's not the only detection. So the only detection is the interface between the animal and the human. So we need to think about another surveillance system is the interface surveillance system. So that's my 2 points. We need to work together globally. How to establish that kind of surveillance system in future. It's definitely is One Health. But we talk a lot about One Health, but how to do that? How to, put into practice this kind of surveillance system, we should consider it.
Yes, talk us into the next question, but One Health is so important. Now, not just avian, now we talk about bovines. Diane.
Okay, I think we have a lot of lessons that we can learn from COVID-19. I think an important one is the collaboration between different sectors and different, for example, also different departments. For example, in one institute, the collaboration between the AP part and the lab part, and this is the example. If they do not have a very routine, smooth collaboration, when something happened, they can't respond very good.
Yes. Diane, I refer an experience that I have. It would be very interesting. We can talk about it. I was giving a talk, I think it was in Washington, D.C., after the 1997 H5N1 cases in Hong Kong. I gave a talk, and someone from the audience stood up and said, "Why is Hong Kong so dirty? You're finding all these new viruses. It's spreading all over the place. Must be a really bad place." So I stood there and say, "No, it's because we are good, because we are able to detect it." That means laboratory system becomes so important for us now. So you'll be able to detect it because your technology developments to a point where you'll be able to find it early. So, and I said, if you have these kind of cases somewhere in Bronx, in Queens or Bronx, would you be able to detect it? Yes, they can, but maybe 1 year later when the specimen being saved. So I said, laboratory system being set up to look at all these things, we have to be good. We have to make it vigilant, make it robust so that we are able to be confident of what we see or what we detect, right? Diane, so you experience with a lot of that. So last thing that we'll lead into is the controlling of avian influenza. That's a huge topic. That's a big one. I think One Health is certainly one. Lu Zhao, what do you think?
That's okay. Yes, for the avian influenza, I think now we should continue to monitor and concern on the avian influenza and other animal influenza. The first, like the global influenza strategy, we should build the capacity on the surveillance and in the future should focus on the better tools, the vaccines, especially on the universal and broad spectrum, the flu vaccines, and to protect the more longer duration and also cross-reaction of different subtype, and also the rapid and accurate testing on the novel influenza virus. So the better tools is always needed for the future for the avian influenza control and pandemic preparedness. The other thing is One Health. You have mentioned the One Health, but this One Health in the future, I think, is a mechanism should be built from the country level, and also in the future is the internship, the interregional, and is a multi-sector collaborative. Dr. Chen Hualan talked this morning. The agriculture sector conduct the vaccination campaign in China. I think it played a key role in the decrease the avian influenza. So in the future, maybe we could think about this strategy and also build more closely collaboration mechanism between the multi-sector. Thank you.
Thank you. Lance?
So I'm not an expert on avian influenza, but one thing to say, I was so impressed with Dr. Chen's talk about vaccinating all of those birds and the impact that it had. No more H7 cases after that, and very few birds that had to be killed, and it was amazing. And then I always thought, like, during the COVID-19 pandemic, I thought 3.5 billion doses of vaccine was really a lot. But then she talked about 300 billion doses of vaccine and the impact. So anyway, I was very impressed with that. And so the other point to make, though, is just that I think one of the key lessons from COVID-19 is that local vaccine manufacturing ability would be very important. I mean, you could really see the unevenness in the world based on either wealth or the possession of vaccine manufacturing. One of the ways to help build vaccine manufacturing capacity for flu and others is to use more seasonal influenza vaccine to really raise that so that there's much more production. But I think local country capacity really needs to be augmented.
That's a very good point. I mean, capacity to build capacity to make vaccines is very, very important. David.
Thank you. Yeah, I won't comment on the avian bits of it in detail, but it's certainly a real issue for us at the moment in terms of monitoring for when this virus, the H5N1 enters into Australia, assuming it will. And I would say One Health to me means two things. It means the transparency of exchange of information between the sectors and also the pooling of capacity and capability across the sectors. And it's knowing soon enough from a human health perspective, as soon as possible, what's happening in the animal health sector, and then being able to act upon that. What we then had to think about is how, if we're concerned, if it gets into the animal health sector, do we know it's entering into the human population? So it's then setting up where you think the gateways are for that transmission to occur and how you're going to monitor those. Certainly, we've already looked at how we have our capacity to detect the new strains, intensifying our testing and characterization of flu viruses that are coming through, concentrating on patients who are being hospitalized or people who are recently returned, identifying people who may have had contact with animals. Easy to say, not so difficult to do in a system where it doesn't normally do those things. But they're the sort of processes to have in place for testing, which as the threat becomes more apparent, if it does, then you can begin to roll those things out and get more compliance as it becomes a more real risk to humans. But I do think a lot of it at this stage is for the animal health sector.
And also public health policy to assist in terms of stopping avian influenza or animal influenza transmitted to man. One very good example here in China is actually closing of live market. That really had an impact on stopping transmission and also together with vaccinations.
Yeah, so definitely avian influenza poses a pandemic potential. So for short-term goals, we need to enhance the surveillance. I mean, to develop the rapid test assays, antiviral drugs. But I think the long-term goals, we need to promote the broad protective vaccine development just presented by Evan this afternoon. So I think from the surveillance to the broad or universal vaccine, this is the right way for future pandemic.
Well, what to do for avian influenza? I think if you even you ask some AI APP, they can give you very standard answer because it was already discussed for many years and for a lot of from a lot of aspects. So I don't think I answer routinely for this aspect already discussed. I think the most question people want to ask now is that if current widespread H5N1 will be cause a pandemic, if the risk of this H5N1 increased to human. I think this is the question we need to answer now, but I think the answer is that current H5N1, not only H5N1, also some other subtypes of influenza, even influenza virus, they can't cause pandemic now because of their property based on their biological characterization. So what we need to do is still to enhance surveillance. Okay.
Thank you. Nance, you have a final comment? You have microphone.
No, not necessarily, other than I liked what I think WHO did a very nice job throughout the pandemic, and one of the things that they started with was solidarity as the watchword, and I think is very important, and it just the importance of international collaboration and exchanges, and I think is really critical.
And communication, fast communication and accurate communication becomes important. Well, with that, thank you very much, panelists. And I think we can say today we had a very fruitful discussion and all the presentations from the speakers. And tomorrow at 9 o'clock, we're going to have a separate parallel sessions. Where would they be? Would they be downstairs, different places? No. Tomorrow. Downstairs. Yeah. There's a program book is out there. Yes. And we'll have dinner now. It's on same place, second floor, one floor down, right? Thank you very much.
Depend on you. We all rely on you.